Okay, I think it's time to start. Thank you for all of you coming. Thibaut, come with me. Just to tell you, it's a great pleasure for us to have you this year. As you know, because you know, it's the 25th anniversary. So it's going to be a big thing, not only in otology, but on social program. There's a lot of good wine. So you remember that. That's the good point. Not now, later on, but it's going to be okay. So we're going to start with live surgery after John's presentation. First thing, because I don't want to forget that. Don't use this system of Wi-Fi because we need to reload something. So it will be becoming more easier this morning. I'll let you know anyway. So we're going to start after John by 2 live surgery simultaneous. I would do, in fact, the first one would be a revision Stapes operation. The primary operation I switched for the second case. So if you see the program, I'm starting by the revision and I do the primary later. And Thibaut is specialized in our clinic for cornicotitis surgery and middle implant, active implant and passive implant too, of course, but he has great experience with all these middle implants, and so he will demonstrate two implants, especially with the Sentio, and the Sentio is the new one, and the bone bridge. So a few things also that I need to tell you. As you know, there is a social program tonight, which will be close to the clinic, so it's a walking distance, so it's only 10 minutes walk, even less. I'm not sure you will be able to go back to your hotel before, because you can see the scientific program is really full, so we'll see. But anyway, it's very casual, and it's very hot also, so you don't need to change. It's fine. And I think I've said everything which is important. Maybe something I missed, but anyway, we'll see in the future. Again, it's a pleasure for us. You will see the atmosphere of the course. I know that some of you have been there before, but the atmosphere is very nice. It's a friendship atmosphere. What the idea is that of course, we show our technique that we make. We do that at the Causse clinic. But it's the idea, the concept is not to show you only what we are doing. Although the French usually say that they do the right one, but sometimes we change. So, in fact, we show what we do, but we share things. And we learn, Thibaut and myself, from all the faculty, and also we learn from you. So it is important for you to be interactive. That's important for us, because that's the aim of the course also, to have this type of spirit, freedom. And you can, in this very difficult world, I think this is a place where you have some freedom yet, so please use it. So thanks very much again for coming, and we really hope that you will enjoy. I didn't show Wilco. Can you stand up, Wilco? Wilco is also part of the team of the clinic. And I don't know why you applaud this guy. You didn't applaud me. And so anyway, so thank you for coming again. Enjoy the 2.5 days. And please come tonight, because it's going to be very special. All right. See you later. Bye-bye.
You have to use this one. Not good for somebody who moves around. Okay, we're ready. Let's have a quick show of hands. Who's a trainee? Come on, quick. A few trainees. Somebody in the first 5 years. Old farts. That means old people. Okay, this is an interactive meeting. If you think what you're being told is untrue, you put your hand up and you challenge us, all right? It's much more fun if we do it that way. So I've been standing here for 25 years. It's 26 actually, because we had a pre-meeting before, and realised that I've made lots of mistakes. Meeting Robert was probably one of the worst ones. So the aim today is to thank Robert and wake you all up and tell a story, warn you about the French and the Dutch, try and help you avoiding the mistakes I've made, and detail the technique you are about to see. Actually, because he's changed the cases, you'll have to try and remember this for the second case. So the French are good at telling a story.
dans un camion de livraison. Et puis j'atterris ici. Oh, c'est incroyable. Hein? T'entends ça, chérie?
Ben oui, c'est fou.
Now, I can tell you the British know a bit about lovemaking. Sorry. Oh, it's a good start. Very important slide.
Oh, wait.
What?
I don't think we should do this yet.
Why?
I feel uncomfortable. I mean, this is my mum and dad's car.
Yeah, so what?
It just feels funny doing it in their back seat, that's all.
All right.
I'm sorry.
All right, love, you can't blame me for trying.
Okay, so our story starts in June 1955. Does anybody know why that's an incredibly important date? Come on, guess? It's my birthday. Right, and that was within a year of John Shea, who's the father of modern Stapes surgery. And what we're going to talk about is basically what John Shea did and how little we've managed to improve on what he did. This is rather a poor quality video. It was made by Dan Treese of the Treese Medical Company, which became Zomed Treese, which became Zomed Medtronic, which is now Medtronic. So Shea pioneered the surgery in '56. That was the first modern stapedectomy, and he changed very rapidly to stapedotomy. That's John Shea on the left, and he introduced the first prosthesis. And this is Dan Treese with a smart haircut. He was the engineer. And they met on a Friday, and John Shea said, I want a prosthesis on the Monday, and they made him one over the weekend. No Food and Drug Administration, just stick it in and see what happens.
A clinic, which was only a few blocks away. He had chanced in to see if we could help him with this special project.
Just listen very carefully.
Our meeting would later result in many a technological advance. The next prosthesis was made of polyethylene tubing. After preparing the vein graft,
Vein
he
graft?
would use a sharp knife to cut one end of the tube into a long bevel. Sometimes, for better purchase on the distal end of the incus, he would notch the end of the tubing. With the vein graft over the oval window, he would rest the pointed end of the implant on the vein graft and snug the square end of the implant over the lenticular process of the incus.
So that was the first bucket handle prosthesis. You heard the word vein graft, a synthetic replacement strut, and a bucket handle prosthesis. What's changed? Nothing. Now, I first came down here in 1997 and watched a young surgeon, Robert von Sant, who'd done about 100 cases, and like a lot of the trainees and some of the younger specialists here, I thought I was going to change the world and be the world's greatest otologist. And I watched Robert and I thought, yeah, he's okay, but yeah, I can match that. I came back 2 years later when he had done 1,000 and thought, actually, he's bloody good. And decided that the best way to learn wasn't to make all the mistakes myself, but to watch him, because it was much more likely he would find out what worked and what didn't work than me slogging away in the good old NHS. So he's very famous for his gardening exploits, but never go to a meeting with a friend who's got the camera, because as we all know, they all have tricks that make them a bit better than anybody else, and this is a typical Frenchman in Beverly Hills. And very shortly, really, after he started, only a few years, he wrote this paper that we were involved in with 3,000 Stapedotomies. That's a huge number. People who say they've done 10 or 20,000, people who say they've done 10 or 20,000 are probably not telling the truth. So there's a guy called Matthew Young in the UK, and he said, let's do a learning curve in Stapes surgery, because Gordon Hughes had already done one, and Gordon pointed out all the mistakes. Gordon was very brave, because these were his first 100 Stapeses. Anywhere below the line was a failure or dead ear. Anywhere above it was a success. Any of you do Stapes surgery now and get those results, they won't be letting you continue to do Stapes surgery. So, and that was in the medical legal situation in America at the time, which is not as bad as it is now. So Matthew and I went and repeated this exercise, and surprisingly Matthew was fellowship trained and I was self-taught, but we both did round about 100 Stapes, and it took us 10 years to build up the initial practice. Now, anywhere where you see this, it's called a Cusum graph, anywhere where you see this graph going down is a successful operation with closure to within 10 dB. Anywhere where it goes up is a failure, which means either we didn't get the closure or it's a dead ear or something else happened. So you can see that it takes around about 65 to 70 cases. And this seems to be the case with thyroid surgery and bowel surgery and everything else. You need to do that sort of number before you start getting quite good. So, this is the little acronym, SPIT, and these are the things that are most important to get your Stapes surgery right. You're not ever going to get 5% better than anybody else, but you might tinker around the edges and just get a little bit better. And getting each of these right, you say, well, I haven't quite got the patient selected right, but we'll get a good result. You won't. Start off with the right selection. You know, I'm not in a comfortable position, but I can cope. I'm an otologist. Don't get in a comfortable position. These are really important things to think of when you're in the OR. This is probably a reasonable patient to start with, although I would suggest that a bilateral conductive hearing loss is better, because any improvement at all, the patient will be pleased. If you use a unilateral, you've got to get a perfect result before they're pleased. This is the result before and after. And what you want to look at when you're assessing somebody else's results is the inner ear around 4K and above. If they're good, they won't have lost any of that higher hearing. And you want a pretty good speech audiogram as well. I would say above 65%. And so here's the result in that one. This is quite a good result. Okay, so at the table you want to get really comfortable. That means you get comfortable, the patient gets comfortable. And some people strap them on the table. This is how they do it in Ireland. You have to read it to understand. Here, unknown to you down in the clinic, horrible things are going on. It's a bit like the Spanish Inquisition. And Robert's patients are being strapped to the table as we speak. So you can move the table around without any danger of anybody falling off. This is the system that was in Burton-on-Trent that Sarcourtaquet and Nina Mystery in the audience will remember. This table was made sometime around the turn of the last century and was condemned, but I forced them while I was still working to keep the table. This board here is a pregnancy board, and that means patients can't fall off. They've scrapped it. As soon as I retired, they scrapped it. And here's me on the table, no straps at all, looking slightly pregnant. That's 12.5 degrees head down, which works very well. But I'm not sliding off. Anaesthetists and nurses are paranoid about you sliding off the table. In my experience, it doesn't happen. And here we are, look at the tilt on there. That's a 14, 15 degree tilt. And what it's done is it's made my ear horizontal. Because what we're trying to do with the surgery is if the ear's horizontal, the prosthesis is vertical. The prosthesis is vertical, it won't fall either way, or is less likely to fall either way when you're fiddling around with it in the middle ear. And it works for ossiculoplasty as well. Losing a bit of hair, but that was 10 years ago, so I've probably lost a bit more now. And there's the table rolled. Now, that's a Yashagil or similar retractor. This is one that was made by Medtronic, and then we reproduced it. And you can see on the right-hand side, it's horizontal. And that's quite important when you see the position we sit in. These are the two different types of retractor that you'll see. The original Yashagil on the right, he's now 100 years old, still alive, great engineer, great surgeon. And that's the one that Medtronic produced on the left. And that gives you a stable platform. But there is a difference between the two of them. And the problem is, if you're a little bit compromised in the abdominal department, like some of us are, and you're sitting by the table, this one sticks in your gut, and every time you breathe, the patient moves. This one doesn't, and the patient stays still. So little things like this make a big difference. So get comfortable and give yourself room to work. As Robert and I and other people here use a ceiling-mounted microscope, and unusually we have the optic axis at 90 degrees. And you have to get used to this, because when you first look down it and start using the instruments, you don't know where they are. The nurse has to position the instruments. The nurse has to position the instruments for you. So here we are, it's one of my trainees, sitting, looking at 90 degrees. They get used to it very quickly. And back straight, hands in a comfortable position, and that makes a big difference. Illumination, all our surgery is done trans-canal. I asked Chris Aldrin, who he's probably stuck in Rome at the moment, because he's had to detour to get here from London. And he told me in the 13 or 1400 Stapes he's done, he's only had to do an endoral slit once. And we think down to 3 millimeters you can do it. This is the same amount of light, and I was talking to Manohar last night about the formula that governs light down a tube, and neither of us know, but you can see that if you can get a 6 millimeter speculum in, you get a much better lighting than with a 5 millimeter speculum. Minimize bleeding. This is an ossiculoplasty and mastoid surgery. Before you say it took him a long time. And we, for ASA grade 1, that's American Society of Anaesthetists, 1 and 2, we will take the systolic blood pressure down to the resting diastolic. Below that, you lose cerebral autoregulation, and you can have problems with the patient waking up properly. But look at this fantastic anaesthetist here. And that blood pressure that he's given me over nearly a 2-hour period. Really very, very lucky to have worked with the same anaesthetist for my entire career, and he did 86 or 87% all my cases, like a sort of husband and wife relationship. And we use a laryngeal mask for all our surgery. There's no coughing at the end of the operation, and despite what people say, there's no aspiration or anything if you work with an anaesthetist who's used to using it. The other important thing is the instruments that you choose. And here are straight needles. And look at the difference if you use an angled needle. Again, it's all about access and what you can see. My life changed when we got a KTP laser. Expensive fibers, but not that expensive. Moved on to the OmniGuide laser, which is a CO2 laser, which Wilco knows a lot about lasers and will tell you is the best laser, but the fibers are very expensive. And a good sharp knife, and this on the right hand side is a joint knife, but we're going to modify that a little bit. This is a beaver blade stolen from the ophthalmologist and bent, and this cuts the skin of the ear canal absolutely beautifully. And you just bend it with a forceps. And I don't know about the rest of you, but you come to do a Stapes operation and you find that the joint knife won't go all the way through the joint. So you go and steal one of these MVR keratotomy knives from the eye theatre, and you use the box section on your microforceps to bend it. This is probably one of the most useful tips. And it's about 0.5 millimeter longer than the commercially available knives, and it's got a diamond edge, and it cuts through the joint like a knife through butter. Prepare the vein graft, dorsum of the hand in 99% of cases. Peel off the perivenous tissue with a knife. It's like taking off a piece of toilet roll. And that gives you a nice piece of vein, which you can then split. You'll see Robert doing it. And you place it sticky side down on a plate, preferably glass, so it doesn't stick. And the sticky side's the outside, otherwise the blood would obviously stick in the vein. When the time comes that you've opened the ear, there's certain things that you need to be able to see to get a good result or to make life easy for yourself. You need to see about half the incus, the facial nerve, and the posterior crust there, and the tendon. If you don't leave enough space in this area, and you're somebody that believes in crimping, you will not be able to crimp at the end of the operation. How do you find the joint? This is the only thing I've ever managed to teach Robert. It's a synovial joint, and because of that, you get negative pressure when you lift the incus, and you see the joint suck in. You see the joint suck in. It's always further down than you think. So here we are again. Steadying the incus with the sucker, giving it a bit more of a prod just to make sure. We've already established that the joint is lower down. And there we go. Cutting through it. And if the knife moves suddenly, you're steadying the incus with the sucker so it doesn't have any disastrous effect. And now we move on to assess mobility. You can only assess mobility if you have separated that joint. And it's important to look at lateral flex of the stapes and vertical fixation. You'll see the needle go onto the top. And you do both. And one of the commonest causes of being sent revisions is somebody elsewhere has said they can't make their mind up whether it's otosclerosis or not, and they didn't separate the joint. I use the laser to separate the tendon. Robert uses nice little scissors. That's the subiculum down there, and it's just getting in the way a bit, so we vaporize that and pick the little bits of carbon out of the way. And now we're going to have a go at the posterior cross, just to thin it. Hopefully, there we go. 1 watt, 0.2 of a second. I tend to use that on the cross and the foot plate, or I used to tend to use that. I don't do it anymore. And we're going to pick that maybe with a needle, or my favorite drill, which is the B&R drill. The Zoma Medtronic drill is good, but it's not as good as it was before they had the reusable. Yeah, the B&R is the osteostat. Yeah. So certainly I like that. And then the foot plate, we form what's called a rosette. 5 or 6 little blasts on the foot plate. Just 0.2 of a second again. And once you've done that rosette, you literally complete the stapedotomy almost like the drill acts almost like a fan. It doesn't cut anything. It just blows carbon out of the way. I don't know whether we'll see the drilling here. We might do. This movement you see is my eyelashes touching the eyepieces. So even though it's a ceiling-mounted microscope, there's a little bit of movement. Okay, so nice stapedotomy, probably 0.7, 0.8 of a millimetre. And we're now going to place the piece of vein that we did earlier on it. But first we're going to measure to the surface of the perilymph, because that's the length we want. And measuring to the surface of the foot plate before doing the stapedotomy may be shorter. These are the 2 prostheses that you will see most commonly used. There's the Causse large and small loop at the top. That's a large loop. And at the bottom is a Robinson Teflon bucket handle, which I quite favour actually. I quite like that. We cut that to length. This technique doesn't add any extra to the length. You don't put an extra 0.25 on to make sure it's in the hole. You know it's in the hole, and I'll show you why in a minute. Vein into position. We can argue about whether a vein makes a difference or not later. Wilco will have quite strong views on that, I hope. No. And then we're going to pop the prosthesis in. So we do a bucket handle. Harder to put a bucket handle in than a loop prosthesis. It's a bit like patting your head and rubbing your tummy at the same time. You need to lift up the incus to drop it into the hole at the top. I think, certainly in my series, that there's less incus necrosis with this prosthesis. And I used it about 30% of the time. The handle itself is irrelevant. It stays in place without the handle. So there we are. Stretch the vein. If the prosthesis is too long, the vein will be like an umbrella, and you could potentially get a perilymph leak. So this tells you whether your prosthesis is the right length, along with what we call the bending sign. This is supposed to indicate the reflex. I don't know whether it'll show it. It's not terribly clear. Believe me, there was a reflex there anyway. And we move on. This is if you're using a larger loop. And the only thing to notice here is that the open end of the loop is facing towards the attic. If you do that, when you come to rotate the prosthesis, it won't catch on the lenticular process. It's much easier. If you face it the other way, towards the promontory and the lenticular process, it can be quite difficult to get it over the incus. And it's really a turning moment. You're not pressing, you're pulling and pressing at the same time. Robert will put it straight in. He used a slightly different technique, which is quite impressive. And then he will close it with 2 needles. Don't try doing that. You're better to use a crimper until you get as good as him. And there's the prosthesis in position. We've got another 4 minutes, so we're getting towards the end. And this is, if you haven't removed enough of that bone that we talked about from the scrotum, you can't get the crimper in there. Okay, so my series, which finished in 2020 at the beginning of COVID, and a little bit difficult to work out exactly what happened, but we had sensorineural hearing loss in 0.7%, and of those there were definitely 5 dead ears out of the 1397, which is 0.35%, but there were 3 dead ears due to either infection or the patient-inflicted trauma, and 2 patients were seen with Q-tips in those 25 years, and we think that's what caused the problem. Well, that's my excuse anyway.
I will say this. This is a time for healing. A time to stress what we agree
The British Foreign
not
Minister.
what we disagree about. We should be looking for the good in our opponents, not always be looking for the faults. There's good in everyone, you know, Lily. Except the French. Even the French.
Okay, thank you very much. You okay? Go next then. Right, okay. Questions, yeah. Yeah, of course you can. Do you want to take the microphone? Sorry, we normally have microphones around our necks.
John, thank you very much for the presentation. It's good to see it for the first time, but I think we all do. Very interesting. I think there are many variables, and I'll talk a little bit about that too. I wonder, does anybody do vein graft interposition, or does anybody just make a hole and put the piston in and go to his lunch break? Who does vein graft? Who doesn't? Who doesn't do Stapes? Okay. Exactly. I mean, I'm from the Netherlands. I did all my life no vein graft. I did a lot of endural incision. And I think the major, now we do, as we all do here, transcanal. And I think transcanal is very nice, elegant. The patient will be happy because it's less painful afterwards. I mean, endural is pain, I suppose. But I noticed I would not have been able to do it on that scale in the Netherlands, because in a university center, you don't get the table that the ENT likes, you get the table that the other surgeons like. So you never have a table that allows you to maneuver the head down, the position, etc. And here in the table, So I think I would very much advise you to try transcanal surgery. It took me maybe to really get comfortable, maybe a year working here, but it's only doable if you can maneuver the patient very much. If I do endural, I can keep the microscope in one position and I can see everything. With transcanal, you need to maneuver your patient if you want to see everything. So you need more flexibility of the patient. And on an academic surgical table, I was never able to achieve that.
Let's throw that one away now. They rang me and they said he's retired. The table's been thrown away. Because it won't take more than 20 stones, which is, I don't know, 140 kilograms. Absolute rubbish. It would have taken 300 kilograms. Yes?
Sorry, you said you didn't use vein grafts before, and now you do. What?
Because we all want to do the same procedure. The clinic's well known for the procedure, and I think the results here are incredible. But I need to tell you, the patients here stay 7 days. They get pampered, they can eat out, and they eat here at the cafeteria, they get ear protection. It's an whole thing, but I must say the results are better. In an environment where price is everything, I've done them in daycare and they go away, etc. But the results are not the same, and so patients do have more vertigo, in my experience, without the vein graft. I can't say there was a huge difference in dead ears or so, but there's definitely a little bit more vertigo afterwards. But then again, I mean, here I don't have to say anything. With my limited French, they give me the right instruments all the time. I mean, even if I ask something else, they give me the right instrument. Because, I mean, the team is so drilled, and it's always the same team. In university, you would have a new nurse, never done anything. Oh, is this ear surgery? Okay. And, I mean, you can't achieve the same level of quality if it's not fully dedicated. Of course, ear surgery in a university center will never be dedicated, because they do open heart surgery, they do other things, which makes more money, etc. Cochlear implant maybe, but that's not Stapes. But the team here, it's so automated. It's, I mean, fantastic.
The results haven't improved much since John Shea. What we're talking about is tinkering around the edges. No, nothing we do is going to produce a step change. But, you know, getting your own theatre with the same theatre sister all the time, with the same microscope, with the same team, with the same instruments, all these little things improve by fractions of a %. Nobody can prove that a vein graft's any better, but for somebody who's more interested in engineering than medicine nowadays, it makes sense to me to have a seal. But Wilco can tell us about the statistics later on. Do be controversial and say this is wrong.
You have a question, Javier?
Question.
Okay. Last question, because we need to go to the patient. Okay.
John, I've had 3 delayed facial nerve palsies, one due to Ramsay Hunt. And I've been using the laser, and I wonder if you've had complications because of the laser. I mean, they've all recovered.
What laser are you using?
KTP.
KTP's great laser. I've had I've had 2 complications, and these are the truth. One was when the nurse tripped over the shutter release, because you know there's a shutter that comes for the laser, and the patient woke up with a facial palsy. And it lasted 6 months. And she got better, complete facial movements, although the neurophysiologist had told me it was the end and the facial palsy was permanent. Second one, we don't know. Both KTP, 1,300 cases.
Otherwise, relay your question for after. Robert, bonjour. Robert, can you hear us? Céline, bonjour. We don't hear any sound yet. Before we had sound.
Ça marche pas, hein?
Oui, maintenant oui.
Ah, okay. I was wondering regarding John talk. Is it
It's new.
British? Is it British 20 minutes or South of France 20 minutes? Or I don't know. I don't know.
Okay, no.
Okay. All right. So we're going to start with the surgery. So I think it is, first of all, I'd like to present my team with Céline, my nurse, and Dr. Dupuis, who is the anesthetist here. And one of the important thing is that Dr. Dupuis is there and preparing everything. And one of the important thing is that we try to use hypotension. So this is important for us. So I think it is interesting to show you the way of taking the vein graft. As you know, I'm always using a vein graft interposition, even following revision surgery, of course. So I do a very small incision. This is the right hand, of course. And I will dissect now the skin and try to get the vein. So the aim of this vein graft deposition is to seal the labyrinth. For me, it doesn't make any difference with or without interposition in terms of hearing outcomes. I think it's the same. But the main aim of this technique is to decrease the risk of postoperative dizziness. And you know, I have the fact that I'm keeping my patient for 6 days in the clinic, which is a good point because I can follow the evolution of the postoperative short follow-up. And it's extremely rare, really extremely rare, that we have any dizziness postoperatively. And I believe it's related to the vein graft deposition. So I've already done this technique since I'm entering the Causse clinic. And if we talk about that, or maybe we have time to talk about that later, but you can also use perichondrium or fascia, but both tissues compared to vein graft are really thicker and not as nice in terms of flexibility and thinness. It's very thin material which fits very nicely to the oval window. And of course, the difference also is related to the size of the prosthesis between the two options of with or without stapedotomy, because I'm using stapedotomy. My stapedotomy is 0.8 millimeter, and I use a vein graft, so I use a 0.4 millimeter diameter Teflon shaft, which I think if you are not using any interposition, most of the surgeons would use 0.6 millimeter with a 0.8 stapedotomy. All right. So you can see it's a very small stitch and a very small incision with only one stitch, and that's it. Okay, table en avant. So this is the, we can maybe show the position of the patient for 1 minute. Il faudrait montrer la position du patient. So you can see I think it is important to show you this. The patient is horizontal, and I am perpendicular to the patient. You can see the ear right here, and we have a speculum holder. This is a very nice tool. I'm sure we have time to discuss this point. So this is the speculum holder with several joints, and there is a plate which is placed underneath the head of a patient to hold this speculum holder. And I use transcalar approach. So you really need endoscopy. You need
What are you saying? You've been drinking.
I was thinking about that because it's the same approach. In fact, you know, we have a very famous endoscopic surgeon here in this course, and they use the same approach of minimally invasive surgical approach. So yes, speculum. I wanted to say speculum and not endoscopy. So now we need to prepare the vein graft, to pre-shape the vein graft. And so it means that I need to remove some perivenous connective tissue from the lateral side of the vein, which is the sticky side of the center.
Microscope?
Yes.
Hold on, Robert, we don't see the microscope yet. Le micro? Oui.
C'est bon?
Oui.
Okay, so I'm trying to grab this vein graft, which is a very thin one. And so I will pass this instrument through the vein like this to hold it. Doesn't want to go. There we go. So now we are facing the lateral side of the vein. And so I will remove some perivenous connective tissue, which is, I think, important because if it's too thick, it's not good. And sometimes when I have a really thick vein graft, which can happen sometimes, it's not the case here. It's a very nice one. Then I put it on the press to make it really thin. So that's it. And now we're going to open the vein, cut the vein transversally, and shape it.
It seems very strange to emphasize the thickness of the vein graft, but it makes a lot of difference. If it's too thick, the surgery becomes very difficult.
Yes, exactly. So I'm opening it. So still at the moment we are looking the lateral side of the vein, which is the sticky side, which will go to the foot plate. Now I'm cutting the vein transversely like this. And by opening the vein, I'm now exposing the intima of the vein. So I put the vein over this plaque. You can see the plaque with a hole in the middle of the plaque. And this is a nice way to pre-shape the vein. C'est très chaud dans le bloc encore, hein? C'est dingue. So this is a little bit too big, so I will keep it like this. And I will explain a little bit about, talk about, a little bit about the case. But that was interesting to show you. So now I will push the vein down to the hole, so the part around will stay wet, while the external part will dry a little bit. And that's a nice way to take back the vein into the middle ear. Tête en déclif, s'il vous plaît. So this is a female patient. Well, I operated on her many years ago, and she had good initial results for many years, something like 8 or 9 years. And then after her head trauma, she experienced a recurrent hearing loss on the right side. And so, of course, we decide for the CT scan seems to show prosthesis dislocation, which can happen, of course. But, you know, long-term failure like this is, in my experience, I'm sure Joachim will talk about that, but with my experience, that long-term failure without head trauma is more related to incus erosion. And it is possible that there was a slight progression of...
You're now injecting something, John?
Yeah. I'm injecting adrenaline xylocaine. So at 12 and now 6 o'clock, because the right ear.
Robert,
so it is possible that we have an eroded incus at the same
Robert,
time.
just tell the audience what size is the speculum you're using.
Oh, yeah, we start with a very small one, and then I'm increasing now. I will start something like 3.54, and I'm now increasing the size until I found the right one. Which means that I will have some compression to the skin. So like this, so I don't know. On est à quel diamètre là? So 6.5, ça c'est 6,5 ça. Now 7. Larron, s'il vous plaît. So you see now I have some trouble to introduce the speculum, so I will push the skin a little bit. C'est un 7 ça, c'est ça? But it seems to be a little bit too large. Non, le plus petit alors. Because sometimes you have to push a little bit there, and then it works. Larron. C'est bizarre que je ne puisse pas mettre le... Redonnez-le-moi encore, parce que quand même... ouais. I'll try with a 7, because it feels very strange not to be able to place it. Larron. I would prefer this one, but I have some trouble to introduce. Because the other one is a little bit too small, but this doesn't fit very well. Okay, I think it's going to be fine. Right, okay, good. Now, you see I can fix the speculum with the speculum holder.
Can we see the, yeah.
Okay, so we have the platform here, with which is fixing the speculum like this. And this is the first joint that I fixed like this, and the second one, and the third one. And now it's stable, and I can use this as a platform to stabilize my fingers and introducing the micro instrument. So we have a nice view of the tympanic membrane. Now, we like to prepare with betadine, there and there. And now cleaning it. And now we're going to start. So we have, just to explain, this is right here. So this is 12 o'clock, 3 o'clock, 6, and 9. So the aim is to make an incision running from 6 to 12, elevating the posterior half of the tympanomeatal flap, and then checking what's going on in the middle ear. So I'm using this round knife to make this incision. I take care of the skin because it's a very scared skin. You can see that, very thin. So I do it in different steps because otherwise there's a risk of making a big tear. And now, now I'm using a smooth elevator to elevate the posterior half of the flap like this.
These are very
Trying-
nice instruments, eh? Especially
Yeah,
microphones.
very
or
fine.
who makes
Yes,
them?
it was Microfrance at the beginning, and now it's called. Comment s'appelle la société Intra déjà? Comment c'est le nom? Integra. Integra is the name of the company now. It's a French company. They bought it. Then, you know, originally it was Microfrance, which was bought by Xomed, Medtronic, and then bought again by Integra. So you see I'm taking care of this skin, which is really in bad condition. Okay, and you see I'm following the horizontal line until I can see now the annulus all around. This is the annulus. And I'm going to open up the middle ear cleft, but first I want to expose the annulus all around. And of course I will try to expose the over window and especially the facial nerve and the pyramidal process. So this is the chorda tympani, very thin chorda tympani. So the problem is to preserve a chorda tympani in such a presentation, because it's not like primary surgery. It's connected to the skin, so I'm not sure I can preserve it, but we'll see. All right, so we go to the right. Décolleur encore. And I will try to elevate the right part of the flap. You can see that I'm taking care of the whole step here. I'm not opening the middle ear cleft yet, because I want to be sure that I can try to preserve the chorda tympani. You see the annulus is there. There we go. Décolleur. So you see there's a little bit of a tear of the skin, not of the tympanic membrane, but the skin here. So this is why I'm going in the inferior angle. And now I will elevate the flap. Okay, so let me see how I can deal with this.
It's quite bulky, yeah?
Yeah, and the chorda tympani is right in the middle of the field, and that's not a problem, but it's connected to the tympanic membrane. So you can see, I don't think I can preserve it. It's going to be difficult. Anyway, so this you can see the prosthesis dislocated,
yeah.
but there's no incus erosion, unfortunately. That would have been nice to show you. Oh, there is an incus erosion. Oh, that's good. That was, I think, I thought that. No, it's good, because I mean, it's interesting to show another technique rather than incus to stapedotomy procedure. And that was, I think, I was thinking of this point, because, you know, head trauma could be, of course, a cause of prosthesis dislocation. But by experience, I know that when the prosthesis is definitely connected, I mean, strongly connected, then even a head trauma usually cannot dislocate the prosthesis. Well, I mean, cannot is not true, but it's very rare.
Robert, the CT scan, did it say something about the dislodged prosthesis from the oval
Yeah,
window?
it shows the dislocation of a prosthesis.
Okay.
Yeah, it is. And then, but it doesn't show, of course, it didn't show this
the erosion.
incus erosion. So there's no way I can do something with this chorda tympani. It's right in the middle of the field, and I don't think I can preserve it. Anyway, okay, so I will first remove the prosthesis. So I'm intending to perform, of course, the Malleus to Stapedotomy procedure with a torp. Les ciseaux, s'il vous plaît. Trying to cut this fibrous tissue here.
Robert?
Yeah.
Good morning. It's Neil.
Hi, Neil.
Is there a length of the incus that you might consider still using, you know, before going to the malleus? If there's
not
just
really.
mild erosion, slight erosion.
You know, what I could see is that it's when I have a very limited erosion, of course I can use again a prosthesis, a Stapes prosthesis, a piston, I mean, ciseaux. But in the vast majority of cases, the erosion is there, and I think it's better to remove it. But it really depends on the size of the residual.
With an erosion like this...
Here you cannot.
Yeah, no. Robert, just a question, because I'm sure you used a vein graft in this procedure.
Yeah.
Can you see the vein graft, or is this?
Yeah, yeah. I show you in a second.
Okay.
Yeah. First, I want to relocate the malleus, because I'm going to use a malleus to stapedotomy procedure, and you see that we have, as usual, a really anterior malleus. Okay, you see the malleus going there. This is again the quarter tympani. Okay, let me see.
You may be able to get it free.
Not so easy. You see, I will try. I
Well,
will try.
it doesn't need to be easy, does it?
Ciseaux. Yes, that's right. Okay. I remind you that we are in France and not in the UK, so we need to take care of the quarter tympani for the food. All right, good. It's fine. So, no, it's not true. Now they make good cuisine since they learned from the French people, so that's, you know that. So,
Robert, just to get clear, can you
Canal.
show us all the landmarks, the facial nerve and maybe
sure,
the
sorry
round
about
window?
that. Yeah, sure. So if I go back to the exposure, we have... Quel est normal, s'il vous plaît? Bon, table vers moi alors. Oh, I move the table a little bit to show you this. Stop. So what we have here is a nice exposure with the fallopian canal here on the left.
Yeah.
The round window niche here.
Oh, your hand was in between. Can you show us the round
Here.
window? Yeah, your hand is there.
Okay.
Cut off your hand. Yeah.
I can't remove my hand.
Okay. Well. Okay.
Here's the
yeah,
round window.
And we can
okay?
see an indication. Yeah. Yeah.
All right. Okay.
Promontory. Yeah. Very vascular promontory. Yeah.
Yes. And you see, we can see the vein graft here. The previous vein graft is still there, and this is a very nice thing. You can see it's still connected to the full plate after so many years, and still alive, flexible.
Yeah.
Okay? And this is the previous stapedotomy. So of course I will...
Robert, just to say, I guess if there wasn't a vein graft there, and the prosthesis had come out, maybe there would have been a perilymph leak. I don't know. What do you think? Bob's saying bullshit.
Maybe. Not sure. Because usually there is a perilymphatic membrane that is going back. So even without vein graft, it works. But it's clear that now if I'm using a TORP, then if you use a total prosthesis, then you need to interpose something. Otherwise, there is a risk of protrusion in the labyrinth. So that's definitely
Robert,
clear.
it's Rob Briggs here.
Yeah.
My approach is not to use a vein graft for standard stapedotomy. And for the revisions, there's always regrowth of the endosteum. And there's a membrane, of course, that replaces it. I'm very interested, however, in the TORP situation where you're using a Malleus to vestibule prosthesis, because I do wonder if those are more at risk of increased movement and pressure change and things, and so a vein graft perhaps does make it safer.
Robert, please emphasize as well, because it went very quick. Certain prostheses you would not be able to use without an interposition.
The TORP. A total prosthesis needs... It's mandatory to use an interposition.
Because if you would make a hole, it would you see it gradually sink to the bottom and risk the air. You need some tissue to keep the prosthesis
Otherwise, the risk is, if you don't put anything, the risk is to have a protrusion within the labyrinth.
Yeah.
So this is the malleus. So I'm not removing the incus yet, because it helps me to dissect the malleus, making some, stability, and I'm making an incision through the periosteum of the malleus with a fine needle like this, which is bent, as you can see. And I'm elevating a periosteal flap. And the first step for the malleus relocation technique is to separate entirely the malleus from the tympanic membrane, which is always difficult at the level of the umbo, but usually if you get the right cleavage plane, it's fine. So I need to go anterior, following this, dissection. And you can see that I'm using also the sucker with my left hand to elevate the flap here.
I'm always surprised, Robert, you also use quite a big sucker relatively to the surgery.
A big what?
Your sucker is, the diameter of the sucker is quite big. You're used to
it's a 1.2.
Yeah.
It's not that big, but if I use a smaller one, then you cannot really stabilize the malleus.
Yeah.
I use it to stabilize the malleus also. You understand?
Yeah, yeah.
Sometimes I place the sucker between the tympanic membrane and the
Malleus.
malleus like
Yeah.
this. If I have a gap, then I put my sucker like this, and then it helps because then it gives me some stability.
A good point. We're so used to it. Of course, there's a suction reduction with your foot.
Oh yeah, you can explain that
Yeah.
better than me.
I mean, you cannot have a continuous suction if you do, in my opinion, middle ear surgery. I think everybody agrees to that. That'd be dangerous. So he controls the suction all the time with his foot. And that's
So
essential.
I don't think I will use it for this surgery, but I'm going to demonstrate for the primary case the laser that I'm using now as a test, which is a diode laser. Technically, it is a diode laser, but it's a blue laser, so it's very nice. But they are coming from the
It's a blue
ARC company, which is good. Okay, so you see now the elbow is separated, and now I go back. Quel est normal? Bon, c'est bon. Donnez-moi. Non, j'ai pas fini là. I go back to the neck of the malleus, because you need definitely to, separate entirely the tympanic membrane from the malleus endole. And you see again that if you leave the malleus in this position, the malleus is definitely anterior, and then you have to bend the prosthesis to reach the malleus endole, and then at the end you don't have a final vertical position of the prosthesis, which I think, as you know, is an important point.
So Robert, doing this, it's fairly easy also to make a perforation of the eardrum.
It can be. I'm going to check that now.
And what do you do if you do?
Yeah, and then this is also interesting with the vein graft, because we still have some residual vein in most of the cases, so I can use a vein to reinforce the tympanic
I know,
membrane.
just
but
want
in
to
this case, it's no problem
good,
there,
yeah.
so it's fine. All right.
So you
okay.
do you squish it before you use it then, or do you use it as it is, the vein?
As it is for the tympanic membrane. Okay, so now I will remove the incus, and relocate the malleus after that. So I use a hook. It's not so difficult usually to...
As you were saying, the reason he leaves the incus is this bearing of the malleus, and everything is very difficult if the incus isn't there, because it wobbles around all over the place.
Crochet à hausse encore. Okay, so I will remove that now, I hope. There we go, and now I can remove it.
And if you would have had a dehiscent facial nerve, would that change anything?
Not in this case, because I use a torp. That would be more tricky if you use the incus. So I would use the bucket handle prosthesis. I'm sure that John was showing it.
Yeah.
So at the moment, because I try to explain that step by step, the malleus is still attached by the anterior tympanomallear ligament and then the superior tympanomallear ligament. So now I need, and the tensiotympanoid tendon. So I need to cut the tensiotympanoid tendon like this, close to the malleus. There we go. And then I will overstretch the anterior ligament. You can see the position of the malleus endole. If I put a torp, then the shaft will be there, which is too anterior, or you have to bend it. But now what I want to do is to relocate it. So I'm going to use my sucker on the other side of the malleus, and then I will pull the malleus, reaching the resistance of the anterior tympanomallear ligament. It's a progressive mobilization like this, and now you can see, of course, I place the malleus over the over window. Table vers moi, s'il vous plaît.
Have you ever, because I mean, you need to explain, you put your hook very close to the body and not on the long part.
Exactly.
Have you ever broken a malleus doing this?
Yes, it happened to me, of course, and especially for malleus ankylosis problem. So this is why I knew that I need to place the hook close to the neck, because otherwise if you put it at the
Can you show us where you put it again?
Yeah. Crochet encore alors. Yeah, don't put it here, because then you break it. So you put it close to the neck, okay?
Okay.
All right, now the next step, table vers moi, is to determine the prosthesis length. Stop. So...
so he changes the position of the table all the time, and that works fine here.
We need
in
to be mobile.
university, the nurse has gone for coffee, and you need to wait for someone to help you.
Yeah, sometimes champagne, but not always. All right, so I want to measure the distance, but I want to be sure that the malleus is connected to the tympanic membrane, what I mean is that there's a tendency to see the malleus medialized like this. So you need to be sure that you will measure from the good position, which seems to be fine now. So you need to lateralize a little bit the malleus. And then place the flap back to see if, in this position, the malleus is connected to the tympanic membrane or not. Otherwise...
Robert, hold on. Can you see it or do you feel it?
Feel what?
The lateralized malleus.
No, you can see it. You can see it. And also, it's not. It's also because my experience when I was introducing this technique many years ago, I had case of failure, and all of them when I revised were due to short prosthesis, which means that I was making a mistake in the measurement of the distance. So I understood that, and then I tried to correct it, and now I know that the trick is this one. You need to be sure that we are going to place the malleus horizontally like this.
Yeah. Stuck to the membrane.
Yes, stick to the tympanic membrane. And now I think it's fine. And now I can measure. Le mesureur, donc.
This is a special measurer, isn't it?
Yeah,
It's longer,
longer
much
one.
longer. Yeah.
Yeah, the regular one runs from 3.5 to 4.5. This one runs from 5 to 8. And you see, we have 4 notches. So the...
can you send it where? Can you show it again?
Hold on, I come back. I'm coming back, but I'm not sure about the position of the malleus. I think it's too medialized. Okay, here we go. I think it's slightly better now. Mesureur. So here we go. We have the second notch in front of the malleus, which means 6. But I will use 0.5 because of a deepness of the groove of the prosthesis. Donnez-moi le claron, s'il vous plaît. Okay, so I will elevate now the drum, and then I will do the Stapedotomy first, which means that I will refenestrate the labyrinth. So I know that some surgeons will leave it like this, but it's clear to me that if you leave it like this, there is also a lateralization of the vein graft when there is no more prosthesis. And so the risk is to have a short prosthesis or not to be able to place the prosthesis in the right condition. So I will now refenestrate the labyrinth with the micro drill. So I'm using a 0.7 millimeter diameter diamond dust burr. And on my left hand, I'm using a 0.7 millimeter sucker because I don't want to suck too much into the labyrinth. So of course, I'm doing it just in the same way as I do for the full plate, and the position of the sucker, as you can see, is not exactly at the level of the fenestra because I don't want to suck into that. All right, so I'm going to measure again. Mesureur, s'il vous plaît. The main cause of failure related to this technique is short prosthesis. Before that, it was prosthesis dislocation, when I was not relocating the malleus. With this technique, it's very rare to have prosthesis dislocation, but short prosthesis is the main one. So you see second one and the sixth one. So 6.5, I think, will be the good one. All right, so I will put the vein now again. Alors, s'il vous plaît. So I'm going to take the vein. You see the vein is well prepared. And you see this part is a little bit dry. So we need to remove it from the glass plate. And the part inside the hole is still wet. So I'm going to grab it with the sucker and then introduce with the sucker within the middle ear. So I'm grabbing now the intima of the vein.
Look what he does. He folds the exterior part on his sucker, which is very practical, because otherwise you stick to anything in the ear.
Okay. All right, now I'm going to place the vein over the fenestra. So again, introducing the vein with the sucker and then stretching it with the needle. Stuck the vein a little bit in the sucker.
Yeah.
So I have to take care of this. There we go. And now we are facing the intima. All right. And now I will cut the prosthesis at 6.5. Okay. So this is the prosthesis I designed with Grace Medical. We have adduct appetite head with a groove at the center of the prosthesis, and this is the deepness of the groove I was talking about, is 0.5. I'm going to cut the shaft now.
This is a wonderful prosthesis, but most of us won't have too many in stock.
I know, that's the problem now.
You don't know when you're going to need this prosthesis, actually.
Yeah, I know.
Is it? It's called Vincent Total. Is that correct?
Yeah. Vincent Grace. Both.
Grace Medical Vincent Total prosthesis. It's very good to have in the closet when you need it.
Yeah, very good. Yeah, very easy to place, in fact. Okay, so I'm going to introduce the prosthesis. What I want to do is to introduce the shaft first within the.
For the titanium lovers, it's great because you only need the one prosthesis. You can cut it to any length, which you can't really do.
So you see the shaft is inside the fenestra. Now I will place the groove parallel to the Malleus handle, which means that I need to rotate a little bit the prosthesis like this. And now I will grab the Malleus while I'm going to stabilize or hold the prosthesis with the sucker, and then it's becoming really easy to introduce the Malleus within the groove like this, can they? And should fit well. There we go. Okay. That's it.
How do you know that you're exactly? Hold on. You say you're in your fenestra, but do you check? Do you do a round window sign?
I can check the round window. I can check the round window.
Or do you do a bending sign in this case, or what?
No, not bending. No, don't need a bending sign here, because you know it's a torp. So the shaft, the head is not attached, fixed to the ossicle. So if you do the bending, you can dislocate the prosthesis. So you see the round window niche, I guess, right?
Yeah, some adhesions, yeah.
Yeah, I can remove them. Okay, so now I need to push and see if we can see it, but I'm sure about the position. But
a little bit of water would be. Yeah.
Yeah, okay, fine. It's working good. All right, good.
No, hold on.
So I'm going to reposition the tympanomeatal.
Show us what you're going to do now.
I'm just going to reposition the tympanomeatal flap like this.
Yes.
And be sure that it stays in place. So I will re-elevate the flap one or two times more to check if the prosthesis stays in place, which is the case now. So it's fine. You can see a little bit of a Malleus handle here.
Now, Robert, I say to my patients post-operatively that they must never use a Q-tip with this technique, and the only person that should ever clean their ear should be an otologist. Do you agree?
Yeah.
It's not like a Stapes prosthesis.
But you know, Q-tip is forbidden, I think, for all of the patients. I would say that. Even for a non-operated patient. I've seen so many traumatic problems with that. So it's better to say all of them that not to use it. All right? Great.
Could I, quick question?
Yeah.
I love this. I really do. This prosthesis works amazingly well. I think a lot of people are in the habit of using a piece of cartilage between the prosthesis and the tympanic membrane just because that's the way a lot of people do it. What's your thoughts on that? Obviously, you didn't use cartilage for this.
Yeah. You don't need to use cartilage with adduct appetite.
Robert, do you have time for one or two questions, if there are any questions?
Yes, sure.
Okay, stand up.
But given the microphone.
Yes, of course.
Hello, Professor.
Hello.
What if it's Andrea?
What's your name and where you're from?
It's André from Brazil. André from Brazil. All right. What if we don't have this Vansa prosthesis? Is it possible to use the regular one? The loop?
Then you call me. No, then you use, well, the other option would be to use a total Teflon prosthesis. You know, the same Teflon prosthesis, but you need a longer one. So you need to buy in advance a longer shaft, 0.4 millimeter or 0.6, whatever, and you put the loop around the malleus. But in this case, it's different. You don't have to separate entirely the malleus from the tympanic membrane. You make just a gap between the germ and the malleus handle at the middle of the malleus handle, I would say. And then you try to insert the loop within this gap and then close it. Okay, it works fine.
A small tunnel.
Yes. The only issue that we have is that the tympanic membrane usually doesn't like the Teflon. So I've seen cases of reaction of the tympanic membrane and few cases of necrosis of the malleus handle. So if you have the choice, it's better to use hydroxyapatite. If not, use a total Teflon piston.
We have one more question from the Netherlands, I think.
Thank you. David Colnott from the Netherlands. Would you consider to have used Otomimics to enlarge the incus and to make it in contact with the prosthesis?
Yeah, that's the other option, of course. I didn't talk about that. I never did it myself because I believe, you know, I've seen cases where you do midley exploration. There is a kind of ossification between the incus and the Stapes head, and this is the cause of problems sometimes. So I guess that if you put some cement, if it's a limited erosion, I think it could work. But if it's a total erosion, I don't think, but this is my personal view, but I don't think it's going to really work well.
I think Dwayne will say something about it later on, I think.
Yeah, I'll talk about that on the last.
One last question, because I know Thibaut is waiting and the patient is sleeping.
I just ask about the anesthesia.
Who are you?
Yeah.
I am Ashraf Yaqut from Egypt, and I will not discuss the operation now because we will discuss it for 3 days later. But the magnificent anesthesia and the view, it is like a cadaveric dissection. How can we prepare the patient? And shortly, just preparing. This is very nice view that we can work a lot. Anything.
It's a cascade of things, and it starts with the microphone, the camera, everything, and the table. The table is essential.
Okay. I'm talking to my anesthetist. Is using propofol, and of course is following the blood pressure all the time during the operation. And the key point is to try to keep it lower. I'm talking about the systolic, talking lower than 80. If possible, which is not always the case, of course, but this is a good condition.
But they're short interventions. Okay, thank you, Robert.
Okay, see you later.
Thibaut?
Yes?
We're going to go to you.
Do you hear me?
Yes, we can.
Okay. Good morning, everybody. I am Thibaut, and we have a surgery, an implant.
And can you introduce Caro?
After.
Yeah.
So, I show you the case. Alors, il faut montrer à la caméra qui est là. Non, revenez en arrière. Encore au début. So, this is Otosclerosis. Donc, montrez à la caméra qui est là-bas.
Allez, parfait.
Vous filmez la tablette, vous zoomez dessus.
Live surgery, Thibaut.
Otosclerosis case. And bone bridge is plan, tourné. Non, dans l'autre sens. This is, non, revenez. A 70-year-old female. She had the bilateral this and was operated on the right side in 1977. But unfortunately, she had a dead ear 4 months after the surgery. And currently, she has a bilateral hearing loss and uses hearing aid on the left ear. Tournez. You see her profound, essayez de zoomer sur la tablette, a profound hearing loss on the right ear, and on the left ear she has 85 decibel mixed hearing loss with 50 decibel airborne gap. She don't want to have a surgery on the left ear, no surprise, and so Tournay, we decided the indication for bone bridge. You see here, her right ear, and we can understand why she has a deeply intravestibular piston, Tournay. On the left ear, on the CT, you see the otosclerotic focus involving the stapes and the cochlear, Tournay. And this is a simulation of the bone bridge implantation. In that case, we can implant it into the mastoid. Très bien, on va remettre la caméra là-bas, derrière moi maintenant. So, we'll start the surgery now.
Thibaut, can you hear me? This is
Yes.
Bahar. Just a quick question. What was your decision making in terms of choosing the bone bridge versus the Sentio?
It's not loud enough. Michel, with help. Could you repeat, please?
Sorry, what was your choice between this bone bridge and the Ossia and the Sentio? How did you choose one over the other in this case?
The choice between the three implants depends first on the hearing loss, the bone conduction thresholds, and after of the characteristics of the implant. The Ossia, in my opinion, is not very well designed. Is too large. The idea to put the vibrator on the tip of the mastoid, quite on the tip of the mastoid, is not a good idea. And so, for that reason, I prefer to use rather the bone bridge or the Sentio. In that case, where the mastoid is large, I can use the bone bridge, and I see you after this morning the Sentio. So, the position of the implant is the vibrator into the mastoid, and I have to take care to avoid to put it under the concha, because if I put it under the concha, it will lateralize the pinna. So the vibrator will be into the mastoid just above the concha with the antenna in that position. Alors, il faut faire quelque chose pour la lumière, là, s'il vous plaît, parce que... So I prepared the approach. Alors, il faudrait que vous zoomiez un peu. So I exposed the mastoid and I prepared a superior sterile pocket for the antenna there. And we will now see how it fits for the implant with a dummy. And so I want to put the vibrator in that position. So I will use retractors, écarteurs, compresse. So the surface of the mastoid is largely exposed. And I will take a landmark for the size of the well for the implant. Alors. Il faut essayer, quand vous filmez, que ma main ne masque pas. Donc, pareil, toujours pareil, si vous pouvez être plus près, plus vertical. Là, vous pouvez avancer. Hein. Hop. I try to center the camera. Hop. Voilà, et il faut zoomer. Il faut zoomer. Voilà, comme ça c'est pas mal. So, and I will start the drilling. De l'eau. So the well for the implant has to be 4 millimeter deep and 18 millimeter diameter. Alors. Vous allez me donner la grosse fraise diamantée. So here I can see the dura. That means I have to drill a bit more inferior. Voilà. Vous remettez la fraise coupante. Ce qui marche pas bien. So now I check the size of the well. Up. Diameter is a little bit too small here. I can see inferiorly the lateral sinus. Here's the dura. Vous me donnez la cire d'Orsley. De la cire. Fraise diamantée, la grosse.
Thibaut, how critical is it, the depth?
Please?
How critical is the depth that you drill? You said it's 18 millimeters for diameter. And what depth did you say?
Sorry, the sound is not good. I didn't understand.
Okay, you said it's 18 millimeters diameter.
Yes.
But what is the ideal depth?
What is?
The depth. How deep?
4 millimeter.
Yeah. Okay. Does it matter if you go a bit less than 4 millimeters?
Yeah. Yes, because the implant is attached with 2 screws that go through little wings beside the vibrator.
Yeah.
And if you want that the 2 wings lie on the cortical, the well has to be 4 millimeter depth.
Okay. Good.
If you cannot, you can use what is called BC lift. It is little accessories that allow us to put the implant with less deep. But in that case, the implant is more prominent.
Yes,
so I try to put
Yeah.
it in a 4 millimeter well.
Yeah.
Alors. De l'eau. Allez, allez. Alors, donnez-moi le gabarit. So I can impact a little bit the dry in the sinus if necessary, and we'll do it progressively. La fraise coupante. Il faut me dire quand je mets la main devant. Hop.
Thibaut?
Yes?
Again, with regards to the selection of this device, you're using this as a, you could continue, go ahead, drill. I'll talk to you while you're drilling. I don't want to interrupt you, but.
Could you repeat, please?
In terms of selecting this device, it seems to me the patient is a cochlear implant candidate on the right side. Was that a
Yes.
consideration?
No, because, not at this date, because the first and better possibility to improve her hearing is a bone conduction implant on the left ear. After, she could be candidate for a cochlear implant on the right side, sure.
The bone line on this side, though, was quite severely impaired, no? What was her bone line pure tone average on this ear?
The bone conduction on this side, on the left side, is around 35 decibel, and so it's suitable for the bone conduction implant. Alors.
Thibaut, some people would argue that you could be very daring and do a stapedotomy on this ear and then cochlear implant if it failed. Has anybody suggested that?
Yes, I suggested that to the patient because if a successful stapedotomy on the left side for her would be the best medical improvement she
Great
could
hearing,
have.
yeah.
But the patient didn't want
That's fine.
because of the risk. But sure, you have to discuss it and to explain the advantages and the risks.
That's a good option, John, but usually we would wait until the speech discrimination, aided speech discrimination, was poor enough that they'd almost be an implant candidate anyway. But then correcting the conductive loss might make them have aidable hearing.
With regards to that, though, I think you have to also look at the vestibular function, because in these older patients, if the vestibular function has been lost on the other side, bilateral vestibular loss is more of a problem because you can't do a cochlear implant for that. So the vestibular function becomes really important to look at.
Alors, on va me donner la cire, un gros morceau. Pas si gros quand même. So, alors, now let's see the dummy. So, maintenant on va prendre la fraise diamantée. The diameter is near to be good.
Thibaut, do you worry about compressing the sigmoid transverse when you're putting these in?
Not really, because I will not impact it completely. I just compress it a little, but it will not obliterate it.
The reason I'm asking is because I see so many patients now with pulsatile tinnitus when they get the narrowing of the transverse or sigmoid when we do angios, and I'm now less and less comfortable compressing than I used to be.
Okay, let's see now. So the diameter is good, but vous allez me monter le gabarit, le décolleur de l'héros. And so if I check for the depth, you can see that, alors, no, you cannot see. The wings of the of the implant do not touch the cortical there, so I have to go deepen to be in the right position. If really it's too difficult, I would use the BC lift, fraise, de l'eau. So I will try again. Donnez-moi le bistouri électrique un instant.
Have questions in the audience? You can
Yes.
You can ask questions as you go along in the audience if you like to. In fact, it's mandatory, as Wilco says. So Thibaut, because nobody's asking questions, if you had a mastoid cavity here, have you done them retrosigmoid or middle fossa these sometimes?
If I had
If you had a big mastoid cavity and you can't find space behind the mastoid, have you done them retrosigmoid or in the middle fossa?
I'm sorry, the sound is really ugly here. I don't understand anyway.
Oh, if you had a big mastoid cavity, so there wasn't space.
Michel, tu peux pas ranger le son là?
Can you hear better with this one?
Bon, allez, fraise.
Can you hear, Thibaut? No.
Oui.
Yeah. Well, I have had to put them. Sometimes you have a big mastoid cavity and there's no bone there, and I have put them in the middle fossa a couple of times, higher up, and also retrosigmoid a couple of times.
Alors, on va remettre de la cire. Hop. Donnez-moi le gabarit. Bon, allez, fraise.
There's a question at the back.
Thibaut, we have a question.
Yes.
Hi, Thibaut. Javier Gavilan from Madrid. Can you hear me?
Yes.
Okay. I think it's extremely important to be able to fit the bone bridge, to have a smaller drill just in the angles, because if you have a large drill, the angles of the back, on the deep of the bone bed, they are round, and you need them to have straight. So.
Yeah, I understand what you say. Yes. On va prendre la taille en dessous. Hop. That means that the rims are okay, but in the depth there, the diameter is not okay, and I will drill it with a smaller drill. Okay, I think now I am good. Donc now I can take the implant. Hop. On va prendre l'implant. On va changer de gant. I will change my gloves. Hop. And for the bone bridge, you can implant it into the mastoid or in retrosigmoid position or in temporal position. In my practice, more often I insert it into the mastoid, but the evolution is that more and more I use the retrosigmoid position. Hop. Hop. J'arrive à mettre mes gants, vous n'avez pas des gants. Hop. Hop.
Thibaut, one more question.
Yes.
Have you considered the possibility of using a cochlear implant on the other side first, and then do whatever you want to do on the left side?
I think that the hearing improvement with a bone conduction implant on the left side will be more immediate and easy than with the cochlear implantation on the right side. I think that the hearing will be more easily improved with the bone conduction implant on the left side.
And using the bone bridge on the right side to avoid the head shadow effect may be an option also?
It could, with the difficulty that the bone conduction on the left side is not perfect, and so it will be more difficult to have a good cross effect because of that bone conduction. And for the right side, if there is an implant to consider, sure, it's more cochlear implant than a bone conduction implant for a cross effect. So I will show you the implant. You see, it is an electromagnetic vibrator with two wings to fix it to the cortical, and the demodulator and the receiving antenna. I want that the implant will be in that position. I can curve a little bit the conductor leak to have the right position for the antenna. So first I will put the implant in position in order to check how it fits. Alors, donnez-moi ça et l'implant. I put the antenna into the superior sterile pocket, like that. Pince râteau. And I will fit the vibrator into the well. Alors, écarteur. Pince râteau. Okay, in my opinion, it will be good. So I will put the two screws to fix the vibrator. Up.
Thibaut, can you hear me?
Yes.
We're just going to watch you put the screws in, then we're going to let the delegates go for a cup of coffee.
Okay.
So we'll just wait for a couple more minutes while you put the screws in.
So I will just put the screw and close. Non, c'est pas, ça tient pas là. The screws. Alors, regardez à la caméra comment vous pouvez faire. So I put the first screw. I will not screw it completely. Okay. And I will put the second screw. Essayez de bouger avec la caméra, mais okay. And now I can completely screw the first one, and up. The implant is fixed. That's okay. Now I have just to close the approach, and as you see, the vibrator of the implant is not under the concha, and it will not lateralize the pinna.
That's great. Thanks, Thibaut. We're going to go for a break.
Okay.
Thank you very much.
You. Alors.
Okay. Just 1 minute, please, your attention, because as you probably know and have seen, we have prepared a practical course in which you will have the opportunity to practice all those techniques that you have seen here, those from the Causse clinic and those that we will show you there. It's limited to 20 attendants, and we have given preference to those who have attended this course or the previous courses in the Bessier clinic. And this will be kept until the 1st of September. Afterwards, it will be open to any other attendant who wants to go. So just take a look, and if you are interested, we will welcome you all to Madrid for this practice. I think Wilco will be there, and Robert will say that, of course, people from the Causse clinic courses. We're waiting for you. You're very welcome. Sorry? Yeah, we are looking for that, but it's not yet. It's not yet. Yeah. Okay, Wilco, your turn.
You can do it again after.
Yeah.
Just announce for the French people, there's no. Quelqu'un m'a demandé de traduction pour dans la langue française. Je dois m'excuser, nous avons seulement la traduction cet après-midi. Ce matin, ça ne fonctionne pas. Aucune idée pourquoi. Je voudrais dire bienvenue en France, mais je ne sais pas. Je dois continuer en anglais. Hello, everybody. My name is Wilco Groman. I'm here in the clinic since 2019, and it's been interesting, very enjoyable, and a much more relaxed life than I experienced in the past in the Netherlands, the Pays-Bas. Absolutely not comparable. My presentation is a little bit different than the others, because I want you to realize, I think that's the only takeaway message I would like to give you. You see a lot of experts explaining their surgical technique and say what's best, and in my opinion, you need to consider it's all opinion-based. I think that's what you need to realize. I'll have my presentation a little bit different. I will deviate a little bit from otology. I know I won't do that too long because I'm sure you don't like that too much. Then I'm just going to focus on Stapes surgery because you need to realize there are many variables, and we'll discuss them briefly, and I'll highlight a little bit more points, not all, obviously, but some of the points. And I need to declare, of course, I have no interest, financial interest at all in the presentation. Nobody has paid me yet, but I may be open to it if it's the amount is right. Okay. Okay. So a little bit of a deviation, because and I know it's off topic, and I'm sure many of you only want to see live surgery, but I just want to stimulate your way of thinking. A little bit evidence-based, I would like to say, and. What you hear a lot here, and like John, oh no, in my hands, no deaf patients at all. When they were deaf, they didn't come back to me, so I have none. Huh? And you need to realize that these are all, we're so selective. We tend to see our patients back, and the patients that we see back we're happy about, and we tend to forget the people that are not so happy. So let's remember, there's a lot of myth and a lot of truth to be heard. I'm not criticizing. Some of the surgeons are fantastic, and all the delegates, all friends, of course, so I can't criticize them. But all the delegates have a huge reputation, from Briggs, Saji, everybody. Sperling, of course, in New York, everybody. München. And even Africa. Welkom. Goedenavond. Goedemiddag. Afrikaans. So you need to realize, when we present something, you need to look at how much relevance is there to the topic. Is there any risk of bias? Because bias is what's in all of us. We always have bias all the time. And we need to think about confounders. And confounders are very strange things. Confounders are things that determine your outcome. You have no idea what it is, but it makes your conclusion incorrect. So, now the world is so strange with America doing what it does. Neil, I'm not telling you're American, The world is strange. But let me tell you, there are a lot of people that doubt the Apollo landing on the moon, and I tell you the truth about it. You should look. So, not everything we know is based on the truth. Okay, I'm going to deviate a little bit. In 1936, that was about, what was it, 20 years after the Titanic, there was a huge research project. Has anybody done ever research? Hands up, who has done the research? Well, that's a good idea. And has anybody done any randomized trials at all? Okay, so we can all tell you that a randomized trial in healthcare, if you exceed, like in ENT, if you have a randomized trial bigger than 120 patients, you're a big shot. And if you do a randomized trial more than 100 patients or 200 patients, it's huge. I'm telling you about a randomized trial they did, They had a sample size of 2.3 million people. And what they wanted to do, they wanted to know what the election in 1936 would turn out. Of course, everybody knows. We know the discussion with Trump, etc., and Biden. That was also going on in 1936. They did research to see who's going to win. And these smart guys said, well, you know what we're going to do? We're going to ask everybody. We're going to call them up. And if not, we'll check the car registration. We contact them and say, Saju, are you going to vote? Who are you going to vote? So that's what they did. And a huge sample size, because 2.3 million in healthcare is almost not seen, maybe in cardiology, but not in ENT. So that's a huge sample size. And they asked the patient, all the people asked, what are you going to vote? And it turned out this guy was going to win, Alf Langdon. And nobody has ever heard of this name, so he didn't win, obviously. But Alf Langdon was going to win by 55%, which is a lot. I think Trump with 1% difference, etc. So this was not the truth. So what happened? Eventually it was Roosevelt, and we all know Roosevelt, who won. But that's strange. I mean, we asked 2.3 million people what they're going to vote, and it was going to be not Langdon, it was him. And what happened? Something went wrong, because he won. And the thing is, the truth is, in America in 1936, you could see these posters on the wall, happy family with the dog leaning out of the window, breathing nice fresh air, and a happy family. There's no way like the American way. But the truth, of course, this was the truth in 1936. So if you're only going to ask the people that drive the car and are happy, and the people that could afford a phone, they would vote Alf Langdon. But the majority of the population, of course, was poor, hungry, looking for work. So this is a fantastic example of a selection bias. Okay? And then you think, oh, that won't happen to me. Well, why do that? Because, I mean, we see our patients from our region, which means by default, it's a selection. If I work in Holland, I don't see French patients. And in France, I see a lot of the French, but not Dutch. So we constantly talk about selection bias. So that's important to realize. And I think evidence-based medicine has been focusing on this. And does anybody recognize this triangle? I hope you do. Who recognizes the triangle? Okay, that's good. Okay, so this is more or less the modern way of thinking of healthcare. The highest level of evidence you can get with a systematic review, which is normally a collection of multiple randomized controlled trials, and you go down from critical appraisal, etc., etc. And then you at the green, the big base, and look around you, look left, look right. That's the big base that's here today, because all what we'll be discussing today is expert opinion. So please value it as expert opinion. I'm not saying it's wrong, but it's not anywhere close to high quality value. If that's what you remember from my speech, my talk, I'm satisfied. No, not yet. So thanks, Neil. He's the American who wants to ask a question, but we don't. So remember, it's all about, you can, but can I finish first? Okay.
So it's all about expert opinion. So I want to discuss a little bit about surgical procedures. And we've seen a very, I mean, Robert's the best ear surgeon that I've seen do live surgery. And you see him do the procedure, even the Malleus relocation. I mean, anybody doing this will break it first, etc., and it will delodge completely. So there's so many variables, and I think that's what you need to realize. Eventually, you need to look for a technique that works for you, and it can be the way Robert does, because I think it's a very proven technique, and I mean, all of us have, many of us have adapted it, but it's not the only way to do it. And you need to realize some people will advocate, I need to do it on the local because I can test the hearing during surgery. Or I do an endural. I've done most of my Stapes surgery with endural surgery, but I do prefer now, as a matter of fact, transcanal. But exposure, etc., becomes in play. And like I said, the table. If you don't have the maneuverability of the table like this, I think endural becomes difficult. Transcanal becomes difficult. Drill, laser, etc., etc. So there are many variables that may determine your outcome, and you need to realize that. And there's no one way. I think that's what you need to realize. There are multiple ways, and I'm pretty convinced, and that's an expert opinion, that many surgical techniques will result in good results. Eventually, I think the surgeon will determine a lot. I did research in the past on Stapes prosthesis, and there are different types of prosthesis. And I'm not sure if you're aware, there are crimping prosthesis that you need to crimp after you put it onto the incus. And some of them are self-crimping, like nitinol is self-crimping, but also other prostheses that are crimping by themselves. There are different techniques, different diameters. I'm only going to discuss the crimping and the diameter discussion in this. So, like I said, this is typically a metal crimping prosthesis, but also the big loop being used today, that is a crimping prosthesis as well. He opens the Teflon hook. It needs to be opened, otherwise it becomes very difficult to put it on. When you put it on, even though the Teflon has a memory of itself, you need to push it a little bit more. The same thing with titanium and gold prosthesis. There was this guy in Switzerland, Daniel A. Wengen, who made a clip prosthesis. That was a non-crimping prosthesis. So we did a research, we randomized a series of patients, we did either a non-crimping and a crimping prosthesis. And this is the difference. Those are some examples. There's gold, the K piston from Kurtz, of course the big loop from Robert, and the non-crimping. And the difference is that you need to realize that prosthesis you would need to crimp if it's metal, and the other one, which is titanium as well, you would not crimp. We did a research, and what we found that in the crimping group, the hearing average mean hearing gate would be 13 dB. If I would compare it to the non-crimping, the hearing result was better, and that is statistically different. And there you can find multiple publications on the matter, all expert opinion, of course, none of them randomized. And what you could see that indeed the non-crimping prosthesis had a better result than the crimping prosthesis. So that's an easy way to think. Okay, then we all go to non-crimping because the results seem to be better. The thing, on the other hand, we found that the patients started complaining about strange sounds, rasping sounds in the ear. And that was only in the crimping non-crimping prosthesis. And that was strange. And we looked in the laboratory and we found that even though the non-crimping can be perfect, but if the angle of the malleus is a little bit different, it will force the piston to scratch the round window. And that was exactly what the patients were complaining about. Of course, in patients we couldn't research it, but we could simulate it in laboratory. So even though this bond, the non-crimping bond is very strong, we paid it with some additional or sort of negative effects. So that eventually was a reason for us to abandon this prosthesis. And by now it has been modified, etc. If you want to read about it, it's all been published and you can look it up. But eventually the problem was that it's too tight actually. Good for the hearing, good for the airborne closure, but it's not good for the end result of the sound. We also looked at the piston diameter. And if you have done some evidence-based medicine before, Now it's a very the technique to do the research. You would determine the domain, what patients what you would do it look for. What is the what modification do you do? That's the prosthesis diameter, shaft diameter, and then the outcome. The other way you could use is PICO, patient intervention compare outcome. I mean, that's the same thing more or less. And that's, if you really want to look into literature, that's how you should approach it. You should not go to PubMed, etc., but you need to look for specifically what you want to know. This typically would yield a response like this. If you look in all the electronic sources, we ended up with, in total, I think, well, add them all up, 2,000 articles in total. After removing all the duplicates, we would end up with 1,455. And after screening all the abstracts, eventually you would end up with only a limited number of articles which were good enough to be evaluated. And then if you want to evaluate it, that's a systematic way to that as well. These forms you can get, I think the Cochrane probably publishes them as well. You need to systematically grade each article. And you would look at the relevance. I mean, I looked for the article, but eventually when I read it, it turned out it was not applicable to my question. And also the risk of bias. And I just gave you the example of bias, of selection bias, but there's many kinds of biases are there. Non-blinding, you have the doctor being influenced by it, etc. If you look at that, at a piston diameter, eventually you get at an overview like this with all the articles that we found. And then you rank them, and eventually the risk of bias in the end, medium, 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 medium. And if you go further, the risk of bias is terrible. I mean, if you look at these articles, they're hardly worth reading because there's lots of biases in it. So if you looked at all at the literature, I know there are some new articles that I didn't include. On average, we cannot say that there's any proof for either a smaller or bigger prosthesis. So anybody claiming, no, it should be 0.6 or it should be 0.8 or 0.4, I don't think there's any scientific proof to support it. And it may be true, but then it's expert opinion, okay? And we did do some laboratory. I think we did it at Manahar's lab, I think. Manahar, where are you? I think we did it at in Halifax still. Huh? Inge Wenger, yeah. Yeah, she worked for us. That's published there, Inge Wenger. In the lab, we did find some differences, but in clinical studies, we didn't. The other thing, I'm sure we're going to be talking a lot about lasers. And now everybody's saying, no, I use a diode. I have a blue diode. No, I have a purple diode. I mean, why do we use diodes? Because the industry came by. A diode laser is very affordable, the cheapest you can get. And the fibers are very affordable as well. And if you're in your own private practice, all of a sudden cost, academic it doesn't matter much. But if you work in private practice or in your own practice, the cost of operation becomes an issue. So diode in that sense is very attractive. Let's see if it's attractive for ear surgery anyway. This is an example of someone during live surgery we did. He's going to do the oval window, and this is what happened. So he unintendedly cut the long process of the incus. And this is not, actually we've had it happen twice during live surgery, twice. So that's the risk of a microscope-guided laser. So I think even though it's expert opinion, I think the majority of us would say we prefer to use a fiber-delivered laser. That's interesting to know because that limits also the type of lasers that you could use. Anyway, fiber-delivered I think is the majority. We appreciate it. You can manipulate it a little bit more, etc. And it's absolutely true that a laser, for the part that you do, you want to remove the superstructure of the stapes, and even for the penetration, it can be very practical. We, all our life, I mean, a major part of our life, we always used the KTP, which was practical. The fibers were not too expensive. That's what we had. I know of publications that we always, some people said they always used argon, but it turned out it was KTP. But we published many articles with the wrong laser in the publication. The very nice, potentially very nice alternative would be a CO2. Because the CO2 is used by the gynecologists and it's used in airway, etc. The big thing is CO2 will not go through a fiber. So, and now you can get fibers, but it's called a hollow fiber or a mirror guided thing. These are a little bit thicker than the very thin diodes, very expensive. I'm not aware of the current price, but it can be close to 300 euros per one. That makes the surgery quite expensive. But these are actually quite good. Diode. Everybody now has a diode because the dermatologist uses it, and it's very cheap. I think you can buy one. I think a Fox for 5,000 euros or so. They're very cheap. And of course, thulium. Thulium you haven't heard much about, but it's used in other specialties like gynecologists and urology. Interesting to know, if we do surgery and if you make a perforation in the foot plate, you need to realize, you need to know how much of it, because you saw John's video, I saw anyway, he was carbonizing the foot plate, but you could see that he went through, you had a small hole through. And then this becomes very important, because you want, preferably, the laser that goes through the bone to be absorbed by water. Because if it doesn't, it goes straight through the water, and the endoneurium may be suffering from it. And I think it does. If you do widely the laser, it will. So what you need to realize, the CO2 is the most favorable because it has a huge absorption in water. The next thing up would be the thulium, which has a good absorption, but not quite. And all the others are, in theory, less suitable for Stapes surgery. I'm not talking about the superstructure, of course, but as soon as you do the perforation and you go through the bone, the laser will go through and hit the nervous tissue. So that's important to realize. And the other thing is, some of the lasers make a lot of noise. Like this CO2, this is noise analysis of the laser, the sound production because of the explosion. We looked at the different laser types and the sound that they produce. And of course, the microburr, the osteostap, produces the most sound. And the KTP, which is regarding because of the water not being resorbed in water, is a very nice laser to use, and it doesn't make any sound. But it's more dangerous in the air to use. So we looked in the same way, like I explained to you, in an evidence-based medicine way into the literature, looking of where the patients came from Scopus, Cochrane Library, PubMed, etc. And the major databases for research. In the end, if you do the critical appraisal beforehand, 1,050 remained. You look for all the duplicates, etc., etc. And in the end, we ended up with 2 articles that may have been of interest in the discussion of laser and ear surgery. And funnily enough, because Robert and I have been doing research for many years, that was the article of Robert and of the Italian group. One can state, with this expert opinion, level 5 evidence, all lasers decrease the chance of mobilization, or if you have a mobile foot plate. That's an interesting discussion we can have. What do you do if you get a mobile foot plate during Stapes surgery? Do you continue or do you abort? That's an interesting discussion. With a laser, personally, I'm not afraid to continue because you can do it without touching it. With other instruments, it may not be that interesting. For you to realize, all lasers are practical, but you need to be aware that lasers go through water, except CO2. We did research with the thulium here in the clinic, and we found dead ears, strangely enough, some dead ears due to the laser with the thulium. And the thulium is not very widely used in ENT, but I would not advise you to use it anyway, because what we saw, the thulium gets absorbed in water, but it created bubbles. It started bubbling, so we started boiling the water. Anyway, this was at Miguel's other course that we did in Madrid. Was very nice. We met together, of course, Robert, Chris, who's still in the plane, Livy, me, and my wife. And I want to tell you about the truth, etc. Have a look at this. I found this on the.
Insanity of these two guys who decided to pull off an illegal urban wingsuit stunt.
Oh, sorry. My fault. Sorry. Do it again. Yeah, I can't. It's the audio is not connected. Should go through
You might question the sanity of these two guys who decided to pull off an illegal urban wingsuit stunt in Rio de Janeiro. As you can see, the men were Red Bull wingsuit daredevils. They actually successfully threaded the needle between two skyscrapers in Rio. One of the daredevils attempted to fly by one of Brazil's famous monuments. Fortunately for him, that was his final stunt.
So, not everything is true what you see in on telly, but also today here. Any questions before we come on? Neil, wake up. Okay.
I guess what I wanted to say was, you know, in the absence of really good research on some of these questions, because we don't have the evidence-based studies, sometimes we have nothing else to rely upon. And that's probably true for almost everything. We have so few studies that we can really answer the questions that we have that we do have to rely to some extent on expert opinion. There's one more layer to that pyramid that has been invented in the US. It's called common sense. And that is what is ruling the nation right now. Well, they recently feel that that is the way to do research now. You don't need NIH grants. You don't need the NIH anymore. You just need common sense.
Your remark is absolutely valid, coming from an American. Of course, you need to, I mean, if there's evidence, we need to look for it. And if there's not, I mean, you can search the databases and there's no evidence, nobody knows. Okay, which, Robert, or what? Okay, anyway. Okay, thanks, John. Okay. Le bloc, Robert. Robert, we don't have sound yet.
Hello.
Hello.
Hello, can you hear me?
Hello.
Hello.
Bonjour.
Bonjour. Can you hear me?
Yes, we can hear you. We can see you.
Okay.
We see your talented hands. Something doing in the ear.
Yeah. So I've already elevated the flap.
Dennis, join.
So, s'il vous plaît. So just to show you the beginning and the landmarks.
Yeah.
Orientation and everything you need to know. So this is the left ear. So this is 12 o'clock, 6 o'clock.
Good.
So I made an incision from 12 to 6, elevating the posterior half of the tympanomeatal flap. And in terms of history, this is a patient with a 40 dBA bone gap, and it was a history of bilateral otosclerosis. I did the right side 1 year ago, and now, of course, I'm doing the opposite side. So, as I explained before during my previous operation, I'm now elevating the tympanomeatal flap and until I reach the annulus. Juste un petit mot pour les délégués français qui sont là et qui ont envie d'avoir la traduction simultanée. Elle sera présente tous les après-midi. Vous ne pouvez pas l'avoir pour la totalité de la journée. So, vous pourrez avoir la traduction simultanée cet après-midi. So, now, calmez s'il vous plaît. So now I need to elevate the annulus. So what we can see here is the mucosa here. I'm going to focus it a little bit. So this is the mucosa.
Yeah.
And we see a little bit of the chorda tympani.
No.
Right here.
Where?
I'm showing you in a second. I'm trying to elevate a little bit more. Maybe I need an endoscope to show you. Endoscope, speculum. I was close. Okay, fine. So,
There's
That's-
Coda.
Yeah, now you can see here, okay? Now, when I want to do, Plaron, s'il vous plaît, I want to expose a little bit more the chorda tympani. So to do this, I will use a short hook, short and strong hook pour le canal. Because you know the chorda is right below this bone with very frequently a canal for the chorda. So I use this and sometimes can help. I don't think I'm in the, I'm not in the canal, so I will see that later. Curette, s'il vous plaît. So we can see a little bit of the, donnez-moi le cannelé du marteau en fait. Cannelé, pardon. So we can see a little bit of the incus and a little bit of the stapes head. So that's, of course, not good enough. So what I like to have is a clear exposure. So I'm going to use the curette.
Robert?
Yes.
It's Denis.
Can you center, please?
C'est Denis.
Yes.
Why do you open so inferiorly?
Oh, because I like to have, it's just 6 o'clock, sometimes a little bit more than 6. It's 6 to 7.
Okay.
I like to have a nice exposure. That's
Okay.
the only thing. But yes, you can do less than this, I guess. Oh, it's a personal cannelé feeling.
Yeah, I would argue, Robert, that if you don't go a little bit a bit beyond 6 o'clock, the flap falls backwards. It makes the flap much more stable if you go a little bit further forward, but everybody can argue. Yeah, exposure is everything, says Wilco.
Canal pour la corde. So I need to open up this canal of the chorda, because I cannot expose it more. Cannelé.
Well, aside of this, we can also look for objective measures, how far we should open. And as soon as we see a pyramidal process and the tendon, then we have opened properly.
So, of course, the chorda tympani is a little bit overstretched here, but it happens, and it's always better to keep it and not to cut it, of course, even if it's stretched. So we have this bone that I need to remove, and then I think it will be okay. Crochet, s'il vous plaît. You can see the facial nerve behind, which seems to be exposed, decent.
Yeah, we saw it in the depths, and we're waiting for some surprises.
Yeah, we're going to do that. I know you like the surprise, so...
yeah, sure, that's why we're here.
Of course, I know.
And we're more than happy that you are the surgeon and not us.
I'm not sure about the chorda, but anyway, that's it. Okay, so now we have a clear exposure. Cannelé.
Yes, very nice.
I think the chorda is really overstretched, probably even cut, but it's the best I could do. No, some residual tissue, so it's fine. I keep it like this. All right. Un plus petit là, s'il vous plaît. So now my exposure looks good. We have this facial nerve, partially dehiscent here. You can see I'm touching it.
Very nice.
And we can see the pyramidal process here. All right. So the next step now is to separate the incus from the stapes. And I use a joint knife for this. And what I like to do is to check the position of the joint. So I'm putting a little bit the incus like this, and I go into the joint, using also my left hand to stabilize the incus. And by pushing a little bit the incus, we can also stabilize the stapes like this. Okay, that's fine. So now I'm going to check malleus incus first. So you see I'm moving the malleus and the incus is following the movement.
Watch the chorda.
Yes. The chorda is really overstretched. And then I'm checking the stapes from the top of the head, and the stapes is fixed. So now I'm going to cut the stapes tendon. All right. And now we're going to use the laser. Plaron, s'il vous plaît. Le laser, hein? So I'm going to use the arc laser, which is a really good one. It's a diode laser. Blue one. increase the light a little bit so we can see that.
You're not afraid if the facial nerve is not covered by bone?
No, because
with a laser?
yeah, it is a question. Yeah, I think we need to use a fiber optic. The micro manipulator could be a problem. So I use a fiber optic, which means that you can really touch the target, and then you are very accurate. And of course, you place the fiber away from the facial nerve.
So do you have any situation where you avoid using the laser because of the facial nerve?
I could do if there is a total dehiscent facial nerve coming into contact with the posterior crus. Then in that case, I will not use the laser, and then I will drill out directly.
Okay.
Okay. So I'm using...
You can ask questions from the floor if you have during the surgery.
Yes, sure.
Because
Robert, do you have
it's not a problem for Robert.
Robert, it's John. Do you have to carbonize the diode laser, or can you use it straight out?
No, you can use it directly.
Okay.
Very efficient. So I use a setting of 1.2, le laser s'il vous plaît, for the superstructure. And you see this fiber which is bent at the distal tip, which is very nice. So I'm going to be a little bit away from the target. Prête? Feu. 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 You see, it's brand new for me because I got this laser only for a few days, since few days, and I'm trying it. And I like it.
You touch the structure.
No, you touch it and you go. No, you don't touch. You just be a little bit away from the target.
Okay.
Prête? Feu. Feu. This is, of course, more tricky because the anterior crus is hidden, so this way would be better. So you see, the position of the fiber is away from the facial nerve. Prête? Feu. 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 Okay, we can't see it, so I touch it. It's a feeling. Okay, so now I'm using the 0.7 millimeter diameter diamond dust burr with a low speed drill.
Hi, I'm sorry.
Yes.
Jose Lovera from Asunción, Paraguay. I have a question. If you don't have the laser, would you use the drill?
Yes.
To do this? Do the
In fact,
superstructure?
yeah. In fact, to be honest, I didn't use the laser for many years now. I was not using it anymore because I used a different type of laser, and then the Luminis one has a technical issue, and I decided to try without a laser. And in fact, I did several hundreds of cases, probably more than 1,000 now, without laser, drilling out only. And interestingly, when I go into my results are better. So it's interesting to see that. And I didn't have any case of sensory hearing loss compared to the series with laser.
And about the diameter of the drill for the superstructure?
0.7. And what I said, my incidence of sensory hearing loss is 0.5. I'm talking about all of them, not only dead ear. And with the laser, without laser, I didn't have any at the moment. So it's pretty interesting.
Hi, this is, there's another question.
Yeah.
It's Tariq Khan from Hull, UK.
Yeah.
Do you routinely use, or do you not routinely use facial nerve monitor in Stapes surgery?
No, never. Except if I have a congenital case. Of course, in that case, I would use it, but not for regular Stapes.
Thank you.
Robert, the other comment I was going to make is, since we've had the availability of the OsseoStap drill, that's made, for me, it made a big difference.
Yeah.
I think the Zomed one was good, but the OsseoStap BNA is fantastic.
I agree. It's more stable. So I'm now measuring the distance from the Stapes foot plate to the incus, and usually I'm using the mid surface. You see the second notch is in front of the incus, which means 4 millimeter. So I will cut the prosthesis at 4 millimeter.
Robert?
Yes.
Did you see any time stapedial artery?
Did you see what?
Stapedial artery. Stapedial artery.
Yeah, it happened to me. Persistent stapedial artery. Of course, it happened. I will show that in this afternoon on my congenital talk. It's pretty rare, but it happens. And that some of them can be really, really big. But even when they are connected to the stapes, they never decrease the mobility of the stapes. So you can do the surgery, but you really need to be very cautious not to do not to injure the stapedial artery, of course. Attendez, un œuf d'abord. So what I need to do now, I need to perform the fenestra. So I will use the laser. Ah, c'est bouché. With different setting. 0.8 watt. So I'm using a very low setting, in fact. The company was recommending the higher one, but I don't like that because then it's burning, I think. This is my personal view. So I prefer to vaporize and then finish the job with a microdrill rather than doing a laser stapedotomy. All right, so now I'm using 0.7 millimeter diameter suction tube with my left hand and the laser probe with my right hand. And I'm going to vaporize now the foot plate. Prête? Feu? Feu? In fact, in this case, I need to increase to 1 watt. Okay. I'll try again. I will increase the magnification, so it will be even better maybe for the vision.
Thank you. We have a nice view.
All right, good. Me too. All right. Prête? Feu? Feu? No, it's not strong enough. Feu? So you see, I'm measuring now. I'm trying to understand how it works, the best setting. Feu? And I think it's not good enough. 1,2 encore. So I increase up to 1.2. And I think this will be fine. Prêt? Feu? Yes, that's better. Feu? Feu? So you see the technique? I'm touching the foot plate first, and then I go a little bit away from, and then I shoot. All right, so now I'm going to use the microdrill with, as I said, 0.7 millimeter diamond dust burst, same as for the superstructure. And this usually creates 0.8 millimeter stapedotomy, diameter stapedotomy. So I'm just leaving the diamond dust doing the job by itself. And in fact, if you notice, I'm starting the drilling out before touching the foot plate. That's the way I do, so I can feel the contact with the foot plate. And the way I'm using the sucker is important. I'm not putting in contact with the fenestra, but just a little bit away from the fenestra, because what I want is to avoid making any risk of suction into the labyrinth, having a dry labyrinth.
And what do you do if you have a dry labyrinth? Do you refill the tank?
Of course, we all do that, but I don't think it works.
With what? With what?
Saline solution.
The tank with what?
Saline solution. That's all. But okay. I don't think it works. I don't think it works.
And steroids?
Yeah, of course. After that, I go for steroids. Yeah,
okay.
Sure.
Okay, Robert. So I've obviously not done anything like as many as you, but I've never seen a dry labyrinth.
I've seen cases.
Robert, adjust the light.
Pardon me?
Adjust the light a bit. It's
too bright.
Oh yes, sorry. Thank you.
So yeah, it's rare. It's very rare, dry labyrinth.
Yeah, of course it is very rare, but you can have it. And Denis, what do you do if you have a dry labyrinth? Do you have a different way, or?
I put steroids within the tympanic, intratympanic steroids.
Oh, okay.
Yep.
Okay. All right. So now I'm going to re-increase the light, and I will now introduce the vein.
We see a very nice picture in the depths. We see a little thin layers of bone from the drilling.
Yes.
Are you concerned about that? Do you
No.
leave it, or do you feel that it goes down to the vestibule?
No, I leave it. And especially also, I believe that with the vein graft, it sticks to the vein, and then you can preserve the labyrinth with that. All right. So there's a little bit of a blood there over the vein graft, but I don't want to remove it, but I know exactly where is the Encore l'aspiration. Where is the fenestra? So it's not going to be a problem, I hope, in fact. And now, of course, I need to cut the prosthesis at 4 millimeter. So I use a cutting block, and you see the piston goes into the block like this. And I'm using, as I said, a 0.4 millimeter diameter Teflon prosthesis, Teflon shaft prosthesis. So I hold the loop with my finger, and then I'm going to cut the shaft like this with a knife. And then
Nice.
I use a needle. I use a needle to go through the
Very nice piece
loop.
of micromechanics.
Yes. And then
That's the large loop you're using, the large loop?
Yes, the large loop, yeah.
Robert, show us what you do, because it all seems so easy, but if you do it, you can easily...
Yeah. Okay.
And cut at 4.
Yes. If well, you know, it's a good question. No, but it's a good question. It's a good question. It depends on the cutting block, because the cutting block I have is flat. I show you right after. I put the prosthesis and I explain what I mean. So I'm holding the shaft and I'm breaking the memory like this. Okay? So you don't want to dislocate the loop. So you have to hold the shaft and then just push the loop like this. All right. Donnez-moi le mesure.
From the measurements on that cutting block, it's at least 50 years old.
Yeah, it's very old.
Yeah.
But you see what I mean, Denis? The cutting block is flat. So if I look the hole, if I look for this hole, for example, the 4.25 or 4.5 or 4, it's flat. There's no groove. But some cutting block, they have a groove here.
I have this like you.
Okay, so then you don't have to add or anything, or remove anything. All right, so now I'm going to grab the prosthesis and then introduce the prosthesis with the needle. I'm not sure about the vision. The picture is not that good for this case, but I'm sorry about that.
98% perfect.
Okay, so I'm going to introduce the shaft first, like this, with the sucker. It goes within the fenestra, and then you put the loop around the incus with the needle.
How did you find the fenestra with the prosthesis?
You know where it is. In fact, if you have a real measurement, you cannot have any problem, because you cannot, if you are not located within the fenestra, when you push the piston, it resists, and then you can see the shaft bending too much.
Yeah.
So that's the proof you are not inside. Okay? Aspiration, s'il vous plaît.
And of course, you know where it is.
Yeah.
You retain a short-term memory for maybe 2 or 3 minutes of exactly where it is.
Yes.
If somebody interrupts you and you start talking, you then have problems.
No, it's fine. So now I'm going to close the loop, and you know that I'm using this technique of the 2 hooks. I prefer rather than the cutting block, because I can hold the loop with my left hand and close it with my right hand like this. So it's you use 2 hands, a double force, left, right, and right, left, like this.
Very
and then,
nice. Thank you.
The bending sign.
Try this in the lab, and then you will admire him what he has shown to you.
Yeah. And then the bending sign. Okay, the piston should bend but not move. So you can see it here.
Yeah.
If it's too short, then when you do this, you can see the shaft going away from the other window. It's a basic sign which I learned from Jean-Bernard Causse, and I think it's a really good one. And the mobility from the Malleus is good. All right.
Yeah.
Fine.
Thank you very much.
Thank you.
Congrats.
Questions from the audience? Yes, please.
Hi, it's Andrea from Ireland.
Alicia.
Can you tell us how you keep your instruments sharp? Because in NHS and HSC, it's actually a dream, your instruments. I actually know the answer, but you can tell it for the audience. Thank you.
You know, it's the force of the French system. I'm joking. Of course, I'm joking.
The truth is,
I'm not sure it will be possible to crimp the piston if you use a 0.6, because the loop is harder.
Yes, you're right. I agree.
Need to use the
0.4.
Arigato.
Yeah, that's right.
The secret with the instruments is he has one nurse, and if you go in the theatre, you can see the girls who clean the instruments and prepare them from the theatre. So he knows all the time.
Yeah, I know, John, but it's true that these instruments are very strong.
But ours go to
they are made by Intracom, which is the not Intracom, Integra, which is a French company. Originally, it was Microfrance, bought by Medtronic, and then bought by this new company. Very efficient company, and they are very strong instrument, very resistant.
But our problem, Robert, is our.
No, John, let me finish. When I travel to go to do surgery abroad, I always take my instrument with me, and of course it goes to the central nettoyage. I forget the name now.
Yeah.
And sterilization, and then I cannot know exactly what they are doing, but they take care, of course, of that. And sometimes with some of them, like the needle, they can have some trouble, but the vast majority of the instruments are very resistant.
Yeah.
And if we have something wrong, then we can send it back to the company, and they they work on it. But especially the curette is very efficient.
Can you change the camera, Robert, so we can see you?
Yeah. Caméra, s'il vous plaît. Caméra de champ.
Question.
Well, you're very fortunate, Robert.
A question, please, Robert.
Our instruments go 50 kilometers away and they get destroyed. But I would say you should always buy a new curette once a month if you want to buy one instrument.
Yeah, but once a month is quite expensive, John.
Well, France is a rich country, so.
We were a long time ago.
But I have add a comment and put also some light on the German manufactured instruments from Tuttlingen.
Yeah.
And one of the secrets is, as you said, that you have no central sterilization. But when you buy the instruments, you should be careful. You have different qualities. Some who are made in Pakistan, some who are made in Pakistan and finished in Germany, and then you have them made in Germany as well. So I think with the French instruments, it's the same. It's if it's somehow homemade with the quality guidelines, then it is different from what you see in international conference.
Yeah, maybe
like a flea market where you can buy it. And
but I mean, if you look to the curette, which is a very important instrument, it's true that they are very sharp, and I have never seen such a sharp curette in a different place with other type of instrument, which I tried sometime, and I never saw such a beautiful one.
But there's more questions from the audience, and also we see this nice Eiffel Tower with the specula in front of you.
Yes,
that looks good.
Yeah, well, you know, Céline is very, very good. You know, I must say that she's part of my. We are working together since 30 years, and she knows everything about me, except the private things, and she's extremely good. I mean, you don't have to ask. You saw that. I just move my hand, and she knows exactly what kind of instrument she has to give me, and there's never any problem with that, and that's a magic point. And she's preparing the table before in a very special way. Maybe tomorrow I show you exactly the way she does. And when I go abroad, of course, I have to do it myself. And it happens to me that I call her when I was in Egypt, I think. I call her, or Brazil. I call her because I didn't remember how to play some part of the instrument, and I call her, and she replied, and we did a FaceTime video, and we did it together. So it was very funny, but it's very important.
A question. The metal cells that you put in the ear, how many days do you put there, and after you take away, do you put something else?
I remove on the 5th day, and after that, no, I don't put anything. And the beauty with the fact that I can keep the patient several days is that I can follow them. I can react immediately if they feel some dizzy or imbalance or any other thing. And the second thing, I can check by myself the bone conduction before they leave the clinic. And you know, the majority of my patients are coming far away from here. So I just want to be sure that everything is fine before they leave. And if I have any doubt, then I keep them for 1 or 2 days more to be sure that they will be fine. And that's really interesting. But I don't put anything else except when they leave the clinic, some local antibiotics or fluoxetine. Because when I didn't do that in the past, I had case of patient having experiencing external otitis, which is not a problem. But of course, it's very scary for the patient. So since I knew that, since many years, I use as a routine ofloxacin local, and it works fine, no problem at all.
Robert, what drill do you use?
The drill. I use a diamond dust burr.
No.
Oh, the drill,
What
sorry.
drill?
It's a BNR, the
Okay.
BNR system, the OsseoStap, which is a very nice one. Very
Yep.
stable.
Yep. I agree with you. We used the old one from Medtronic, the skitter, and I guess this one is better because much more stabilization.
The skitter was great, but as soon as you have some little problem, it was starting moving like this, and so it was bad. With this hand piece, it's much more stable. Much more.
Robert, just one question. I mean, you're very fortunate in having patients stay for a week. And we all know that the patients that we worry about are the patients that get trouble round about day 2 to maybe day 5 or 6. In your experience, how many times have you seen a patient, because you've been able to watch them very carefully, beginning to develop a problem and been able to treat it with steroids or whatever?
How often with my patient, you mean?
Yeah.
It's very rare. Really, I don't know. I don't know exactly, but I would say even, I mean, in terms of dizziness, I see my patient all week, and I don't know exactly, but it's something like less than 1%. Really, it's very rare.
Very good.
All right.
Yeah, more questions, please.
I want to ask about routinely prescribing of antibiotics after stapedectomy and corticosteroids. Do you use this or no after surgery, if there isn't during surgery any complication?
Okay. When I came at the clinic, unfortunately, many years ago now. No, I know. Systemic. Yeah. I'm thinking about systemic. We were using a lot of antibiotics perioperatively and post-op. And now since a lot of years now, since many years, I don't use any antibiotic, even before or after surgery. The only thing I use is a single shot of steroids perioperatively. That's it. I think it's something like 120 milligram IV Solimedrol. That's it.
Hello, Mark Quick from Perth, Western Australia.
Yeah.
2 questions. When do you allow your patients to fly? And the second one is, when do you do your formal post-operative audiogram?
The first one?
Or the first one's, when do you allow them to fly?
The allow to fly is 1 month. I ask them not to fly for 1 month. And then for the second question, so as I said, I have a very short-term post-op audiometric test at day 6 to check the bone conduction, to rule out any complications. So this, we cannot count it. And the first real post-op audiometric test is made at 3 months. And then every year for some time, if I can follow them. But the first one is at 3 months. And in fact, I have more than 7,000 primary Stapes surgery. And I have the database in which I put all my data. And it's a good thing because I follow my patients nearly every year for vast majority of them. So it's very nice because you can have a real follow-up over years and you can evaluate the evolution of the bone conduction and air conduction with time.
Robert, you know over the years that our views have changed on scuba diving and pressurized aircraft. Do you allow your patients to scuba dive?
That's another question which is even more important. When we talk about this, I try to tell them, do not scuba dive anymore. I mean, I'm talking about a severe one. But it happens sometimes that they have to, because some of them were professional. And so they wait 1 year and they come back for this. And I never had any problems. So maybe it's fine. But you know the problem is, I don't think it's a higher risk. But the problem is that if there is a accident at minus 30 meters or something like that, I don't know what would happen. So I'm afraid about that. So I ask them not to do it anymore if they can avoid that.
And what about the light aircraft or the helicopter that isn't pressurized?
No, I don't see any problem with that after a few months.
Okay.
Yeah.
Thank you.
Okay. I think you should go to Thibault.
Yeah.
Good morning, sir. Amit from India. I have two questions. If you operate on a patient with chronic otitis media and it's a perforation and you see that the stapes is fixed, would you operate on the same setting or you'll wait for the second setting?
No, I would do in 2 stages. After at least 6 months.
And there's a other question also. There's sometimes obliteration of the oval window. There's a lot of otosclerosis on the oval window near the incus and all that area. So what would you do in such a setting?
When you're obliterative otosclerosis, that your question,
Yeah,
right?
yeah, yes.
Yeah, but it's the same type of technique, which means that I want to make a fenestra, same as for this one, but the way of drilling out the oval window is completely different. I don't want to do a straightforward stapedotomy, but I enlarge, I skeletonize the foot plate progressively, enlarging the drilling and decreasing progressively the whole thickness of the foot plate until I found a kind of a blue line, which is the perennial membrane, and then I open up the membrane. But it takes much more time. The second thing is when you do that, you have to refresh the burr regularly, because if you continue and drill and drill and drill, the risk is to hit the labyrinth. So what I do a few seconds and then I stop. I put the burr into saline solution, fresh saline solution, and back to the foot plate, drilling a little bit more, and then back to the saline solution, step by step, until I feel the blue line.
Thank you.
Okay, I think you should go.
Pay attention. Don't use the laser with an obliterative otosclerosis because you need an energy huge that can boil the labyrinthine liquid.
And it doesn't work, in fact, with obliterative. So
Thank you.
Okay.
Thank you.
Hello, Thibault. Bonjour.
Do you hear me?
Yes, and we see you.
Okay, perfect. So the second case is a Sentio bone conduction implant. We show you the story. Tournée. This is a 61 years old female, and she has also bilateral otosclerosis. She was operated on the left ear in 1992 with a total stapedectomy and a piston from the incus to the oval window. And she had incus erosion and the dislocation of the piston. She was reoperated in 2000. There is no more usable incus and a nociculoplasty with a torp on the oval window with a bad result, and then a new revision surgery with a torp on the oval window with also a bad result. And so we decided to turn to a bone conduction implant. Tournée. You can see on the audiogram that she has a 75 decibel mixed hearing loss with 50 decibel or 60 decibel airborne gap on the left ear, and on the right side she has also otosclerosis but with a mild hearing loss. Tournée. And so this is on this picture the otosclerotic focus on the left ear. Encore. Here the displaced prosthesis, and encore, and the simulation of the Sentio implant with a little well less than millimeter depth. Okay. Sur le pied.
Thank you, Thibault. Why have you chosen the implant and not another trial for prosthesis replacement with a, so to say, classical Malleus vestibule assembly?
Because she had previously a total stapedectomy. That means it is more difficult to have a stable prosthesis than into a stapedotomy. And she had 3 previous surgery, and she don't want to have a new one because of the previous failures. And the alternative, which is a bone conduction implant, the result is, this is the main reason for.
Okay.
Oui, the position of the implant So I elevated the approach up. I elevated the pocket antenna of the implant, and the vibrator of the implant. Up. Voilà. But the thickness of the vibrator for the implantation.
How deep do you have to drill? I haven't never done such a surgery, and I'm maybe not going to do one in the future because I'm old. Why?
Mouché.
Yeah, Manuel has a question.
So I have to keep quite.
Anyway, just more of a comment. I like the Sentio, but something for people to keep in mind is the Sentio is only approved for 1.5 Tesla magnet for MRI as opposed to the osseous. So the problem we have sometimes is less and less 1.5 Tesla machines being put in around the world. So it's sometimes hard to find one that's only 1.5 Tesla. No, you can't. It's actually electromagnetic. No, so it's not like the others. Yeah. They're working on the new version, but not yet.
They've thrown me the microphone, and I presume because the explanation is that the osseous system, which is the cochlear active transcutaneous bone-anchored hearing aid, is a piezoelectric transduction mechanism, which does allow better MRI compatibility. And also, in theory, it provides better high-frequency sound transduction as well. So it can be used for perhaps a slightly higher level of sensorineural hearing loss than the Sentio or the bone bridge. But otherwise, they're all fairly similar and I think very effective for bone conduction losses.
Well, I think the problems with the artifact in the magnet for the transmitter coil and the speech processor is an issue in all devices, and you have to discuss this prior to the patient. Well, there's a paper out from one of our younger doctors, Sarah Traut. When you do MRI control, you can use a dummy implant and determine the position, just in case you want to control any neural structures, and then you do a MRI with a dummy device, and then you're sure that after placing the implant you can control for whatever vestibular schwannoma or intracranial lesions, if there are to be controlled, like MS or whatever.
So the diameter is still a little bit up.
You can nicely see how in the lower edges Thibaut is carving the hole, and that makes the fitting easier for all the devices that have been mentioned and shown so far.
As
It looks not too bad so far.
Yes,
but
not perfect, but very close. Up. Des problèmes de son?
Thibaut,
Yes.
just on the idea of the Sentio, their structure is a little bit different in the bone bridge in that their transduction is through the base of the implant,
Yes.
not through the screws.
Yes.
So how much of that plate do you still need? I mean, we see if you're going to do it in a patient with a very thin bone, if you're going directly onto dura or something, then you're going to struggle with this implant where the bone bridge, the sound is transmitted through the screws. With this, it's transmitted through the base. Is that correct?
The principle or what say Oticon is that the transmission is made by the vibrator itself, not by the screw with the band. But I think there is also transmission by the screw through the bands. But I cannot say you what is the proportion between both. Alors, faites voir le.
If the transmission is not through the screws, can you put it without screws inside and just fix it through the muscle or the periosteum? Has anybody done this?
I have the experience not with the Sentio, but with the ossia to implant the ossia without anchor, without intraosseous implant, without the Baha implant, just the ossia in a superior sterile pocket. It works very well. So I check if the bottom is flat, and I think there it is okay. So the well for the implant is okay. You see that the dummy is approximately at the level of the cortical, and so that will be okay. And you see it's a large diameter, but little depth well. On va prendre l'implant. Comment? Oui. I have to make a slope for the neck of the implant. So I try Farbeuf. With the dummy, I will put the dummy of the antenna into the superior sterile pocket. Up. To see where I have to perform the slope for the neck of the implant. Okay, Scottman. Hop. Presse. So the idea is that there is no sharp angle for the for the neck of the implant. Voilà. Diamanté, même taille. And we will take the implant. Alors, vous donnez l'implant. L'heure là des... Hop. So we change the gloves and we'll take the implant. So, I will show you the implant. So this is the Sentio implant by Otology. The design is very good. It is a smaller of the bone conduction implants. In terms of direction from this part to this one, dimension from this part to this one, it is a smaller one. And it is a thinner one. You can see that the vibrator is quite thin. The diameter of the antenna is a little bit larger than the antenna of the bone bridge. And the vibrator has to be fixed with a fixation band that you will see. Tenez le pavillon. Donnez-moi un phare à bœuf. So I will introduce the antenna into the superior cell pocket and the vibrator into the well. Écarteur. Alors, pince râteau.
The other advantage of the Sentio is that the processor on the outside is quite a bit lighter than the ossea or the bone bridge processors. So if you have somebody with thick skin, we found it stays on a bit better because it's just so light.
Bistouri lame 15. So I clean the bone.
Yeah, I think Manoa, this is a good point. That it's what we have seen with some of the behind the ear button processors. If they are too heavy, then they have skin irritations and.
Okay, and now I have to fix the vibrator of the implant with a fixation band. As the implant is in a well, I will use the 39mm fixation band and pince râteau. The band has to be on that part of the vibrator, not on this one. So I will fix a first screw inferiorly. Pince, I have to make bistouri lame 15 to prepare the bone a little bit more. Voilà. And there is a self-tapping screw.
Thibaut.
Yes.
Denis. The band is made in steel. C'est du métal.
It is titanium, I think, covered by silicone.
Okay. And flexible, of course.
Yes.
Yep.
It reminds us a little bit to the repair of mid-phase fractures.
Bon, hop, alors.
And now the device will be placed by maxillofacial surgeons in the future.
And now.
Oh, you don't fix in the muscle.
Please?
Tu le fixes pas dans le muscle.
No. And
Great.
so now I have to ensure that the vibrator is well in his well. That's okay.
Yeah.
And now place the second screw.
It's a self-cutting screw, I guess.
C'est un tournevis autostatique, enfin qui marche tout seul.
Yes, on a self-tapping screw.
Will the band adjust to the shape of the implant later on, or is just a straight coverage?
No. It adapts to the shape of the implant. You can see it that there is a curve, and the band curves to shape to fit to the shape of the implant. And if I just put.
Oh, we cannot hear you. Sorry.
On t'entend plus, Thibaut.
Alors.
Je crois qu'on t'entend là. On t'entend plus.
If I do a well for the vibrator of the implant, then I use the 39 millimeter band to fix the vibrator, and you see it's very firmly fixed.
Yes.
If I just put the vibrator on the cortical without a well, then I need a longer band, and there is a 45 millimeter band in that case. And you can see, you can bend it, and it has form memory given to the metallic part of the band.
Very nice. Thank you.
That's okay. I have just to close now, and I think you will have a lunch.
Thibaut, one word for the skin incision and the subcutaneous layers. Do you create special flaps to avoid contact between the implant and the skin incision, or?
No, I go directly in one incision directly to the bone, and I close in 2 layers, the periosteum and the muscle, and after the skin. But they are in only one incision. I do not create a skin flap and a periosteal flap with a different shape.
Okay, thank you. Questions to Thibaut?
Oui.
Yeah.
When do you activate? This is a question. When do you activate the device?
3 weeks post-op.
And sutures will remain 1 week?
No, the patient will leave the clinic tomorrow.
Yeah.
And without external dressing, the suture will be made by absorbable suture, intradermic absorbable suture,
Okay.
so there is no stitch to remove. And a nurse will clean the scar and check that there is no infection or hematoma during 5 days after the surgery at the house of the patient.
Ah, okay.
Did you perform in 1-day surgery and under local anesthesia?
Please,
Sometimes.
I did not understand.
Est-ce que tu fais en ambulatoire et sous local?
Alors, le micro est tellement mauvais que je ne comprends pas, même en français. Alors, est-ce que je fais
sous local, sous
Non.
anesthésie locale et
Alors.
en ambulatoire?
Non, uniquement sous anesthésie générale jusqu'à présent.
Why?
I do it under general anesthesia for bone conduction implants at the.
But do you think it's possible?
I think it's possible to,
Okay.
under local anesthesia, but you have a quite long drilling of the skull, and I think it's not a pleasant experience for the patient, and it's more comfortable for them and for you under general anesthesia.
Okay.
But in the early days, we did mastectomy and sac surgery also under local.
Yes, you
So
can.
we have to educate the patients.
Yes, the question is if it will be for yourself, do you prefer general or local? I think I would prefer general anesthesia.
I would prefer
for myself.
Who would prefer local anesthesia for a bone bridge on himself, and who would prefer general anesthesia? Who is for local if surgery would be performed on you? 1, 2, 3, 4. Who is for general? Okay, so the majority of the audience is with you. They prefer general anesthesia. I still fear the anesthesiologist and being.
Okay,
being
but
away.
what prefer the patient? You don't know.
No.
If you don't try, we. Maria Pia, please give us the experience of the department under local anesthesia.
Experience of what under local?
Hi, I'm Maria Pia from Paris. We do put the bone anchoring devices under local anesthesia with some extra sedation performed by the anesthesiologist, and patients are really comfortable. They are sleeping during the surgery, so they are not complaining of any pain.
But you
It's quite
speak
good.
about bone anchored hearing aids,
Yeah,
not bone conduction implant.
I wanted to say also the bone bridged and the osia, we put
Yes,
them under local and sedation.
In that case, the key point is that supplementary sedation that gives the anesthesiologist. If you perform a neuroleptic analgesia, yes, you can do it under. I would do it for me under neuroleptic analgesia because with neuroleptic analgesia, patients sleep really, but pure bone bridge and pure local anesthesia.
No, pure local?
No.
No, but it's true that with sedation, the patient is really comfortable and you don't have to do any intubation.
Yes,
so
yes.
It's,
It depends of the sedation. I have some memories of my old practice of parotidectomy under neuroleptic analgesia. So you can
And
do
there
some
are
things like that. But
anesthesiologists are also receiving new drugs that are really powerful with lesser side effects. So that's something new that we are doing.
I think there is a big pressure of the health betadine authorities, namely, especially, to push outpatient procedure, local anesthesia, etc., etc. For part of the cases, it's a real benefit for the patient. For part of the cases, I am not sure. It's a real benefit for the hospitals, for instance, but for the patient, perhaps not always. So we have to deal with that.
Just as a comment, it's Diane Lazare from Monaco. Just to discuss with the patient nowadays, considering a general anesthesia, it is as risky as taking a plane.
Alors,
As risky as?
Taking a plane, a flight. So when you have to discuss with your patient to give the pros and cons of local anesthesia or general anesthesia, no, general anesthesia is considered as dangerous as taking a plane. So do you take the same considerations when you take a plane? That's just a comment.
We will ask, and Chris, when he's
For how
maybe
long?
arriving,
The
what
drive,
he thinks
the
about
plane?
taking a plane.
Well, a transatlantic plane, for example.
Do you think with twilight anesthesia, which is what I think you're talking about, there's any risk to the airway? Because we're not talking about local anesthesia, we're talking about twilight anesthesia, which is very different.
Of course, there's a risk to the airway, and it all depends on how well it's managed and the level of sedation. And that's what they put a Goodell airway in for. A laryngeal mask is a more sophisticated Goodell airway, and the safest way to control the airway was with intubation.
But as you know, I've used laryngeal masks since 1991 without a problem, but only with one anaesthetist, the one I'm used to working with. And that doesn't really apply in most of our departments. You could end up with any anaesthetist.
John said it's time for lunch. So if there are no more urgent questions, we go for lunch. Row 1, 3, 7, and 11 first, and then 2, 6. Thibaut, thank you.
Thank you to you.
the shaft is in Teflon, and the loop here is in nitinol that you can crimp with the laser. It's easier. Remember, if you use head creeping, heat creeping piston in nitinol, ask to the patient if they are not allergic to nickel. Okay? Because it's in nickel. Well, to conclude, the narrow valve window niche and other delicate intraoperative situations are not so rare and sometimes frequent, particularly when you starting this surgery. The preoperative evaluation with imaging can help you, and you need to know all the techniques of Stapes surgery, not only one. Not only one. You are able to change to, I don't know, interposition, total stapedectomy, and so on. And that's why I thank you. If you have questions. Yep.
Thank you. My question is, are you routinely providing CT scan in the cases of bilateral otosclerosis before surgery?
We perform always. CT scan before any Stapes surgery. Any Stapes surgery. Primary revision, of course, but the CT scan for us is mandatory. And in France, I think all the surgeons perform CT scan before doing Stapes surgery in all the cases.
And thank you very much. And second question is, in the cases of malleovestibular stapedectomy, do you use cartilage for tympanic membrane reinforcement or perichondrium? What do you use?
It depends. It could be perichondrium or thin cartilage.
Thank you.
Not too thick.
Okay.
Not too thick.
Thank you very much.
Yep.
Thank you very much, sir. For the facial nerve overhanging, we have one case of that, and we try to do the same as you did. But the patient post-operative has a facial twitches all the time.
I never thought that.
And we have to remove the prosthesis because, you know,
this is the first time I heard this, because we already speak with a lot of experts. And when the piston touch the facial nerve, usually it doesn't, I never saw that. And I perform a lot. It can reduce your results because the piston doesn't move as if it doesn't touch the nerve, but we never saw any facial problem with that. And of course, if the patient had that, I will have take off the piston. Yep.
Okay, we're going to move on with the next presenter. I think it's, oh, wait.
I do agree with you. I had.
But are you talking to me?
Cases like
are you talking to me with this
I'm
chart?
talking to you.
Okay.
And so yes, it's true. I've seen cases where the prosthesis was connected to the facial nerve, and I never saw any problem with that. Even with titanium, Teflon, or any
Never.
other. Yeah.
With titanium, I already see the piston embedded in the nerve. So it's a problem if you have to revise it here. But I never saw any facial pulsing or facial synkinesis or so on.
It's also true that the Parisian are stronger than the Marseillais. So
of course, of course.
Thank you, Denis.
Thanks.
Our next speaker is Jochen Muller. I know Rob's going to introduce him. Robert.
So pleasure again to introduce Joachim, who is at the head of the Otology department in Munich and is very well known in the field of middle ear reconstructive surgery, did a lot of work. And we're also working together in a future publication about a series of more than 6,000 primary otosclerosis. So it will be, I hope, ready at the end of the year. So we work together since some years now, and I really love his work. He's very accurate, very scientific, and I think it's going to be, it is important to have him in the group. So he's also part of a permanent faculty. And I'm just thinking about the Parisian, I'm not sure anymore.
So, good afternoon. Thank you. I apologize for not having a Bayern Munich t-shirt with me, but I'll entertain you with some thoughts on revision Stapes surgery. This has been addressed in the morning session quite frequently, and we have seen a wonderful surgery about that. That gives also food for discussion, and I hope I can motivate you to participate in that. I have no disclosures. And when it comes to revisions, that is something that everybody sees, but these patients are always coming from alio loco. That's what the people say. This is not my patient, he's from alio loco. The question is, where is alio loco? Thanks to the Spanish friends, I found out that Alio is a little town north of Barcelona, so that's where the patients come from. One of the problems for revision surgery is that we will fix the prosthesis, and that remains a challenge. There are different prostheses in the market. Wilco has shown a nice collection of what we can find. If you are a friend of crimping, then of course crimping needs some attention, and it's not only the prosthesis, it's also the procedure and the instruments you are using. We have seen in the morning the two-hook technique, which is extremely difficult, and you need good hands to perform that. So, as we said, try it in the temporal bone lab. You will find out, or you take a forceps, and one of these forceps we modified that it will go around the incus, and the upper lip will close the prosthesis around the incus, and then you can loop it around. When it comes to revision Stapes surgery, it is said that the risk of deafness after Stapes revision is estimated to be 10 times higher than after primary stapedectomy. Hearing improvement is said to have significantly lower chances. That's a saying from Hugo Fisch. And it is, according to Shi, successful in only around 50% of the patient with a hearing improvement. So it is considered to be more demanding than primary intervention, and it's somehow challenging. To give you our results at the beginning, so 80% of our patients reported improved hearing, and I will explain you why is this different to the data of Shi, for example. Well, Stapes surgery is always done in the morning. It starts with a good espresso, because the poor pleasure is inside. You never know what you will find. Did you have had your espresso in the morning, Robert? No. Good. He has also the espresso. Good. And the surprise is inside. It's like a surprise egg. For those who want to go back to the US, you're not allowed to take Kinder surprise eggs to the US. There's a penalty up to $2,500 per egg if you bring it to the US. If you go to Canada, you can bring it back for your children, no problem. Well, what we found in revision Stapes surgery, a failed incus reconstruction with hydroxyapatite cement. The prosthesis was fixed, but the mobility occurred between the remnant of the incus and the cement. It's also an issue that was discussed in the morning in the group. We have seen improper fixations. We have seen incus erosion at various degrees after clip prosthesis, as well as after platinum wire, Teflon, or titanium band prosthesis. The most frequent erosions we have seen after wire prosthesis, because the wire cuts somehow through the incus. When the band was introduced, these findings became more rare. And also what we have seen is a retraction pocket in the posterior part of the tympanic membrane if you over-remove the scutum, as it was discussed in the morning while Robert performed the surgery taking away the lateral attic wall. If you take away too much, the tympanic membrane can retract and can also cause incus erosion. A penetration from medial to lateral is, in my opinion, a combination of two factors. One is reossification of the footplate. However, you can discuss whether it was never properly opened. As you see in this right picture, the 4.5 prosthesis, which is our standard, did not reach the vestibule. So this obviously was, the prosthesis was too short. It stood on the footplate, and then the prosthesis migrated through the handle of the malleus. And it's scar tissue around the prosthesis that draws it outside. If the incus is missing, one of the options you have seen in the morning, a torp onto a oval footplate. The other one is a malleus vestibule assembly with a titanium prosthesis where you fix it similar to what you do with the prosthesis to the incus, but on the middle of the handle of the malleus, and then you can shrink it. The titanium prostheses are more difficult to shrink compared to the platinum band prosthesis because they are a little bit stiffer. And you also see that working with two hooks bears the challenges, and then in the end the prosthesis slips nicely into the hole and the prosthesis moves properly. Malleus head fixation, which has been overlooked by the previous surgeon, is an option. Depending on the degree and where you find it, you have to remove it. You can drill it out or just remove it with the hooks and insert a normal prosthesis. Also, new bone formation in between the ossicles has been found, and another finding was fistulas at the oval window. They are usually associated with vertigo at various aspects in the oval niche, especially in the area under the facial nerve. And while doing the surgery, we pay attention to close this area with soft tissue. If you put the vein graft, as you have seen in the morning, you don't have this problem so much. Also, fistula occur at the carbonization edge of a laser stapedotomy, which does not close properly. More frequent finding is this associated with this prosthesis from Italy. Apologize for Italian colleagues. Audio technologies is something that we would not recommend because in several cases we found a jealous phase in between the prosthesis and the soft tissue. That was not scar, but it was not liquid. It's something in between, and there the fistula occurred, and that becomes clear because the part of the prosthesis is porous polyethylene, and this is, to our experience, not the ideal material for the middle ear. Well, dislocated prosthesis can be detected with a CT scan prior to surgery, and if it's moving down far in the vestibule, the reason often is scar tissue around the neck of the prosthesis, which moves the prosthesis inside through the incus and medializes the prosthesis. Again, if the prosthesis is the footplate is closed, the question is, was it ever opened or not? But anyway, you create a new hole and then you will end up good. If malleus is eroded after malleovestibulopexy and the incus is missing on no footplate, another option would be to free the oval niche, put a VSB into the oval niche, wrap it around with soft tissue. That would also, for Thibaut's case, a situation we discussed it at lunchtime, to be an option versus bone conduction implant if the VSB is registered in your country, and this gives good, nice results. Well, again, this situation can be covered and combined with a pore prosthesis on top of the VSB. If you want to look that up, there is a paper recently coming out with this technique. What you also observed, surprisingly, is years and months after surgery, a progressive hearing loss with deafness, and this also after stapedectomy in a long-term run can be associated with ossification inside, and there the cochlear implant, sometimes with drilling out, is the option, and in this case we succeeded to insert a 30 millimeter standard electrode despite the ossification. The most difficult situation you can face is if you have to revise an old steel wire tissue prosthesis, because this gives scar tissue in the oval niche and may cause vertigo when removing it. So we have seen a number of entities. We have one more left, and this is immediate revision surgery after stapedectomy within 2 or 3 days, which is usually due to a foreign body granuloma. This case had experienced inner ear depression and vertigo, underwent a revision, the prosthesis was left in place. 2 weeks later, the same appeared, the ear became deaf, the vertigo were persistent, and what we found was a big foreign body granuloma. So once we face inner ear depression and vertigo in the first days after surgery, we would go in, take out the prosthesis, wait another 6 to 12 months, and then place the second prosthesis again. In our series, in 50%, we could reconstruct the hearing with a standard length prosthesis. In 32%, we used a customized L. This is a 5.5 millimeter prosthesis, which was adjusted to the adjacent length. And in only 3%, we used Malleus vestibulopexy. So again, the mean airborne gap was 12 dB compared to 8.6 dB with the primary interventions, and 85% of the patients reported a better hearing. The results compare nicely with a large series Robert has published years ago, and it also is in the same range like the series of my teacher Jan Helms, which was published a few years earlier. In contrast to him, we included 4 kilohertz to give you an idea, and this explains the variation in the distribution function compared with his data. What Karyem Sharef found out when he analyzed the data and published the 3 papers that I mentioned in the beginning is that all patients who had not a successful surgery had prior to surgery a airborne gap of less than 20 dB. These data are fine for audiological reasons. If you consider a revision Stapes surgery, RINE C2 and T3 should be negative, and then you're on the safer side than doing revisions with less airborne gaps. In advanced otosclerosis, if you have inner ear hearing loss, the power Stapes is a valuable option. It was first described by Thibaut Dimond in the early 90s, and it's my pleasure to remind this invention, which came from the Causse clinic, and enrich the portfolio. And of course, if the speech understanding is not good, also a primary cochlear implant is an option, even with deep insertion, inserting into the second turn. And for those who deal with ossified cochleas, apical cochleostomy from Montadon should be brought to your attention to insert the electrode upside down, which you can do if the implant is capable of being programmed vice versa. And this is also a nice solution for these patients. So in principle, Stapes revision can lead to favorable results. Our generation is in a favored situation because the piston prostheses are more easy to revise than the wire prostheses were in the earlier days. This explained the difference in the data compared to Xi when he used the wire prosthesis. A substantial number of patients enjoyed improved hearing. An airborne gap of 11 dB is not too bad, is RINA negative for the majority of the patient. Risk of a deaf ear was about 1%, and there was one selection bias that was an experienced surgeon, and there's no doubt to make the indication for revision surgery, knowing that we have a cochlear implant in the background if we fail, makes it much more easier than for the generation of our teacher to operate on the last hearing ear. And with that, I would like to thank you for your listening. I want to point out we just came from Rostock. The next otosclerosis meeting will be in Argentina in April 2027. So that might be of interest for you. And if you have interest in more courses, look at the webpage from the Munich clinic. And I do hope that we not only can compete with the knowledge, but also with the hospitality that we receive from you. And I'm open for questions.
Hello.
Yeah.
So well, very, very nice presentation. I always found it interesting because the literature that talks about revision Stapes surgery is like a wastebasket of a lot of different operations.
Yeah.
And so when you put them all together, it's sometimes hard to know whether you should or shouldn't be operating because you can't really use the literature for each individual case. So the case that you showed where there was a prosthesis basically touching the saccule, it was so deep. Were you able to preserve hearing in a case like that?
Yes. We had in the data I've showed for the slides and the pictures I've taken from that was the first 48 patients, and we had no deaf ear. We had two subsequent papers with 96 and 160 papers, but in the second paper we experienced a deaf ear afterwards.
So what would your technique be to take out that prosthesis that's so deep? Are you using a laser or
No,
how do you take it
manual,
out?
no laser, no skeeter, just the hooks, and I would separate the soft tissue with a 45-degree hook down to the footplate in the anterior part, then go around the prosthesis and then carefully remove it. But first, as you do in a cochlear implant when you do a revision, dissect the scar tissue around the prosthesis so that if you have a little sleeve inside, you can take the prosthesis out of the sleeve and do not rupture and pull out the sleeve inside. But this is with a piston, it works nicely. But if you have a wire prosthesis, the scar tissue, that's a completely different situation, and this may explain the rate of not successful surgeries and a higher rate of deafness. I can hear him.
No,
he speaks pretty good English.
You mentioned if you have the older wire prosthesis.
Yeah.
Do you think there's a difference in pulling out a titanium prosthesis from a Teflon prosthesis?
No.
You don't.
I don't think that's.
I like to disagree.
Good.
Well, it's such. I absolutely think that the Teflon is the easiest prosthesis to remove, with the least adhesions and no scar tissue at all. With titanium, which I used to use, they could attach quite severely. Let's ask the French guy. Do you want to? I'll wait.
No, I agree with the difference between the Teflon prosthesis and the wire prosthesis. This is really much more difficult. But it happens sometimes that you need to remove it because of the dizziness that the patient has with fluctuating hearing loss and also the fistula sign. But I agree. It's
but
a
there are two more aspects if it comes to the titanium prosthesis, and if you have to go in for vertigo, is this short time after surgery. Then we have no scar tissue, and it also matters if you have a 0.6 prosthesis. If you do a stapedotomy, and the diameter of the hole plays a role. Huber has pointed that out from Zurich, that you have the shrinking effect that also you showed in your presentation, may pro-roll and may also go for ossification at the titanium prosthesis. What we do in the primary surgery is a partial platinectomy according to Plester. So we take out the posterior part of the foot plate and place the prosthesis in the posterior part, and there we have more space, and we pack it with a big piece of soft tissue in the anterior part, so really place the prosthesis backwards away from saccule and utricle. But I think it's, yeah, please.
Hi, Joe Magnali from London. Perhaps two changes in the next generation are that we've got now a more acceptable range of bone conduction implants available, and also our learning curves are much more in the public eye. You know, the patients go online and share their stories. So do you think that will perhaps lead to a reduction in the number of people or number of revision cases being taken on? And does that have implications for training and whether this operation will continue to happen?
Well, I mean, this is also a question of experience in Stapes surgery. What we see is that the number of centers in Germany who perform Stapes surgery is reduced. There are only a few centers who have a sufficient amount of Stapes surgery to have good results and consistent education. In terms of revision, we offer the patient the option of a hearing aid and a bone conduction implant, and we discuss it. We have data that the quality of a hearing aid compared to a revision Stapes surgery is much better than compared to the hearing aid. We have not these data for a large number of patients who has chosen a bone conduction implant versus a stapedectomy. But I would see that's more medical legal aspect, that you inform the patient about this opportunity and give them the choice. But working in a center who has a lot of stapes and revision surgeries, our preference would be the revision surgery. If I do one revision surgery a year, I would probably think about the bone conduction implant.
You know, Joachim, though, the problem is you go through all of the varieties of treatments with the patient,
yeah,
and what they say at the end is, what would you do, Dr. Muller?
Good.
And that's the problem. You can document everything, but at the end of the day, the patient wants
they
you
ask you,
to tell you. Yeah.
Okay. Well, to answer this, John, I would go for revision Stapes surgery with one of my colleagues that I have educated.
So my pleasure now is to introduce Neil Sperling. We met a long time ago in New York, and since then we became really good friends. He's the only American who is who can enter France now since a few months.
Back though.
And I'm not sure we'll be able to come back. That's the problem. But anyway, he's a very nice man and very nice surgeon, very bright person also, and I'm sure you will enjoy his presentation. Please do not hesitate to ask any questions. An open mind discussion for you too.
I think, yeah, this is good. Thank you. Is the microphone okay? Could you hear me in the back? Did I wake up the front row? No. Okay, so how about now? Hello? Yeah. A subset of our patients that present to us for Stapes surgery also have a semicircular canal dehiscence, and that can go unrecognized, possibly, but it's not an insignificant number. We're seeing it more and more. and it could have a significant impact on the outcome of the Stapes surgery. And I think there's some discussion going on, and I know, at least in my circles, people don't really know yet how to handle this situation. So I think it's an important one for us to look at. No financial disclosures. One other disclosure. So both of these entities are visible on a CT scan. Otosclerosis is highly specific on a CT scan. It's not always visible on a CT scan, but if you see it, it's a very highly specific test. Semicircular canal dehiscence is also visible frequently on a CT scan, but it has a very high sensitivity. You'll see it almost all the time, but it doesn't always correlate with symptoms or the syndrome that's associated with it. The postural view is probably the best view to see the semicircular canal dehiscence for the superior canal. And as I mentioned, not every superior semicircular canal dehiscence found on an image is going to result in symptoms. But if we just talk about the syndrome, the superior semicircular canal dehiscence syndrome, it has a very specific set of symptoms which helps you identify it, such as autophony, sound-induced vertigo, pulsatile tinnitus, bone conduction hyperacusis, so you can see bone lines that are better than 0 decibels on an audiogram, and in general, hearing loss. This was first described in 1998, Lloyd Minor at Johns Hopkins, and the reason why these symptoms occur has to do with the third window phenomenon, where the sound energy is being displaced or rerouted to the fistula at the top of the semicircular canal, and that decreases the sound energy that's being transmitted to the cochlea. Now, if you have Stapes fixation, you could have a semicircular canal dehiscence that is masked. Essentially, you have an immobile third window. And so this situation is such that you can present, the patient can present with what looks like otosclerosis with hearing loss, and there'll be no clinical indicator that there's a semicircular canal dehiscence also present. So, absent vestibular symptoms, exaggerated air conduction loss, and possibly exaggerated bone conduction. I don't think that's spelled right. Anyway. So let me show you an example. This is a patient who was referred to me. Thankfully, it wasn't the patient I operated on, but she was operated on by a skillful ear surgeon who, this was her preoperative audiogram, and this was her postoperative audiogram. She had what was reported as a routine Stapes operation. She ended up absolutely miserable. She was miserable. Severe autophony, tinnitus, strange sounds that she described in her ear. And so this was a disaster. You don't want to have an outcome like this from a routine Stapes operation. CT scan was done after, and a large semicircular canal dehiscence was identified. So we know that superior semicircular canal dehiscence can look like otosclerosis. So it's certainly a concern that you may misdiagnose someone as otosclerosis, and if you're not certain in the operating room that there's fixation or not, you may go ahead and do the Stapes operation and end up with a pretty bad result. So over the past several years, it's become very important for us to carefully consider whether semicircular canal dehiscence is the cause of the hearing loss that we're looking at. And it can be difficult. I think that the hearing loss may look the same in both conditions. The most important difference that you may find is that there's acoustic reflexes present in a semicircular canal dehiscence situation, whereas in otosclerosis you should have an absence of the acoustic reflex. And similarly, VEMP testing is a pretty specific way to identify semicircular canal dehiscence and to differentiate it. The problem is, what happens if they're both present? If they're both present, this patient may present to you in a very similar fashion to an otosclerosis patient, without vertigo, without autophony, without pulsatile tinnitus, and the acoustic reflex may be absent, so that's not going to help you, and the VEMP may be absent. And so again, this patient could present to you with both conditions without you being aware of it. This was one of the earliest reports which indicated that a patient who came in for a routine Stapes operation ended up with pretty bad symptoms post-op and had a CT scan done post-op, which showed evidence of a semicircular canal dehiscence. And so this was an early report, but there were several reports after that which again, confirm the fact that you could end up with a bad outcome if you are operating on a patient with semicircular canal dehiscence. This is not really that rare. This study looked at CT scans of patients with fenestral otosclerosis. 8.3% of them also had possible or definitive semicircular canal dehiscence. So it's not insignificant if you're doing a lot of Stapes surgery, or even not a lot of Stapes surgery. You want to know if there's a way for us to know this, you should know it. Now, obviously a CT scan preoperative is going to help you, but not everyone does that. In fact, maybe by a show of hands, how many people do preoperative CT scan when they do otosclerosis surgery? How many do not do a preoperative CT scan? Good. I would say that in the US, sometimes. Yeah, a lot of people have started to. In the US, I think the most experienced Stapes surgeons don't do preoperative CT scans. They don't. And I think they probably should, or at least they may be changing their minds. This is one of the earlier reports. This is from Mass Eye and Ear. It's actually 2020, not that long ago. And they reported on pretty bad outcomes in their Stapes operations when their patients also had semicircular canal dehiscence. And so they said that 4 out of 8, 50% of their patients who had both conditions had unmasked semicircular canal dehiscence symptoms. And they went on to make these sort of recommendations that this is not someone you should operate on, basically is what they're saying. But there is a problem with these reports, and this one in particular. None of these patients had preoperative CT imaging, and 2 out of the 4 of them were referred patients to them after they had a failed Stapes surgery. And so what you're actually seeing is patients are being worked up after the fact. They have a bad outcome, then they have a CT scan, and everyone is blaming the semicircular canal dehiscence for the bad outcome. And I believe that that's a myth. You still awake, Wilco? Good. Pretty much any cause of a failure is going to have a very similar set of symptoms. And so if you do post-operative imaging and you find a semicircular canal dehiscence, that is absolutely, that's retrospective information, and you're almost certainly overestimating what's happening. This is pre-selecting only the bad outcomes to figure out, whether it was semicircular canal dehiscence. So a failed surgery, a CT scan, then you find the semicircular canal dehiscence is most likely not a good way to really estimate the risk of this. What you would have to do is see what the outcome of patients who had preoperative knowledge of a semicircular canal dehiscence. You want the whole group of people with both conditions, and then you want to see what the outcomes are. And so this is what it should look like. CT scan imaging, identification of both indications and both pathologies, and then see what the success or failure rate is. And that's what I did. I have a series of patients that I looked back about 5 years of my experience and found 10 patients who I operated on who had both conditions. So that's 3.7% of my patients, 8 of them primary Stapes, 2 of them revision Stapes. And I also looked at these other patients who had, they were in my practice they were referred for Stapes surgery, and I advised against their surgery, and I'll explain to you why. And then there were 2 additional cases that were referred to me after a failure, and they were found postoperatively to have semicircular canal dehiscence. I'll get to that. So these are the 10 patients that I operated on. 8 of them were primary Stapes surgeries, 2 of them were revisions. We looked at various factors, including acoustic reflexes, Carhart notch, audiometric findings, CVEMP, which we didn't do on everybody, but when we did, we reported that. And the fact that actually none of these patients had semicircular canal dehiscence unmasked. So there was no of those disastrous outcomes. These are the primary surgeries. There were 8 patients, and these are their outcomes. They had, on average, a gain of 27.6 decibels air conduction. The air-bone gap improved by an average of 21 decibels, but not really great result. I mean, these are good results, but these are not as high a result as we would expect. 75% less than 10 dB. Only, not even 100% at 20 dB. So this is a little bit lower than what we would expect. This is an example of a case that I did. Very standard otosclerosis presentation. CT scan showed semicircular canal dehiscence. She had no symptoms of semicircular canal dehiscence. So we did a routine Stapes surgery, and she had a good result, not a great result. She didn't close her air bone gap. 2 cases of revisions. Now these 2 were done, both the primary surgeries were done by me more than 10 years earlier. They had good results for at least 10 years. And this is their outcome from revisions. They both, by the way, had semicircular canal dehiscence in both sides, as you can see. They had otosclerosis. One of them was unilateral, one of them was bilateral. But they both had semicircular canal dehiscence on preoperative imaging. And their results were not really that good. I mean, not bad, but not good. We didn't lose any hearing, but we didn't gain. And I want to show you an example of one because, of course, as I said before, there's a lot of reasons for not getting good outcomes, but sometimes you feel like you think you know what's really happening. And so this is a patient who had left a Stapes surgery by me in 2003. It was a bucket handle prosthesis, had good results for 10 years, and then developed a slowly progressive hearing loss. So this is what her hearing looked like over the past 10 years or so. She was bothered by the fullness. She was bothered by the hearing loss. Her CT showed a prosthesis that was possibly medially displaced a bit. I was also concerned about possible separation at the incus. This is a titanium prosthesis, so it's quite visible, although the details are not that great. Semicircular canal dehiscence. And this is what it looks like. This is a bucket handle prosthesis that is simply displaced from the distal end of the incus. And so it's just a straightforward, there was no erosion, it was just displaced. And so it felt like a very straightforward problem to solve. I used something called the Bartell's bucket prosthesis, which is a bucket handle, but it also has these tons that are, they're crimpable. And so for me, it's an improvement in the bucket handle design because you can really crimp it in place. And I thought, this is a sure win. I mean, there's no question that this is solving the problem that I needed to solve, and not a good result. And again, so for me, this is because of the semicircular canal dehiscence, which is limiting the success of this operation. Now, there were 6 patients that I advised against Stapes surgery, and I want to talk to you a little bit about what the thought process was, because this has helped me come up with sort of a strategy of how to deal with these patients going forward. We looked at pretty much the same features, although I did VEMP testing on almost all of these, and I'm going to be doing VEMP testing on everyone going forward. CVEMP. This is how they presented. They all had hearing loss that could potentially be otosclerosis. They all had preoperative CT. One of them had sound-induced vestibular symptoms, so that was easy. No surgery for you. No question that I would not operate on a patient with sound-induced vestibular symptoms. The other patients were advised against surgery for a combination of factors. One being acoustic reflex presence, but I wouldn't use that as an absolute contraindication. The absence of CT otosclerosis in combination with the presence of an acoustic reflex for me is a good reason to say no. This is not a good patient to operate on. There was one patient, I want to just point this one out, number 4, who had the only thing working against her was this normal VEMP test. And I don't know how familiar you are with VEMP testing, but VEMP testing, which is a vestibular evoked myogenic potential, should be absent in the presence of a conductive hearing loss. And the fact that she had a present VEMP, even though we'd call it a normal measurement, suggested that semicircular canal dehiscence was actually active in this patient. And I suggested that we not do surgery on her. I could show you. This is something called a third window indicator, which does exactly what I was talking about. It takes the VEMP result and then it corrects the VEMP result based on their conductive hearing loss. So a conductive hearing loss should change what you're finding on a VEMP test in terms of what to expect and what to call a normal test. This is the woman I was speaking about. She's a 43-year-old, very, very intelligent woman. We talked about the issues that she may have if she were to have an unsuccessful Stapes operation, and given the situation with her VEMP testing, I thought that it would be potentially risky to do it, and she opted not to have Stapes surgery. As you can see, it looks like pretty much bread and butter otosclerosis. You would say, well, why not? Let's do it. But again, I think the VEMP testing should be absent in this case, and it wasn't, and that was enough reason for me to suggest that we not proceed. This is her VEMP test. And this is her CT. As you can see on the left that she has otosclerosis, fenestral otosclerosis, and on the right, the semicircular canal dehiscence. We also looked at the location of the dehiscence, and we measured it. There's a way to measure the approximate area of the dehiscence, which I think is probably a worthwhile technique, but in our study, we just weren't able to make any correlation to outcomes. I just think we didn't have enough power to do that. So we weren't able to make any conclusions on that. So what should we do now? What do we do with a patient who walks in? First of all, I do preoperative CT on everybody. If you don't, then you should be highly alert for the potential signs of a semicircular canal dehiscence. And if they're present, then you should go ahead and do a CT scan and a VEMP preoperatively. If the CT shows a semicircular canal dehiscence, I would personally, and again, this could be debated, but if they do not have otosclerosis on the CT scan, I personally would avoid surgery. So semicircular canal dehiscence without visible otosclerosis on imaging, for me, I would avoid that. Now, you could potentially do a VEMP in that case to make a decision, but my preference would be to avoid. In the presence of otosclerosis, I would do a VEMP on everybody. And again, if there's no measurable VEMP, then it's safe to proceed. And if there's any measurable VEMP, I would avoid surgery. Now, anytime you're going to proceed with surgery, in these specific cases, I think you have to have a specific conversation with these patients. And you know, the risk is a little higher. They're not likely to have as good of an outcome. And so I think it's an important point to discuss with patients and let them decide if that's what they want to do. Robert, I think you stepped out. So I've been coming here for a long time, and we're all starting to look a bit older, but it's really been a pleasure to be part of this organization. I've been inspired, and I go back a ways. So anyway, thank you all very much. Question?
Okay. Well, you have to wait. The microphone. I have a question.
No, you don't get a question.
I don't
I
know.
want Saji.
No, listen, I'm a bit cautious of what you call dehiscence, because I mean we know that dehiscence can be found up to 8% of all scans, and clinically dehiscence is about 0.5% of that. So you talk about dehiscence all the time, but I think you should distinguish clearly CT scan dehiscence and not. The question is, what kind of CT scans do you make? What resolution do you do?
Well, it's 0.6 millimeter slices,
the
but I think the word dehiscence is a radiographic term. Dehiscence syndrome is what you're talking about, which is, I agree, that it's a small percentage of the people. Well, what we don't know, when you're doing if they have otosclerosis, that's potentially masking the actual syndrome.
But I'm talking about the scan because I published with Dan Lee as well from Boston on this.
Yeah.
And we even had an automated routine because it depends also on the guy judging it. And the main issue is the partial volume effect, which makes it difficult to determine. And in many cases that you find on a scan dehiscence, in clinical situations it has no value at all.
The problem is we don't know which cases those are. You know, that's it. That's why we have to proceed with caution. But it's a finding on a CT. We can't ignore it. I agree that we don't know. Yeah.
Well, the other thing, Neil, I just wanted to ask is in France now it's mandatory to do a CT, and I've changed from pressure off you and Chris and Wilco over the years, and did CTs up until my retirement. What's happened with the lawyers in the States? Because it looks to me now as though this is a little bit difficult to defend.
I think if you end up with a post-operative bad outcome and you do a post-operative CT that shows this, I think that could be hard to defend.
So Neil, do you do canal plugging for superior canal dehiscence?
I don't, but no.
Because I think a very real option for
Yeah.
these sort of cases
Yeah.
is you're hopefully aware of the potential for dehiscence in advance, and you discuss with the patient that you're aiming to correct the conductive hearing loss, and if that unmasks canal dehiscence symptoms, then you can confirm that it is a functional dehiscence with your VEMPs, and if the symptoms are bad enough, then you can do a transmastoid plugging of the superior canal, and usually get very good outcome. So I think it just needs to, something to be aware for both.
Yeah, I mean, but
and interestingly, none of your cases seem to show a pseudo-conductive hearing loss, which should be part of the audiometric findings with canal dehiscence syndrome.
But not with otosclerosis present.
Maybe not.
Maybe, yeah. But I think having to do a second if you tell a patient that they may need a second operation to fix what you caused in the first operation, I'm not sure that's the feature of your operation.
Well, best to warn them in advance. And I actually disagree with John. I don't think everyone needs to have a CT preoperatively. If you've got a strong family history, they've clearly got clinical otosclerosis, then you're doing an exploratory procedure. Do your Stapedotomy until you've confirmed the diagnosis clinically or at operation.
I didn't say what to do. I wanted to do a scan. I said the lawyers have forced us in the direction.
We shouldn't be doing preventative medicine or practicing preventative medicine. I disagree with that approach. Saji would like to say something.
May I have your attention,
Oh,
please?
Saji.
Well, do you offer to those patients that decline surgery any other hearing solution than conventional hearing aids?
For you, get out. Other than a hearing aid, you said?
Exactly. Like
certainly, we'll always talk about Baha, but I mean, most people would elect for an air conduction
do you
hearing
have any
aid first.
experience with this, these devices and the symptoms of the dehiscence of the superior semicircular canals? They complain of it, or it fits well.
You're saying a hearing aid that sort of brings out the symptoms of semicircular canals?
A bone-anchored hearing aid in a patient like that, there's any major concerns?
Yeah. I don't know. That's a good question.
With
Yeah.
a vent, we use a shaker to provoke vertigo.
No, you never told us if you unmasked symptoms in any of those patients. Did they have no symptoms afterwards of severe canal dehiscence?
I didn't have any unmasked patients. I mean, I don't know why. I'm not, I mean, I got lucky, I suppose.
The other thing I was thinking about is, what about using bone conduction vents? That way you bypass the air conduction confounding factor. We've been using bone conduction
Yeah,
vents.
I think bone conduction VEMPs could work, but yeah, I guess that makes sense because that overcomes the
You overcome the confounding factor
Right.
of the air bone gap, then you can really see if it's low or not.
Right. That would be in the cases where it was absent, but the fact that it's present in some of these cases
Yeah, if it's
means that
present,
there's a
clearly, but-
hypersensitivity to the stimulus. So
Exactly, but if it's absent and they have low VEMPs, then you know it's a functional dehiscence, not a radiological dehiscence.
Yeah.
So Neil, this is a very interesting topic, and I really have some very few of some patients, and we don't know what to do with them. I agree with Wilco that there's a difference between high-resolution CT and cone-beam CT. I've seen cases in which it looks like there is a semicircular canal dehiscence, and in the cone-beam it's not. Even with the cone-beam, you may have some doubts in some cases. But I think I'm always using for otosclerosis cone-beam, because I think it reflects really, I agree with you that this is a problem. I don't know the frequency, but it's really worth considering a preoperative CT scan. You have cases with bilateral dehiscence, unilateral otosclerosis, and you didn't mention about symptoms of the dehiscence of the canal. So you may have patients in which it looks like, but there is no symptoms. Now, in a case in which you have otosclerosis and a dehiscence, I think you should consider not doing an operation. at least for what you've shown.
Yep.
The results are not so good, and so on. And you cannot decide to plug in preoperative to the sclerosis because you don't know if there is symptoms or not. So I wonder if after doing that, you should consider plugging just to avoid symptoms and to improve hearing, if it's the case. But probably the tendency is not to operate these patients, probably.
Yeah. Well, I mean, I think
but
that's what we're trying
some sort
to figure
of
out.
overdiagnosis.
It's probably overkill, as we're saying.
Yeah,
These CT images are probably not really fully accurate. So it may be too much to say don't operate at all. It'd be nice to find ways to be selective.
Thanks, Neil.
Alrighty, thank you.
Thanks. That's questions.
Want to charge it while we're Cool.
So now comes the man, the Brazilian. So it's more than a pleasure for me to introduce Saji. Again, we met long time ago, thanks to Neil in New York. I think it was in New York during the American Academy. And so Saji Salaman da Costa was the past president, one of the past presidents of the Brazilian Society of Otology, and is professor in Porto Alegre, which is in the south of Brazil, right in front of the Argentina. And so my family went to his house, my daughter, and now she's in big trouble since she came in his place, but we enjoyed it very much. So he has really good experience in Stapes surgery, so I think it's good to hear him.
Not my problem so far. Hello? Hello? Well, thank you so much for an invitation, Robert. It's always a pleasure to be here. As Robert used to say, I am from Porto Alegre. It's a nice town. Last year we were flooded with water, but it's blooming back again, so it's a nice town, and we are waiting for your visit here. This is our university hospital. I used to say that we from the ENT department, you are not in the picture because you're in the basement. But anyway, this is the hospital. And we're going to split the presentation in 200 slides. It's going to be real fast. You please tell me in 1 hour, but we're going to talk about basics. We're going to talk about the basics, a little bit more than that, and a little bit of another work that I have been developing with my good friend Robert Briggs. So the first thing to understand is the environment, the middle ear cleft. And the question here is that we need to pose is why and how the middle ear system has been developed. Well, we know that the otosclerosis is not a disease of the middle ear, it's from the inner ear. But anyway, the problem began when our ancestors came from the water to the earth. So we became 30 decibels deaf because of the impedance mismatch between water and air. So we developed this tympanocecular system to work in two ways with the hydraulic mechanism and the ossicular lever to convert the sound waves in the air of high amplitude and low power into low amplitude and high power waves in the liquid. And again, this is the work of the middle ear and the tympanocecular system. Otosclerosis, my friend, is a primary metabolic osteodystrophy of the aortic capsule and the ossicle, exclusive in humans. And of course, you can bring the conductive hearing loss, sometimes even sensorial hearing loss. And there is a clear genetic predisposition. This is a autosomal dominance inheritance with an incomplete penetrance of 40%. Well, what makes the aortic capsule so special? Why this bone is so special in the human body? Well, you know that the inner ear is fully organized and attains full size and differentiation at the midterm. And why this is important? Because the bone around it, it gets consolidated at birth. So you need to have the final size before birth. And this ossification will happen from 14 ossification centers around the cochlea and the semicircular canals. And the temporal bone, I mean, the petrous portion of the temporal bone will be completely ossified by birth, with some narrow spaces with, lasting cartilage. And the most important of that was a small fissula close to the window that Sibman called the fissula antifenestra, the anterior oval window. Well, if you take a femur of a newborn and the petrous portion of the temporal bone and you follow it through the life, the femur, of course, will grow, but not the petrous bone. And that makes possible to take a child with 6 months and do a cochlear implant in this child. And this electrode will not be displaced because, the temporal bone, the petrous portion of the temporal bone will remain the same. Again, the bony turnover of the petrous portion of the temporal bone is also almost new. So you take a femur, you have a fracture of the femur, and you're going to have later on a bony callus. But if it happens at the petrous portion, you have a fracture. Never more you have a consolidation there. You're going to have a fibrous callus. So, and what's so important? This happens to maintain the configuration of the inner ear, especially the semicircular canals, to maintain symmetry between one and the other side. And the other one is that if you have those toxic enzymes working around the cochlea, you're going to become deaf as soon as we're born. A little bit of history, that in 1741, Antonio Valsalva describes the first time the ankylosis. 1869, von Trost created the term otosclerosis, and 1894, Adam Politzer described a histopatological profile of otosclerosis. Later on, 1930, Surdil describes the fenestration in multi-stage. 38, Lampert brings the fenestrations to the state of art. And a little bit later, 53, Rosen reintroduces the stape mobilization. The big change was 56, as has been mentioned here before, with John Shea describing the first stapedectomy. And here, sir, you can see a surgery of John Shea with his microscope, and a surgery here done probably in this house. Those guys were heroes. We have to agree with that. Well, we have a disease with a 10% global prevalence of histological otosclerosis, much more common than we think. But clinical significance, it's less than 1% of the cases. And as I said, it's an osteodystrophy of the aortic capsule with resorption and new bone formation, limited to the aortic capsule, and there are some triggers. The hormonal trigger is the most important of that. To understand a little bit the slides that will follow, we'll have to understand a little bit of microanatomy and histopathology, and we're going to do a quick tutorial here regarding this. And we start doing this years ago. What is going on? At the orthopathology lab with my good friend Neil Sperlin and our late professor Michael Paparella. And you have to understand those pictures. Maybe? Hello? Yeah, much better. And the sound is... Temporal bone microanatomy. We're going to slice the temporal bone top from the bottom, and you see some key anatomical landmarks here, just to understand the picture. So here we have the malleus and the incus, and you go to the facial nerve, close to the geniculate ganglion, the ampulla of the superior semicircular canal, it's, of course, the fundus of the internal auditory canal and the base of the cochlea, going one section below, the malleolincudo joint, the anterior malleolar ligament, the cochlear forming process. Lower, you have the action zone where the oval window with the facial nerve and the cochlear forming process. And here the relationship of the foot plate with a sacculum, dilated sacculum, by the way. The window, the anterior, the posterior crus, and the incudo-stapedial joint, Robert showed this morning beautifully how to make this articulation. So a little bit, the other section with the umbus of the malleus, it's the part that is hard to separate the tympanic membrane from the malleus because it goes like an envelope around the malleus tip. You have the tympanic annulus, carotid artery, facial nerve, round window niche, the ampoule of the posterior canal, sinus tympani, facial recess, and this endolymphatic sac. So a little bit of pathology. You know, as I said, Siebermann was the first one to establish the histological profile showing this otospongiotic bone, like here, and generally limited to the anterior margin of the foot plate. You know that there are two phases of this disease. The active, that we should call otospongiosis, and then we have a lot of osteocytes, histiocytes, and osteoblasts, and a lot of vascularizations that is reflected by the Schwartz sign. And the mature otosclerosis, that is much more dense bone. Here you can see the difference. You know, there is a very immature focus of otosclerosis with a lot of vascularization and the Schwartz signal here. And here, the mature or the consolidation of the focus, and you know, the tympanic membrane turns normal again. And here you can see pretty nicely the division between the normal bone and the otosclerotic bone. And when the bone with otosclerosis advances, there is an increased affinity for hematoxylin, and you know, Pulmonassi used to call this the blue mantles of Pulmonassi. And you can see here around the cochlea the invasion of the otosclerosis focus, and here are the blue mantles. Actually, the real blue mantle is the jersey of the Grêmio Futebol Porto Alegrense. And where is Mario? Mario is around? You know, next year I'm going to bring you a larger shirt of the Brazil. I don't think this one is going to fit anymore. The histopathological profile. You have histological and clinical otosclerosis, and that's very interesting. For example, here we have the window, and the annular ligament is free. So we have histological otosclerosis, but not clinical. And here we have clinical otosclerosis. Again, in this section here, you have a focus of otosclerosis, but the annular ligament here, you can see in the tail, it's free of disease. So you have histological, but not clinical otosclerosis. And here, we have a small focus of otosclerosis here. The annular ligament here is free, and you can move this Stapes. It took me 3 days to prepare the slides. But anyway, let's move on. Again, histological and clinical otosclerosis. This is a perfect and beautiful focus of otosclerosis here. Going, you know, in hierarchy, otosclerological, fenestral, and cochlear, and pure cochlear otosclerosis. Is it possible? Yes. Here we have only histological, maybe cochlear, but no advance in the focus over this foot plate. So, histological otosclerosis. Again, a focus of otosclerosis, the foot plate and the facial nerve here. That's okay. Histological otosclerosis. Now we have a fenestral focus of otosclerosis here, pretty clear. Again, two focus, one anterior and one posterior to the Stapes. Very mature focus, a lot of vascularization. Fenestral and cochlear otosclerosis. We have the fenestra here and the cochlea affected by otosclerosis. It's pretty common. Again, the fenestra and the cochlea. And you can also have only cochlear otosclerosis. Is it possible? Yes, it is possible to have only cochlear otosclerosis with the invasion of the spiral ligament and the stria vascularis of the cochlea. We're going to see it later on. You have here pure cochlear otosclerosis. You see the Stapes here is free, but the cochlea is invaded and is surrounded by otosclerosis. Again, cochlear, even in otosclerosis, even in the modulus, in here, but the foot plate it's free. And as I said, you can have the involvement of the spiral ligament and the stria vascularis of the cochlea with sensory hearing loss pure, without the cochlear and the conductive component. But some people would say, well, if this focus, normally we start here at the region of the fistula antifenestra and it grows circumferentially, how can it affect the cochlea without affecting the Stapes? But you believe me, it's possible. We have this patient here with you know, a pure sensory hearing loss, And here is the CT scan. So yes, it is possible to have cases like that. Pure cochlear, you see with magnification, more. You see the spiral ligament here being invaded by the focus. And here even the stria vascularis and also the organ of Corti that has been damaged by the focus. Just to show you a case, a control, and a case. So is it possible? Yes, it is. What are the most common sites of involvement? As I said before, the first one is the fistula antifenestra, anterior to the oval window. The second is the round window niche, very important in cochlear implants. The middle turn of the cochlea. The posterior margin of the oval window. The posterior margin of the oval window. The anterior wall of the internal auditory canal, around the cochlear aqueduct, and the semicircular canals. Clinical profile. What's the most common presentation? Woman, 20 to 30 years old with conductive or mixed hearing loss. Slightly asymmetric and tinnitus most of the times. The audiological profile of those patients. Excellent bone conduction in the low frequencies. Conductive hearing loss. Carhart notch. And of course, absent reflexes. This is very important to make the differential diagnosis with the things that Neil just has shown to us. Differential diagnosis. Well, we have differential diagnosis in the middle ear, and the most important of that is the malleus head fixation, as probably, I don't know who showed this morning. And you have here, in the histopathology, it's clear that there is a fixation of the malleus head in the lateral wall. And Vincent had explored this subject years ago. We also can have ossicular chain fixation or disjunction. And you do use cement here to rebuild this. Fracture of the stapes. Very interesting case, fracture of the handle of the malleus. Congenital fixation of the incus instead of the stapes. The stape is moving here, the incus is fixed. We removed here the incus and you put a piece of cartilage here with a kind of good result. You can have stapes monocruta. That's why it's so important, the CT scan in the pre-op. And sometimes even a bony bar from the promontory fixing the ossicular chain. Sequela of otitis media, it's pretty common. And hyalinization of the anterior malleolar ligament. This was something that Professor Fish used to talk about. And for this reason, he changed to primary Malleus stapedectomy in 20% of his cases. But only he was doing this kind of surgery. We studied this ligament in histopathology. We couldn't find any changes. The most important differential diagnosis in the internal ear is the dehiscence. Neil has shown, and I will not stick in here. But importantly, the audiological checklist of these patients, excellent bone conduction, the conductive component, mixed hearing loss in the upper frequencies, Carhart notch, and reflexes are present. Solutions, all kinds. You know, the guys have been talking all the time, and you know, the easiest way to do that is to perform a stapedectomy. But believe me, it's moved like this only here in Béziers. No, it's not in Porto Alegre, not in Australia, Melbourne, no, it's only here in Béziers. Because we do have some special considerations and some complications of the surgery. It's not so simple. First one, tympanic segment of the facial nerve. We have covered this subject just a bit ago. You have many kinds of situations. You have the facial nerve here with bone around all over. That's okay, no problems at all. But you can have this kind of facial nerve. The superior lip of the canal, you have bone, not in the inferior, but it's not also a problem. But then you can have the bony canal, okay, and the nerve prolapse to the window. That's maybe a problem. And sometimes you have the whole nerve that is prolapsed and the dehiscence in the round oval window niche. This is a big problem. And here you have a monumental problem because you have obliterative otosclerosis. The facial nerve displaces on the top of the obliteration. And if you drill through the obliterative focus, you're going to drill through the facial nerve. That's a big, big problem. The dehiscence facial nerve, biscuit foot plate, obliterative otosclerosis, and here, this is a case of Robert Vincent with a focus of obliteration here. In one of our cases in Porto Alegre, we do endoral, so we could manage to drill with the actually mastoid drill here with the cochleostomy burr, a hole and insert the piston. But that's nice to see, the difference between the facial nerve and the focus. They look alike, they're pretty close. You have to be sure that this is not a facial nerve, this is a obliterative otosclerosis. Floating foot plate, again, a slide that gave me a lot of headache to produce. And it can happen. You can push the foot plate inside the vestibule. It's not impossible to happen. This is a case of Silvio Caldas, a good friend, that was drilling the foot plate. It went inside the vestibule. He had to fish the foot plate back. And this is one of our cases that it's kind of bleedy here, but the foot plate was kind of unstable. You put the prosthesis on the top of this foot plate. Gusher. Gusher is due to a patent cochlear aqueduct that is here. And this kind of situation, this one case of Robert, this happened to us maybe 2 years ago. It was the worst gusher that I had. It was really bad. And it's very interesting. This patient stayed at the hospital for 3-4 days, and he didn't know why I was keeping her in the hospital. And she had a splendid hearing result. Talking about this morning, the persistent arterial artery. This is in the persistent of an artery in a chronic otitis media. And here, another one during the Stapes exploration. So it's a real artery here. It bleeds a lot. Obliterative otosclerosis on the round window. Here, not invading the scala tympani. Invading the scala tympani. It's all around the cochlea. And some medical complications.
Hey, listen, I was wondering if you might help me, huh? Listen, I'm in the bumper sticker business, and I've been trying to think up a good slogan. And since you have been such a big inspiration to the people around you, I thought you might be able to help me jump into. Whoa, man! You just ran through a big pile of dog shit.
It happens.
What shit?
Sometimes. And some years later, I heard that fella did come up with a bumper sticker slogan, and he made a lot of money off of it.
Shit happens. You can see this case has been shown this morning, and you see the histopathological profile of the erosion of the incus here. And this is another case, we do augment the long process of the incus with some cement, and then we put the prosthesis on the top of it. Of course, we have to be very careful to do that, but anyway, it's possible. Surgical failure. It seems like a nice prosthesis here, but it's not. You can see the foot plate here. It doesn't go into the vestibule. So, failure. This patient here with a prosthesis deep seated in the vestibule, really bad result in terms of vertigo. Seems like the prosthesis is in the right position. No, it's leaning on the lip of the window. It's not working, not in the vestibule. Here it seems, now we have a nice prosthesis here. No, but we have one prosthesis here also, and another one here. 2 prostheses in the same window. Vertigo. You see, the foot plate and the sacule, that is dilated here. So you can easily poke the sacule if you have for example, a hydrops in this ear. So we do the small opening and gets into the vestibule 0.5 millimeters, not to reach the sacule here. Because you can have the association of otosclerosis and Meniere's disease, otosclerosis and the dry drops clear here, very huge items. Because of the involvement, this is the sac, a normal endolymphatic sac, and a sac involved with otosclerosis here. And remember, the old guys here probably remember the sac procedure when they poke the sacule through the oval window. Very interesting case, a female with a kind of kind of regular hearing result, but with a lot of vertigo. And then we did a CT scan of this patient, and she had a whole stapes inside the vestibule. As the Americans used to say, shit happens again. Perforation. This is very upset when you have initially a very nice result, and then the hearing drops, and you can have this kind of situation. You have adherence around the prosthesis and the prosthesis that was displaced. But this one was inside the vestibule, so it was pretty easy to fix. Well, I'm coming to the final part. In this part, we have been working with the group from Melbourne. We're talking about cochlear otosclerosis and the implications of cochlear otosclerosis in cochlear implants. And the aim of the study group was to develop a new radiological classification of cochlear abnormalities. And of course, associating is this kind of findings with the histopathology. So in cochlear otosclerosis, we have problems with the introduction of the electrode. Could be limited to the round window niche without involving the turns, but can go round window niche and membrane, further into the scala tympani, and scala tympani and of the basal and middle turn, and the scala tympani and vestibular. So it's really a problem. And sometimes, in otosclerosis, we also have the problem of the false track insertions that could be beneath the cochlea, on the top of the cochlea. You have a cavity here caused by otosclerosis. Close to the carotid canal, you see the proximity of the cochlea and the carotid canal here, and to the internal auditory canal, and sometimes even stimulating the facial nerve, like this patient here. Good result, but with this facial fasciculation. So we put together this group with Australia, the guys from the histopathology department of the University of Minnesota, and we came from Brazil. So we first study, and Robert has done that, study very carefully the cases with very complicated insertion of electrodes in cochlear implants. And we could see that there is a wonderful correspondence of the CT scan and the histopathology. I don't have time to show this, but anyway, it's splendid. And we came up with this classification, the category 1, antifenestral otosclerosis with normal round window and the scala tympani. So it's free to go. Sometimes you have the involvement of the round window and the scala tympani is free, so no problems at all. A narrow scala tympani, you can do it, and a very, very compromised scala tympani. You have to do the cochlear implant through the scala vestibuli. And sometimes you cannot do it at all because you have the ossification of the cochlea. Second part of the study was to study the endosteal invasion of the otosclerosis in histopathology. And over 2,000 temporal bone, we studied 237 with cochlear endosteal invasion. And we divided the invasion in 3 categories. The first one, it gets to the endosteal but does not compromise the spiral ligament or the stria vascularis. The second one, you have a minor involvement of the spiral ligament and the stria vascularis, or a gross involvement of those 2 structures. And most of the cases, we had this great anyway, let's go. So we could see here that we have involvement of all turns of the cochlea, especially anterior here, but also posterior here, close to the fistula antifenestra, but also anteriorly, and sometimes even through the modulus. So the involvement of the cochlea goes through this direction as a general rule. And I also studied the round windows, and you divided round windows in 3 types with no obstructions at all, less than 50%, and above 50% of obstruction. And we came to grade 1, most of the cases with grade 2, with at least 0.5% of the round window compromised by otosclerosis. And it's that interesting because when you have a gross compromise of the round window, most of these patients will also show that they had what I call they have focus that are pericochlear and invade inside the cochlea, one of the terms. We have done other studies, but I will not discuss. So it's very important, again, to study these cases. And we also have some studies regarding the difference of ossification of the otosclerosis and the meningitis. One is outside in, the other one is inside out, fast, slow, fast. There are many differences between those two ossification. And there is a huge impact also in this kind of studies in the clinical treatment of the disease, turning focus of otospongiotic bone to otosclerotic bone. Well, we'll finish here with the lineup. And if you are playing, you know, some nice teams like Argentina, you prepare your defense, you know, exposure, approach, counseling, and indication. Easy. Never operates only hearing in ear. Hearing aids are also excellent options. Check hearing always with turning forks. Trust your turning fork. Start with the worst ear. Never overstress the surgical indications with the patient. Give yourself a hand. Go endoral. We do endoral. Always order a CT scan if anything seems atypical. And take your time. And finally, let's see. If a guy like this can do it, of course, you can also do it. Merci beaucoup.
Thanks, Ajay. Tour de force, I thought you cut down slides from 500 to 480. That's great. The question, you know, you showed a lot of otosclerosis around the vestibular structures as well, around the semicircular canals and the vestibule. And Jean-Bernard Causse used to talk about the otosclerotic vertigo syndrome. And do you think that exists? And does it exist because it's high drops, or does it exist because there's a second phenomena, like cochlear otosclerosis causes a hearing loss? Is there a secondary phenomena around the vestibule?
Well, I have two explanations. Of course, it's common. The association of otosclerosis with vertigo is pretty common. Paparella has written many papers on this association. And you can see here that the otosclerosis focus can invade two key structures for the balance, you know, homeostatic balance of the inner ear. The stria vascularis and the sac. So is it possible? And also, as I show you, you have all those enzymes that are not supposed to be there. But when you have an active focus, they can actually poison the inner ear. So I think it's pretty, common. Not only possible, but common.
So why don't we see caloric loss in otosclerosis?
Excuse me?
Why don't we see loss of caloric function, caloric testing?
Well, actually, I don't test them. That's maybe...
It's not really been reported.
Yeah, no, I don't test caloric for patients with otosclerosis with no complaints.
My opinion is that it's more related to high drops rather than vestibular symptoms specific to otosclerosis. Because we have cases like this, and I'm sure there's more eye drops. The most... usually the people I saw with dehiscence, as Neil said, I didn't see any vertigo in most of the time. So, yeah. All right?
All right.
I'm not sure about the last slide, but it's... So let's see. Yeah. No. Vous voulez tester le son, c'est ça? Oui. Okay. Okay, I think it's interesting because it's going to follow the presentation of Saji, and it fits quite nicely because I'm going to talk about congenital malformation, and I will show you my experience in congenital. Just before that, I would like to remind you that for those who would like to have English to French translation, you have the microphone there. Pour ceux qui veulent avoir le microphone de traduction simultanée, elle est en train de se faire tous les après-midi, hein, donc c'est en cours là. Okay, so it's always a fascinating time. I will talk about congenital malformation, but I just would like to present in 1 minute a video clip the pianist that you will be able to see tonight with a very big yeah, but I hope it's stopped. I didn't make it on. So he's a very unique guy. He has been having a international recognition, and he has played with most of the biggest in the biggest plays and with the biggest chef, and so I think it's a big chance to be able to follow him. Yeah.
A child prodigy who won the first prize at the Conservatory of Paris at the age of 13 and who was noticed by Arthur Rubinstein at the age of 16. An accomplished artist who played at the highest level of the international classical scene for 30 years, with 2,500 concerts to his credit in the most prestigious concert halls in the world. A virtuoso with a huge discography who has played and recorded with the greatest like Yudi Menuhin and Herbert von Karajan. And now imagine that in 2003, when this artist played 78 concerts in just 7 months, he announced the end of his concert career, tired of performing mainly for an elite, as he said.
And now this is what he's doing. You will see in a minute.
He symbolically threw a piano into Lake Annecy and burned his concert suite.
This is not what's going to happen
Since then,
tonight, don't worry.
he chose to share his music with as many people as possible. Thanks to his piano C-pad, a bicycle equipped with an electric piano, he generously sold his music to the 4 winds of France.
Anyway, that was just to present the guy you're gonna watch tonight, just for us. So, if we talk about real things now in terms of congenital malformation, hold on, I don't have this problem now with the. Sorry about that. Okay, so I have to put this disclosure, which is true, in fact. So I'm going to talk about congenital, and as I said, congenital is particularly interesting because, as we know, we never know exactly what we're going to find. So it's a fascinating surgery. It's much more interesting than Stapes surgery itself because there are always many traps, and it's very interesting to try to identify the traps to avoid them. And this is exactly what I'm going to try to introduce to you. Like for ossicular reconstruction, we need a classification. And there are different types of classification, but for the congenital malformation, one is the Tönnissen and Kramer's classification from the Netherlands. Sometimes they are good, and they made a nice one. So divided in 4 groups. Group 1 is only the Stapes. Group 2 is the associated simultaneous Stapes malformation plus another one, and the group 4, as you can see, and then the group 4 is the aplasia of dysplasia of the over window, which is the most difficult thing to understand sometimes, even what's happening. And in terms of distribution in my personal series, which I published in 2016, of 243 congenital malformation, you can see that's it. It's the majority is class 1, which means only Stapes malformation and fixed, or sometimes fixed or not. And you can find my results in this publication. So like in life, you need to be not too confident, because if you are too confident, then the problems occur. I understand that some of you had some problem with the air traffic control. Now you understand why in France. That's what's happening today. So let's talk about the varied distribution. I have some examples, video examples. Class 1 is defined by malformation of stapes only. So you can have lots of different things, including, like you said, Saji, the bony bar, which needs sometimes that you need to drill out the bony bar, but you need to identify, like in this case, why the stapes is fixed. And in fact, it's fixed by this bony bar here. It means that there is no otosclerosis, and not any other problem. This bar is fixing the stapes superstructure. So if you are able to cut or remove this bar, then you have to check again the stapes. And in that case, the stapes remains mobile. So you just have to keep it like this. And of course, when you make the introduced stapes joint separation, you need to separate very gently in order to be able to reposition the lenticular process to the stapes head, and it worked fine. This is a case. For example, when you do the middle ear exploration, you can see just the stapes like this, and you immediately can identify that there's a single crus stapes, a very big one. There is no otosclerosis focus, so definitely this is a congenital malformation. So you have to deal with this. You have to check every other possible traps. And you continue only when you identify the landmarks. That's always the main problem. We have to identify the landmarks all the time, but specifically in case of congenital malformation. So what I did in this case, I used the laser to cut progressively the superstructure with the laser, and then with the drilling out, with the drilling, in order to remove the superstructure, preserving, of course, the malleus and the incus, because both were normal. So it's great to have a laser in those cases, because, and specifically, you need a probe, which is more accurate than any micro manipulator. So you remove the superstructure, and then we have the stapes like this, the stapes full plate, and then this is what we have. This is the malformation of the stapes superstructure. Then the following step will be the same as you saw this morning when I was doing live surgery, performing a stapedotomy followed by a reconstruction with the piston. These were the results I published in this series of class 1. You could see, of course, it's not the same as success rate for otosclerosis in my series. When I published the first big series of stapes surgery in otosclerosis only, my success rate within 10 dB was 95%. And you can see it's not the same for congenital malformation. And you can understand that there are so many other problems in the same type of presentation. The class 2 is defined, as we said, by the simultaneous malformation of stapes plus another one, whatever. So you can also have different types of things. The most important, most classical one is the simultaneous malleus ankylosis. I would like to remind you that malleus epitympanic fixation is regarded as a congenital malformation. It's interesting, it's a big debate, and as Saji said, Hugo Fisch was introducing a new concept of malleus ankylosis due to ligament fixation. And he said that it was at least 20% of cases of otosclerosis in which it was associated with a ligament fixation, which means that we should have had at least 20% of failure in our experience. So it's not true, and in fact, there was a very nice published paper made by an American a long time ago doing lots of dissection on the temporal bone, and he never found any ligament fixation in case where there was epitympanic malleus ankylosis. It was always related to the very poor epitympanic space, which means that the malleus head was becoming progressively in contact by friction to the epitympanic wall, creating the fixation. So this is another type of malformation, but just to go further, this is the type of class 2. You can see a malformation of the incus, which is very, very small and not completely attached. And then we have also malformation of the stapes here. So in fact, we did the same. I did the reconstruction by drilling out the superstructure like this. And then if I remember, I think that the stapes remain mobile by doing this, by cutting the reconstruction. You can see it remains mobile. So I use, just to ensure the results, I put a prosthesis like this from the incus to the stapes full plate, but I didn't remove, of course, the stapes superstructure. And the fact that I kept the superstructure like this helps me to stabilize the piston also. In class 3, these are my results, not as good as a class 1, of course. Class 3 become more interesting because then you have a kind of complication things with the malleus or incus, like in this case. And the bony bar fixing things are really interesting. This is a very interesting case which I had. What you can see here is that we have the incus, the stapes, kind of malleus, and the bony bar here. And there's also a plate which is underneath the tympanic membrane. And in fact, stapes was mobile. So in fact, the malleus was fixed by the bony bar and by this plate which is underneath the tympanic membrane. So what I did, I elevated the tympanomeatal flap, elevated the tympanic membrane to expose the malleus handle here and the bony bar, but there's also a plate here running underneath the malleus handle, which was in fact fixed by the bony bar and the plate. So here what we can do is to, of course, drill out the bony bar and also drill out the plaque underneath the malleus handle. And the problem is that we have a mobile stapes underneath, so we need to be very cautious about not mobilizing too much, of course, the stapes. You can see the bar here. So I started drilling out the bar first by posterior to anterior like this, and I had to turn around the malleus handle. I pass anterior to the malleus, and you see by doing this then suddenly the malleus remains mobile. And of course in those cases you need facial monitoring and you need a CT scan pre-op, especially when you do on the young child. So at the end we preserve the ossicular chain by doing this, and we just keep it like this and reposition the tympanomeatal flap like this, increasing a little bit the size of the middle like this. And then by repositioning the tympanomeatal flap, everything remains mobile. You can see that the tympanic membrane is still attached to the malleus handle here. This is typically the bony bar that you can see. So I'm not going to show you the entire procedure, but it's interesting to understand what's going on here. We have a bony bar, and we also have a malformation of the distal tip of the malleus handle, which is disconnected from the body of the malleus. So even if I remove the bony bar, then you cannot use the malleus here because there is a really reduced malleus handle only in the body of the malleus. So in fact, I was trying to understand what I could do, and I wanted to put a prosthesis and try to find a way to stabilizing it. And we have a mobile stapes. You saw that. So in fact, here you see I removed the bony bar. And then what was happening, I'm going to do it faster, removing the distal tip, the distal part of the malleus, and then had to remove the malleus incus. And in fact, there was a fusion of the malleus and the incus with a mobile stapes. So definitely, it was definitely a class 3. So in that case, I will reconstruct using a TORP. This is, you can see here, the fusion between the two ossicles. So I remove that and I put a TORP at the end with a silastic bending technique. So placing the prosthesis like this. And of course, the fact that I use hydroxylapatite helps me very much in terms of congenital malformation, because you have to reduce, in many cases, the size of a prosthesis, and you can drill progressively the prosthesis head. This is the technique. Maybe I hope tomorrow I will be able to demonstrate live, but this is the band. This is the old technique. The new band works much better now. The idea is to attach the prosthesis to the stapes and to ensure prosthesis stability, and placing the prosthesis head, of course, underneath the tympanic membrane. In fact, I'm using this all the time, despite the presence of a stapedial arch, instead of using a PORP, but we'll talk about that on the hearing session, like this. And you can see they're moving together just like a single unit. My results in class 3, you see 63%, which is, of course, not so good, but still, it's interesting to improve that. It's within 10 dB, so it's pretty good, I think. And finally, the class 4, there's a lot of things there. Big basket in which you can find lots of different things. Like in this case, there is absence of over window, a clear dysplasia over window. So we need to identify the things, the landmarks, just to first understand if we are able to do something or not. If we cannot identify any landmarks, I think it's better to abort. But if you find progressively each landmarks, then you can start doing something. So this is right here. What we have is absence of Stapes superstructure. And while I try to understand, we have here the promontory, the possibility of the facial nerve here, and the round window niche here. So I try to understand what's going on here in the middle. There's a little bit of depression, so I thought the over window was there, and it was possible, as you will see, to dissect progressively this area to be sure that I could drill out progressively there, avoiding any problem with the possible facial nerve running there. So, but it was interesting to see that there is a fibrous tissue covering this bony area over the over window, and so you can see I'm using a first a fine needle to be sure that I can find a gap. If I find a gap, I keep going on. If I don't find a gap, I stop. But in that case, I was able to find a gap and progressively do a stapedotomy on this place, as you will see. So at the end, making the stapedotomy and reconstructing with a piston. It was in fact the bucket handle prosthesis because the incus was very short. And John was talking about that this morning. All right. Now, this is typically the case, so I'm not going to show you again. So, interesting traps regarding the facial nerve and the differential diagnosis and things like that. This is typically the malformation. I've seen few cases like this, and it's always the same presentation. In this case, what you will see, this is the left ear. So we have the fallopian canal here, we have the incus, the stapes, and you will see that the stapes is superstructure is not connected to the full plate. This is not the trauma, this is the congenital malformation. Each time I found this, each time I had the same trap. I'm going to show you this. So I'm trying to understand what's going on, and you can see this is not connected to the full plate. The full plate is down there. So I'm dissecting the superstructure, and here on the promontory there is a facial nerve. So fallopian canal, facial nerve, abnormal root of the facial nerve. So you need to identify that. Otherwise, if you drill out the promontory, then you drill out the facial nerve. But remember, this is a message I give to you by experience. Each time I had this case with this connection or absence of connection between the superstructure and the full plate, each time with a bony full plate, each time I had a malposition of the facial nerve. You can see I'm touching the facial nerve on the promontory. So definitely this is different. And then at the end, of course, we can perform it's the same thing. Now I have identified the trap, found the trap, I can avoid the trap. If you do not identify the trap, problem can occur. So at the end, it will be the same, but you can see, of course, the drilling out procedure of such a bony full plate is completely different. So you have to stop progressively using saline solution to refresh, and at the end, you can perform the stapedotomy plus the vein graft and the piston as we saw this morning. Again, another one, exactly the same presentation. You have the facial nerve running down through the stapes superstructure. This connection between the stapes superstructure and the full plate and the facial nerve abnormal situation. It's the same thing. Each time you have that, there's a problem. But then again, in this case, I have a gap, so you can do the stapedotomy on the right because that's good enough. Of course, you can see the facial nerve, the superstructure connected to the facial nerve. And of course, I'm not going to talk too much about the stapedial artery passing through the stapes superstructure like this. The only message that you have to remind you is that do not do anything against the stapedial artery like this. Preserve them all the time because there's a risk of facial palsy or any other risk of sensory and hearing loss. So it's better to preserve it. But again, I found by removing the superstructure, I could find a gap to be able to perform stapedotomy posterior to the stapedial artery. But in most of the cases, there is no problem with that. I know that some radiologists doing the CT scan would say there is a big stapedial artery which is responsible for the stapes fixation. There is no indication for surgery. This is not true. I never saw any stapedial artery fixing the stapes. It's completely flexible. So you see here, there was a possibility to remove the superstructure, performing a reconstruction. These other results, of course, not the same, 47 success rate. And finally, this is the last case I wanted to present. It's always the same one, which I like very much. There was a woman came to see me with 40 dB, 35 dB progressive hearing loss, no tinnitus, nothing special. And when I explored the middle ear, I found a very big stapedial artery passing through the stapes arch. And you will see I separate the incus from the stapes and check again the stapes, and I found a mobile stapes and severe reduced mobility of the malleus. So I found that's fine. It's just a malleus fixation, so I will put a port and that will be fine. But there was a big trap. So seems fine. Well, fine, not fine, but I mean you understand. There's a big stapedial artery here, from the facial nerve to the promontory, and then I separate the joint here. Pretty big. You see it already. You can see that the stapes is mobile. There's no doubt about that. And so, but the malleus was a little bit fixed, and there was something bulging here on the promontory, which was in fact, as you will see, a carotid artery here, connected to the malleus. You can see that. So what we did here, I had to remove the carotid artery, and then no, of course not. I was able to abort, so sometimes we abort. So thank you very much for watching. It was just a presentation of different things that you can find. Thank you. Yeah, Manoa.
Thanks, Robert. It's a fantastic series. I've seen quite a few of those bony bars as well. I always wonder if that's the quarter tympani, because it seems to go in the same direction every time. But
yeah,
the thing I wonder about is when I'm drilling on that, I'm always worried about those vibrations being transferred from the malleus to the nuclear chain. Do you decide? I mean, most times you can't get to the incus tibial. If I can, I try and disarticulate that first. But do you worry about that when you're doing?
I think it's better to separate first. But in some occasion you cannot, because it's so narrow that you cannot do it. But if you can do it, I think it's better to.
And when you haven't, have you seen a bone curve drop?
No, not really. Really
Maybe I'm worrying too much then.
Okay, if there is no more question, then Manor? Break is after Manor. Come on, Dwayne. Do you want to make some magic or? No, we do Manor, we have the break, and then we go for the hearing session. So Manor, you've heard about him. He's in Cambridge. He moved from Canada to Cambridge. He's at the head of the ENT department in Cambridge. He's also at the head of the neuroscience department. And you heard about him because he was the first team was able to do a gene therapy on a young child of, it was 2 years, right? 2 years? 10 months. 10 months. And a congenital absence of hearing, right? And they treated with gene therapy, and of course he restored the hearing. So that was the first one. He went into television and everything everywhere in the world. That was very funny to see because I know him. I was very proud. And so he's going to talk about his experience. Thank you, Manor, for talking to us. Pardon.
Oh, sorry. Yeah, that's better. Yeah, good. Yeah. Wait, can you hear me? Yeah. Okay. Very good. Excellent. So there's a lot of build up. Most of it, my time's gone just putting my microphone on. Sad to say. I usually talk about other stuff like middle ear mechanics or eustachian dysfunction or cochlear implants, but because this has been a major focus of my life for the last 3-4 years, and it is something exciting that's coming down the pipeline. I thought it'd be good to talk about genetic hearing loss and genetic hearing loss clinic that I started about 3-4 years ago, and gene therapies for hearing loss. Disclosure, I'm a chief investigator for the core trial for OTOF, for Regenerative Therapeutics. I'm also a medical advisor to Camgene, which is a company trying to restore hearing in due to presbycusis. So this is the main reason I was invited, not because when we did the first surgery, it's about almost more than 2 years ago now, we had the results at 1 year and they were very good, and this lovely young woman, Opal, was all over the world on TV, and this is primarily, I suppose, I was invited. She's much more photogenic than me and much cuter, so that's probably the reason why she made such a big splash. So why should you care as otologists? Because gene therapies, hearing loss are already here, and your patient's going to ask about them. They will ask about them, particularly those people who are eligible for cochlear implants may want to wait. Genetic hearing loss is more diverse than you think. I mean, when I've been a consultant otologist now for 29 years, and used to be thinking about cochlear bite abnormalities as being congenital hearing loss, and in fact, they can be anything. They're all over the place, and at least in the UK, we can order our own genetic test now with gene panel, 147 genes. It's coming around the world, so there's not enough geneticists to deal with these things. You will have to learn something about them because there's not enough clinical geneticists to actually deal with this huge volume of frontline testing that's happening. And the ear is a good target for therapy. Most hearing loss, genetic hearing loss, is monogenetic, so a single gene. It's a closed system, so when you squirt something in the ear, it can reach most of the cells connected by fluid. It's relatively easy to measure success. We have good biomarkers. We can look at ABR. We can look at hearing tests. Unlike, for instance, things like cognitive decline or things like autism, which are very difficult to understand if you got success or not. We've got a single biomarker, or a couple of biomarkers that are actually relatively easy to measure. Genetic hearing loss, just a little bit about that. Approximately, most to refresh for most of you, for 1 or 2 per 1,000 newborns in Europe. Roughly 50% of all cases of early childhood hearing loss, but it's actually up to 70% in developed countries now because we don't see so much rubella and neonatal infectious diseases, meningitis, etc. About 150 genes associate monogenic forms of hearing loss, and most cases of hearing loss are single gene to date, and over 400 syndromes associated with it. As I say, the ones in red are the ones that we see most often. So we see genetic hearing loss, more than 50% of the time, non-syndromic mostly. So most of them don't have any syndromes. The hearing loss is the only manifestation of gene variant, and most of them will be autosomal dominant. And most of these will be more than 50% will be GJB2, connection 26. So if we could solve that, we could solve something like 14% of childhood hearing loss, which would be amazing. So this is, I want you to write all these down because there'll be a test later on this. But there's so many different cells in the ear, and you can see that things that can go wrong in so many different cells that can all cause a hearing loss. Multiple sites of hearing loss. So it's a complex condition, but it's not as complex as, for instance, the eye, which has over 1,000 genes that cause non-syndromic visual loss, and which is in our advantage because it's a bit easier sometimes to work with. So interesting tidbit, mammals can't regenerate their hair cells, but birds and amphibians can. So regeneration is a completely different ballgame than genetic hearing loss. We're not trying to regenerate something. We're trying to replace a protein that's missing, single protein that's missing. But it's really tempting, isn't it? It's like the nature's dangling something in front of us saying, it can be done, you're just too stupid to do it. So it is very, very, very tantalizing that mammals can regenerate. So we started the genetic hearing loss clinic over 3 years ago now with a clinical geneticist. Now we've added a pediatric otolaryngologist. We've seen well over 200 genetic hearing loss patients, probably a lot more than that now. We do MDT monthly. We do this 147 genes. And the main reason we set it up is because we don't understand how the phenotype relates to the genotype, because we do not know, just because you have a genetic variant, it's really hard to know, is that the cause of your hearing loss or not? Because we all have up to 4 million variants, and there's billions of genes. We all have up to 4 million variants that could cause a genetic disorder. We don't all have 400 syndromes, so sometimes it's hard to know, is that gene the cause of that particular hearing loss? Or is this a normal variant, just a rare variant of a normal genetic normal genotype? And also to see what happens to that particular gene variant over time. If you're going to lose hearing very quickly, you may as well intervene early before you lose other cells. For instance, we have downstream regeneration. But if that variant stays stable over time, we can wait. Those kinds of things really become really important. And we need to collect families for future gene therapies as well. It's just a random sample of something like 14 or 15 different kinds of hearing losses we've seen maybe recently. And you can see it's all over the map. So some are cookie bite-ish, some are low frequency, some are profound, some are asymmetric, for instance, even. So we have asymmetric hearing losses here. You see more often, you see asymmetric hearing losses with autosomal dominant, to be honest, than with autosomal recessives, because the dominant ones can express the protein differently in different cells. But you can you can see all kinds of. So there's no one. It's not cookie bites. Just because you have a hearing loss, that's not cookie bite does not mean it's not. In fact, most of our cookie bite abnormalities come back with. We haven't been able to find a gene for them. And the other thing is, not even the same gene, connection 26. These just random 5 or 6 connection 26. We see lots of this, GJB2, can be everywhere. So these patients have mild hearing loss, mid-frequency hearing loss, cookie bite loss, and profound loss. So when I was growing up, we used to think that only profound hearing loss was connection 26. But it depends on the genotype, because if it's a mild variant, it might still produce a protein that's partly functional. You might not get that. So it can be all over the place. So what about gene and cell therapies? So the advantage of these therapies would be one and done, right? You'd want to repair the normal biology and walk away. A bit like stapedotomy. You just want to replace the normal mechanism and then let that person live their life, as opposed to bypassing the mechanism with the technology like cochlear implants or bone conduction devices that need replacement, need programming, things can go wrong, etc., etc. So, and plus we know that all these devices don't give you normal hearing. They give you some approximation to hearing that functions, but not very well in background noise. So we want to try and restore that. In the ideal case, that's what we want. So I'm not saying we'll get there with every gene therapy, but that's ideally what we want to do. Particularly true in developing countries, because they don't have cochlear implant audiologists. We don't have cochlear implant audiologists half the time. It's hard to find them. So gene therapies for hearing loss have already been validated for all kinds of things in animal models in mice. If we could cure all the things we could cure in mice, none of us would have a single disease. We can cure everything in mice, but it's very hard to translate that to humans, and a lot of things fall down between the translation between mice and humans. So the most common thing, and the one I'm going to be talking about, is gene replacement. So usually that's a recessive condition where the protein, something's wrong with the genotype, so it can't make a particular protein, so something's not working in the cell, so we need to replace that protein. So we need to put something in there that's going to start making that protein again. So that's gene replacement. The dominant genes are not the same problem. In general, the problem with dominant genes is they're producing a protein that's interfering with the normal protein or toxic to the cell. Those are common types, other kinds too. So we can't put a new protein in there that's going to help with that. We need to suppress the protein that's being produced. That's gene suppression. And that we can't do with gene replacement. Usually we end up having to suppress the RNA, so the gene expression RNA. So you put short-term RNAs that interfere with it. But those are short-term therapies that have to be repeated all the time. Nowadays, though, you can actually edit the host genome, gene editing, CRISPR-Cas9 editing. So that's been done now for homeopathic disease like thalassemia. So it has been done in humans. So you can actually take a bit of the genome, snip out the bit that you don't want, insert a gene that you do want. Sorry, somebody's trying to translate. I should slow down, I guess. I just saw he's squinting. He's squinting very, very hard. So I better slow down. Have you caught up yet? Okay, very good. I want to talk about some of the other stuff here because that's. Yeah. So, and I'm not going to talk about cell replacement because cell replacement is a whole different thing. So these are things, or regeneration. So what we really want to do with an aging population, regenerate everything. It's not a single missing protein. It's because everything's dead or dying and old, much like much of the faculty. So we have, so we can't really do a single gene. So for that, we need either to put new cells in, and people have tried this 801 gene. That was Heinrich Strecker did that a few years ago, but it didn't work. So we tried to regenerate using adenovirus. So it didn't work at all. And I'm not surprised. It's a very complex problem. So that's not going to be very easy. You can put new cells in. There's a company, Renew Therapeutics, out of England, actually, that's putting stem cell transplants that are supposed to replace the spiral ganglion cells or cochlear implants. So that's cell therapy. And that is a completely different thing than what I'm talking about, which is gene therapy. But it's regeneration. We're working on an mRNA using lipid nanoparticles to try and produce some neurotrophins inside the inner ear to try and repair synaptopathy. So how do we get genes into the ear? So the thing, I think in the foreseeable future, we'll be using these AAV, adeno-associated viruses. And the reason we're going to use those is because they've already been approved for human use in the eye, in the liver, of homeopoietic cells like sickle cell anemia, etc. So they've already been approved. They're not pathogenic. They're naturally occurring viruses. They don't integrate into host genome, so they don't get passed on to your children, or don't get passed on to daughter cells when it divides, rather. But they can only package a small gene, about 4.9 kilobytes. And in the hearing world, I'll show you that most of the genes that we have are fairly small. And now there's tricks in the last 10, 15 years. We can put two halves of gene, two different viruses, engineer the end, so when they come in the cell, they connect back up again. So you put a larger gene into, it's called dual packaging, and that's what we were using in a trial. There's also new synthetic ones. You can engineer them to try and target different cells. You can try and target hair cells versus spiral ganglion cells, and they're primarily optimized for hair cells. And there's other things. The only other things that I think might come down the pipeline, lipid nanoparticles, liposomes. I think we'll be using AAVs for quite a while, but they're very expensive. That's a problem. They're hard, expensive to scale up, expensive to do GMC manufacturing, and these therapies are very, very expensive because of these kinds of things. So if you look at the delivery potential for AAV, most of the recessive and dominant genes will fall in 10 kilobytes. We can put them into two. We can usually put them into two AAVs. So all of these can potentially be packaged into AAV, so that we can deliver all these genes in two AAV viruses that could restore that gene. So why is the inner ear an attractive site? Well, as I say, it's compartmentalized. So there's blood labyrinthine barrier. So there's not much systemic toxicity. So if you inject something in the ear, not much of it goes to the rest of the body. And so toxicity is always something. People have died from liver AAV therapies because you put large amounts systemically. Here we put in tiny amounts of small organ, and there's a blood-brain barrier, blood labyrinthine barrier. Constrained organ, so there's not a massive number of genes causing hearing loss, so we have a chance to try and identify the common ones, and we have good biomarkers, and unlike some other areas. The inner is continuity of fluid, so vectors can reach most of the cells. I'm just watching to see if translates squinting, he's okay. And most cells don't divide. So if you put a AAV virus, it doesn't integrate into the host genome, so if a cell divides, you lose it. So that's a problem in the liver and other places, but in the ear, most of the cells don't divide, so hopefully it will stay for life. And most hearing loss is monogenetic. So this is a trial that I'm involved with at Regeneron. I actually started this with Decibel, and then they got bought by Regeneron in the middle of a trial, actually after I did the first two patients. So I thought I had done the first two patients in the world, actually, because nobody else had ever published it. But it turned out they'd done it in China, but not published or registered it in a clinical trials just a few months before me. So it's not the first two. The first two I knew about, but not the first two turned out afterwards. But it is. That's what it is. So the gene that we were looking at was OTOF and otoferlin, and it causes something like an autoneuropathy. What it does is OTOF is a gene, that produces a protein otoferlin that allows these synapses, these vesicles containing glutamate, to release a neurotransmitter from the hair cell to the auditory nerve, peripheral process auditory nerve, so that everything else is working. Outer hair cells are fine, the inner hair cells are fine, it just can't release the neurotransmitter. So it's a very small localized locus of failure. So if we can fix that locus, everything else is intact. So it's a good low-hanging fruit to start with. It's not that common, 1 or 2% of genetic hearing losses, but because everything else is intact, if we can fix that, likely we will be able to solve the problem. Also, everything else doesn't die if this isn't there. It's unlike GJB2, where if you lose the GJB2 gene, lots of other things die in this inner ear as well, so we have to get it very early. And these kids present with present otoacoustic emissions and absent ABRs, because they can't generate ABR because they can't release this neurotransmitter. And sometimes we see these kids, sadly, age 4 or 5, and it's a real problem for us because they've missed the boat because they've passed otoacoustic screening because they've got normal hair cell function for otoacoustic emissions. So that's why this was a good choice. This study uses two, as I say, I already said they cut the gene put in two separate AAV viruses that recombine to form the viral vector genome that produces the new protein inside the cell. So the surgery is similar to a cochlear implant. In fact, the first two patients I did cochlear implant on one side and gene therapy on the other side because I wanted to make sure they got at least nobody had done this in the world as far as I knew, so I did not know what we were going to get. So I wanted to make sure that at least they had something on one side that they could use, the kids. So a standard facial resistance approach, then we put a catheter in the round window and infuse a gene product over 16 minutes, but we open the lateral canal, do a little fenestra in the lateral semicircular canal, so that the gene product can go all around the cochlea, go around the scala tympani, all around the scala tympani, around the helicotrema, and out scala vestibuli, and out this fenestra, so that it actually can permeate the whole of the inner ear. And this is intraoperative shot. This is the incus, of course, and this is the facial nerve. This is the facial nerve, quarter tympani, and here I've put the catheter into the. And here's a product. I just made a little fenestra in the lateral semicircular canal. There's a product coming out of the lateral semicircular canal here as we infuse it. And then we repair this afterwards with bone pate. So in fact, she had no symptoms after. She's 10 months old, this little child, when we did this. So far, now they've done 12 patients around the world. We've got the first couple. Spain this gene is more common in Spain, so there've been quite a few in Spain. There's not been any serious adverse events related to the gene therapy. My kid had a mastoiditis on the cochlear implant side, but not on the gene therapy side. She gets recurrent ear infections all the time. A couple of others, not related to the gene product itself, but to childhood diseases that happen in children. So this is the most important slide. So this is the results of the 12 patients. This is my patient, almost 2 years out now, and this is my second patient. Actually, he jumped up to about here after a while, but most of them seem to be following the same trajectory. So this is within 20-25 dBs pure tone average in the ear that's treated. In the untreated ear, nobody has regained function. So it's clearly to do with the treatment, and some of these later cases didn't have a cochlear implant on the side. So you can see that clearly has had an effect in this particular area. This second kid didn't do as well, but it's now jumped up to about here, about 60 dBs. One of the kids didn't respond. Nobody knows why, but the rest have all responded. Majority have following the same. We're much further out than everybody else, so this may be the trajectory we're all going to go into. This is the child, just to show an example of her ability. This is with the cochlear implant off. This is at week 48, I think, after, this is her audio. Now, what happened at week 36? She got a severe ear infection, got mastoiditis on one side, got severe infection on the other side, and dropped the 4K hearing. That came up to about here afterwards, but I don't know if that's related to the otitis media she had. Anyway, this is just her.
Can you give Snap Snap a big cuddle? Yeah, give him a big cuddle. Can you give Snap Snap a kiss? Yeah, can you give her a kiss?
Nora's her sister.
Snap Snap is hungry. Yeah, he's hungry. What shall we do? Oh, yeah. Snap Snap would like some hot chocolate. Can you give Snap Snap a drink?
Wow. So Snap Snap has a good life, doesn't he? Yeah. Anyway, so this is her just showing that she can actually recognize spoken language and actually respond, I think.
Where is the duck? Good girl. Can you show me again? Where's the duck? Which one?
There's a duck.
Good girl. What noise does a duck make?
What does it make? Does it make quack, quack?
Quack, quack, good girl. Where is the ball?
There's a ball.
Show me.
There's a ball. Good
girl.
So she can understand speech, and she had pretty good. So it's one of our problems that we were worried about. I was worried about that they would have thresholds go up, but they wouldn't have good speech understanding because you need a lot of functional hair cells for speech understanding. You don't need that many for threshold, but she seems to understand speech not bad. And these are the tests, open and close set tests for appropriate to her age. She's doing quite well from that point of view. So this came out a few months, about 6 months to a year after we did our cases, and they'd already done these from Fudan University, Shanghai. These are 2 participants where they showed good results 6 participants where they showed good results in 4 of them. Another group out of China had done 2 patients, and at 5 years and 8 years old. So even 8 years old, there was enough remaining cells that they could still get a hearing gain, not necessarily get a speech understanding, but they could get a hearing gain at that point. So why is there variability in outcomes? This is one of the unknown questions here. And so since that time, there's been a bunch of companies in the space. Regeneron was one when I started with. Eli Lilly acquired another company called Aquas from the US. Sensori in France have now dosed, I think, a few patients. These people have dosed 7. Everybody's dosed about more than 10 patients, and Regeneron's dosed more than that. I'm not only allowed to present the first 12, but mostly they seem to be doing well. So the problem is going to be, where do we go from here? Are we going to do other genes as well? And there are people working on lots of other genes. Everybody's working on GJB2, which is the gene that's the most common cause of sensorineural hearing loss, the connection 26 gene. But we know that in animal models, in mice models, you get death of other cells as well. Once you lose function, for instance, GJB2 is involved in keeping the endolymphatic potential at plus 80 millivolts, and if that goes away, then other cells start dying too. And in animal models, that happens very early on, like within first month of birth, and which is equivalent to newborn in humans. So some of these, so not every gene's been studied, but these genes all had normal hair cells. These genes didn't have normal hair cells at birth, and this GJB2 is one of them. So are we going to have to get them earlier and earlier, or is there some other way for us to mitigate that? So that's going to be a problem for us in gene therapies. Can we afford them? So these are the gene therapy prices in some of these that have been improved in the UK. They may not be what the NHS is actually paying, because they might have special. These are the list prices. Are we going to pay 1 million, 2 million pounds for a gene therapy? I don't know. I mean, maybe for rare cases it might be justifiable, but if you're going to have GJB2, you're going to have thousands of cases. Who's going to pay that? And is it going to scale down the price? We know that for pharma, with drugs, once patent expiry happens, the prices tend to come down, etc. That has not happened with cochlear implants, has not happened with auditory implants. We have not seen the scaling procedures in pacemakers and things like that. So in medical devices, we don't see the same scaling laws, and I don't know which one this is going to follow. So we need to find better ways to do this that don't involve AAV, because that's just a very expensive vector to try and develop. Maybe lipid nanoparticles, things will come down the pipeline. So the future is finally here. All my life, it was always 5 years away, gene therapy, and now it's here. And I was a bit shocked myself, actually, to see good results, because, you kind of always expect it to fail, because everything else I ever went to always failed. But anyway, how do we get ready for it? And this is our challenge of the next generation. So I think we need to start thinking seriously about these kinds of things. And with that, I'll stop here. Thank you. No?
Amazing. Thank you, Manon.
Okay, thank you.
And now it's time for a break. I don't know what you can do in 4:30. It's again upstairs at the tea place for the trade.
Oh, Robert is here. That's good. We're waiting for the master. Give him a few seconds. Here he is. Good. Mr. President, thank you. On behalf of us, I would like to welcome you to the hearing session, and I gratefully thank Robert to start this experiment with you, having the hearing group for a roundtable which should be interactive. May I ask the panelists to come to the podium? And I think while they are in preparation, yeah, you can wear it. While they are preparing, I get a little bit of information what's about hearing and about the aim behind this experiment, which we have done a few times before. And we will focus in this roundtable on Tympanoplasty around the world. We have a lot of discussion in the morning where different aspects were discussed, and we thought about separating the Tympanoplasty into four phases. We have five speakers. I forgot one. Yeah, you were late. Xavier, forgive me. Well, by the way, he's the vice president of the hearing network, but anyway, we can forget him. Copy paste. We have no conflicts of interest, and hearing is a group of 36 comprehensive hearing centers around the world. And as I said, we want to address the different aspects of Tympanoplasty, which, as a German proudly is announced, comes from Wollstein 1952. We will discuss different materials, and we will have a first lecture on the opening by Dennis. He is not chosen by chance for that, because he is French and he loves endoral incisions. So we want to have some controversies, and then we will have a discussion with you about the aspects and questions. Then Prep will describe transplant and implant materials, which are also used differently around the world. About the reconstruction of the prosthesis, we will hear Robert Vincent and Javier, whom I forgot it in the introduction, because he has the most important topics. He will put the finger on controversies and how solutions could look like, and I will talk a little bit about aftercare. The idea is to have 5 minutes impulse presentation, and then 10 to 15 minutes of discussion and questions with you, and hopefully each aspect will give some information to take home for everybody of you. So I'd like to welcome Dennis. Yeah, well.
Okay, so Joachim asked me to speak about external surgical approaches. So to the middle ear and mastoid, we have three external approaches: the transcanal one, the endoral, which is usually minimal, but you can extend the endoral approach on the retroauricular. Then the regular retroauricular approach. For choosing what is the best, you have several criterion, like size and location of the perforation or retraction pocket, the presence of cholesteatoma and or the need for a mastoidectomy, the ossicular change status, and the anatomical consideration that you can see with your otoscope or with the imaging. For the retroauricular approach, in the department, we use this approach for all the cholesteatoma surgeries, except if we use the endoscope. For the large perforation extending anteriorly to the Malleus handle. Okay. For revision surgery or the need of for wide exposure, and also if we have to harvest cartilage from the pinna, we prefer to do the retroauricular approach. For the endoral approach, we use in the department the endoral approach for working on the posterior part of the tympanic membrane if we don't need to reinforce the anterior part of the tympanic membrane. For ossiculoplasty, and in case of narrow canal that limit the exclusive transcanal access, but we perform very few transcanal access. The exclusive transcanal approach, we use that in the department for quasi-exclusively transtympanic fat meringoplasty. Okay, but when you see the skills of the player in Marseille, you can see that you can go, you can do a lot of things if you have been trained for, because it's difficult. It's difficult. That's it for me, so we can launch the discussion.
Yes. What are the panel? Please comment on either way of incision.
Well, in the clinic, also with...
Tu le mets à côté.
And so we use especially transcanal for, as you said, tympanic membrane perforation, including I use for anterior perforation, but it's a personal view. You have to drill out the anterior wall, and the problem of drilling out the anterior wall is the TM joint. You have to be very careful about that. You never know exactly how to approach, but it's more transcanal. I know Thibaut is using more posterior, and I don't think you use endo, Thibaut? No. So we use transcanal or posterior.
Thibaut, why no endoral?
First, because I was not teach for that. I never performed endoral approach in the Portman school. It was transcanal or posterior approach.
Javier, what's the situation in Spain?
Well, I don't know what's in Spain. We have more Spanish here to speak about, but I can tell you what's my experience. I'd rather have, for tympanoplasty, I'd rather have retroauricular, postauricular, for stapedectomy, transcanal, and sometimes, very few times, endoral.
Well, in Asia, I think more and more people are doing endoscopic transcanal. Even if the subtotal perforation, people are moving towards endoscopy now. And the younger generation who grew up with PlayStations and whatever not are very comfortable in endoscope. So the vast majority of people in Asia are doing endoscopic for TM, simple myelingoplasties. So the post-auricular will always be whenever there's mastoidectomies and things like that involved.
So we have the younger people in the audience. So are you trained with PlayStation to be trained in ear surgery? Who has a PlayStation at home to be trained? Any programs available?
You're young, I see.
My son.
Okay. You want to comment on that?
I think transcanal, absolute transcanal is possible, is feasible for almost every meningoplasty, almost whole tympanoplasty. But I with you that sometimes, in my case, when I perform ossiculoplasty or I perform stapedotomy or stapedectomy. I use the microscope. I prefer it transcanal, but with the microscope. It's a matter of still going transcanal, but with another tool.
The approach is the same. The tools we use may be different, but the approach is the same.
Questions regarding the approach from the audience? Everything is clear. What would you use? Please. Fine?
But does it matter? Miguel?
Yeah, just. You want the microphone?
Yes, there was a
just
gentleman
a
in the
moment.
No, first you and then.
Okay, just a matter of terminology, because transcanal is through the canal. And through the canal, you can go endocanal, and you can go endocanal like Robert Vincent with a speculum or with an endoscope.
Yeah.
And you can go transcanal endorally, and you can go transcanal retroauricular. So I think transcanal is just to the canal. Endocanal is when you are going inside the canal with no incisions, no external, no endoral.
What do you mean by transcanal retroauricular?
Yeah, because you do retroauricular incision, but you are only working transcanal, just through the canal. That's the terminology. I mean, it's something. Sorry.
Take the microphone, please.
I think it's just a semantic. Permeatal is a term that's used for, transcanal, as we're using it, transcanal. But permeatal is through a speculum, or it could be an endoscope. Transcanal incision.
I think the most important thing is correct. Someone say there. Most important thing is adequate visualization so that you can deal with the disease, and that's where you have to alter your approach, possibly, to get adequate visualization. And the endoscopic surgeons feel that they can get that endoscopically most of the time. In Australia, there's a lot of patients who have a degree of exostoses, narrow bony canals, and need a generous canalplasty as part of the procedure. And that's a good reason to either make an endoral approach or a post-auricular approach, I think.
I guess at the end of the day, it's whatever works in your hands. So as long as it works, the end is justified, I think it's fine.
I agree that whatever works, but it's not exactly true, in my opinion, that looking down the canal with a microscope is the same as looking down the canal with an endoscope. For example, the anterior bulge that I grew up with. So I grew up with transcanal when I took over from John Oates at Burton. But now I do most of my middle year stuff with the endoscope because the anterior bulge almost stops being a problem when you use the endoscope. And I also work in New Zealand where we have a lot of exostosis. It never is a problem with the endoscope. You get a far superior view, I think, of the middle ear with an endoscope than you can get with a microscope.
Yeah, I mean, that is a question of training. I like the structure of Dennis because I'm older. I never used the endoscopes for middle ear surgery because of the binocular view, but I've learned and heard that you can get an assessment of the depth, but visualization and choosing the proper approach, I think this is the key. And
I think when we started ENT, my first 1-2 years, we didn't have an endoscope. So we were doing catwalk lock, we were doing even nasal surgeries with a headlight. But subsequently, when the endoscope came about and everyone examines the nose, I'm talking about the younger residents and all that, with a camera system. So in their mind, they're already used to seeing a 3D anatomy in a 2D camera system. So when they move, that's what they were exposed to from residency. So when they move to surgery itself, looking into the middle ear space with an endoscope onto a flat screen, they are able to convert it into their mind to 3D because they were exposed to it from the very beginning. So I think it's about what you're used to, what you're exposed to.
Can I ask a question to the audience?
Yes, please.
How many of you are using routinely, let's say at least 50% of the time, endoscopes for the middle ear surgery? And how many are not?
So it's still more not than.
Yeah, but how many of those who are using routinely endoscope sometimes have to move to microscope? How many of you? This is important. It means that you need to learn both techniques.
Yes.
Because if you learn only the endoscope, then you have a problem. If you don't know how to use the microscope, then it's becoming a problem, especially for the cholesteatoma, I guess.
Well, I think that's what Dennis said. No, that wasn't sign for me to go to the next speaker.
Sorry. You need
the
help.
secret charming person behind.
You make the better choice.
But I think what you said, that the endoluminal approach can be extended. So depending on the pathology, you start with an endoscope and end up with a microscope, or modify the incision. So we have a common sense. Everything works. And maybe the choice of approach has to do with the pathology and with the transplant and implant materials that you want to use, and to hear little bit about the different materials, hopefully creating even more controversial discussions with prep. Thank you.
So I do skull base for a living, but now I'm going to talk about tympanic membrane reconstruction. So the topic that I'm going to speak on is actually the tympanic membrane reconstructions and what are the things we use. So we know the tympanic membrane is 9 millimeters in diameter, that is 0.1 millimeter in thickness, 3 layers, epithelium, fibers, and the mucosal inside. If you have a perforation, it can heal spontaneously, which means that the fibrous layer is missing. You get a much more thinner epithelial and the mucosal layer. We can repair, and the idea of repair is basically to have a scaffolding. So the idea of repair is to have a scaffolding. We did some work for the epithelial migration. So these are the publications I've had. So one of the things we looked at was to see the epithelial migrations on a normal tympanic membrane and compared to a post-Tympanoplasty tympanic membrane. And we found that the epithelial migrations were identical. And these were the times when we were using only the temporalis fascia. And we also found that the attic pockets have got slower migration, especially when the perforations are, or the pocket is small. That's why you have keratin buildup. So what we need is a graft that provides a scaffold for epithelialization. So we need something that is biocompatible, something that will give a similar acoustics to the native structure, and also last long enough for epithelialization. Now we can divide this into autologous. The most common one will obviously be the temporalis fascia, the cartilage, perichondrium, vein. Fat, I've had a few patients with small perforations after fat tympanoplasty where they cough, they sneeze, poof, it just goes off. So fat is not something that I'm very fond of. And if you look at, there are some newer things as well, like hyaluronic acid, platelet-rich fiber. Now all these are way out of reach for the guys in Asia. Yeah, life is not that easy for us. So this is completely out of the way for us. So either temporalis fascia or cartilage and perichondrium. So this is probably a busy slide, but this is probably explains the best. The most widely used is temporalis fascia. It's got a low metabolic rate, high collagen rate, is easily accessible and available, and the success rate is quite high as well. The good thing about this is it doesn't damper the sound transmission, whereas cartilage has got a much higher success rate. However, it tends to be thicker. Therefore, there's much more sound loss compared to temporalis fascia. So again, if we look at a simple diagram, would be temporalis fascia will be easy, effective, low rejection. Cartilage is good for retraction. However, the sound loss is quite significant as well. So my personal choice, if we need, what we do in Asia is if we need to do a ossicular reconstruction, then we will do a cartilage because we will use the thin perichondrium for the tympanic membrane, and the cartilage will be available for reconstruction. That's what I usually do. And it's because I do endoscopic for middle ear, so most of the time I will take a cartilage. Life is difficult. Let's keep this simple. Thank you very much.
Well, I'm not sure if you have kept it as simple as it might be. What are your preferred materials, Robert?
I prefer perichondrium. as you said, compared to cartilage, because it's much thinner, elastic, and it's easy to use, and it's healing very well. Cartilage I don't like too much because I could see that there are several cases of some residual hearing loss. But it also depends on the way you use cartilage, because if you trim it very nicely, then it's better. But some people use the cartilage. I saw that, like this, and just put it in the middle here. It's very bad.
But it heals very well.
Yeah, but the sound is not good. And then when you revise that, it's just a nightmare. So.
Well, I totally agree with Prepa for the first time. Well, I think in my hands what works better is fascia, temporal fascia. But if the perforation is big and you need some more support in the attic or something like that, cartilage is the top. I mean, it goes very well as long as you do it thin, just to avoid a big block on the ear. And perichondrium only when I don't have a retroauricular incision and I can have a harvesting of the perichondrium. I may use perichondrium, but I prefer temporal fascia as a routine procedure, unless for large perforation.
Dennis?
Well, I guess I didn't use any more the fascia, except for revision if I need something. I always use cartilage, thinner cartilage, with perichondrium for tympanic membrane perforation.
Yeah, tympanic.
Okay. Yep.
Does it play a role
well,
as?
In fact, I was with my mentor at the end of the 80s, and we started the cartilage use with full thickness cartilage, okay, for residual perforation, revision, for retraction pocket, it's normal, and then we moved to cartilage all the time. All the time we use cartilage in the department.
As Prep has discussed, he made a difference in the tympanic membrane repair if he needs to also reconstruct the ossicles. This will part of the next talk, but does this affect the choice of your material?
Yes, the good thing about post-auricular and endoral is you have everything in front of you, the muscle, the fascia, the cartilage. So if you're doing endoscopic and you need to harvest something, so you want a minimal, there's no point doing endoscopic if your incision is going to be big. The entire reason of doing endoscopic
this
is to have
speaks
minimal.
for post-auricular incision instead of transcanal to have the materials ready.
Exactly. Yeah, but then you can always do a tragal,
yeah,
a small incision, and you can take the perichondrium and the cartilage, and that's adequate for you to do whatever is required.
Well,
we don't have the money that Europe has got for all the prostheses and whatever not. So we have to rely on the cartilage.
If you what would you prefer, tragus or contra
Tragus.
cartilage?
Tragus, yeah.
Why?
Maybe I'm just more used to tragal cartilage. I think it all depends on what you are experienced to. And the tragal cartilage has got some amount on concavity as well. And that can be quite useful for you to reconstruct the ossicles if required.
Questions regarding transplant materials from the audience?
For the
or comments?
question of tragal or concha,
yeah,
okay, for the cartilage, I think that tragal cartilage is better for tympanic membrane reconstruction, and the concha is better for canal wall reconstruction because it's the curve.
Yeah, I agree. This is a good point. And for the tragus, you have perichondrium on both sides, and you can peel off one side, and you double the size of your transplant.
I was doing that 15 years ago.
Okay.
No, I changed because when you
butterfly, yeah,
the cartilage, and if you want to thinner the cartilage, it make a chips.
Yeah.
So if you want that your cartilage stay plan, you have to remove all the perichondrium. All the perichondrium, I guess.
To avoid.
I used the cartilage in full thickness at the beginning, okay?
Yeah.
But it's more difficult to manage that when you make chips of cartilage that you can put in a mosaic.
Yeah.
Okay. about, you said the acoustic properties of cartilage. I was 15 years ago, maybe 10 years ago, with the colleague from Cologne, Untenbrink.
Hittenbrink, yeah.
Okay, Untenbrink made a lot of works on the acoustic properties.
Yeah.
Okay, and he said you have to cut the cartilage 0.3 or 0.6 to have the better results. And in a meeting, I presented the cartilage myeloplasty in full thickness. That's what we were doing at this time. And during the meeting, I said, I don't understand, Carl. You said, but with our technique, we have very good results. And he told me, yes, what I told is in the lab, but on the patient, it works.
Right. So, Manoa, yeah. Comment on the middle ear mechanics and the tympanic membrane.
Yeah, I mean that's exactly right. I mean, if you look at I did a ton of this work in middle ear mechanics as well, and we did a whole series of publications on thickness of cartilage and where you put it, and it does make a difference in the temporal bone lab. But clinically, all the systemic reviews seem to show equal results in terms of where it makes a bigger difference is if you're touching the edge of the annulus. If it's in the center, you can put a concrete block in. It doesn't matter because you've got nice. It's really the baffle effect that you're trying to avoid. So it doesn't matter if it's near the center. But if you're going to touch an edge, then having a flexible boundary can have an effect on the low frequency.
Of course, usually we don't touch the edge, and I performed the Highland cartilage like Donhofer, I think.
Yeah.
Okay. But it's very difficult. And it's difficult to transmit to the young surgeon.
Yeah, please, question.
So regarding that touching the edges, what we usually do is we slice the cartilage. We remove one side of the perichondrium. We slice the cartilage, and then we remove part of cartilage from the edges.
Yeah.
It's like an island. So that perichondrium part we rest on the canal wall, and the cartilage part stays in the middle. So then it's not touching the bone, and it's not hampering the movement of the cartilage, and then it's perfectly fine. The results
This
are
is
good.
perichondrium cartilage island technique described by Milewski 82. But that's what Manoa said is important, that if you have a fold in between the annulus, this is similar to what Bekeshi described as a movement for the regular tympanic membrane and the model behind, and that works. Questions from the audience, comments?
I just want to know for each of you, can you put the before slide before of this? Yeah, in that big perforation, I just want to know for all of you the approach and what do you use, and if you use cartilage with perichondrium or just cartilage.
For me, with this situation, I make a circular incision in the canal, and then I will use a bed of connective tissue, perichondrium or fascia, but I will put cartilage on this bed, this hammock, and then put connective tissue in front of the perforation. It's like a McDo. It's a hamburger.
Without gel foam.
Without gel
Without
foam.
gel foam.
If I need to support the cartilage, I use a thin cartilage, which I put medially to the graft. Okay, we call that the bending cartilage. Okay.
Prep, what would you do for the lower case?
So, assuming the ossicles are intact, we will use perichondrium with a very thin layer of cartilage in the center. And the success rates are very good. With the cartilage and perichondrium, I think they last longer. The scaffolding of a perichondrium and a cartilage lasts much longer and allows epithelialization to occur. A temporalis fascia maybe does not last as long, and maybe that's why the scaffolding it provides is not long enough for the epithelium to regenerate itself.
I will also use a post-auricular incision, cartilage with perichondrium, and I think it's extremely important to revitalize the edges of the perforation in such a large perforation, because otherwise you will not get a healing. But if you use cartilage with the perichondrium unfolded, in my hands, that works much better than before using gel foam and temporal fascia. That re-perforations or remaining perforations, even smaller, were the rule.
So what I do in this case, I do a 360-degree incision, elevate the whole flap, and remove the whole flap, and I call it a total flap removal. So then I have the bone and I have the ossicle. Then I put my graft over the bony canal wall, over the Malleus handle, and over the bony canal wall. And then I reposition the tympanometal flap. I call that the total flap removal. And when I was starting to do this, I was thinking that I will have the problem of lateralization of the, and I had few cases. And then Benoit explained that the way to decrease this risk was when you put back the graft and then the flap, you have to fill the entire anterior angle, even the canal, with gel foam. So I put now 3 silastic sheets, 1 in contact with the graft and 2 around the canal, and then I fill completely the canal. I think you saw that with gel foam to hold the graft in position, and then I put a mirror cell.
Just to be clear, you remove the whole skin.
The whole, yeah. It's like a skin grafting, a free skin. Yes.
Okay.
But I think the problem with lateralization of the graft is it's after time. So it's even if you keep it at the beginning there, it will.
No. I had the big difference, really, before and after this technique. When Benoit trained me and explained to me how to do it, when I started doing it, I decreased a lot the incidence of lateralization. Of course, I have some still, but not the same amount. It keeps in contact for some time. So. And I thought there could be some necrosis of the skin also when I was doing it, but there's no necrosis. I never saw it.
No, that's surprisingly. I just want to add a comment. Robert pointed out an important thing. That's the anterior annulus. And one dogma in our school was not to touch the annulus. And many schools have this.
It's a German school.
Yeah. But sometimes when you grow up, you move away from your school slightly. And what we did is also to remove the annulus, put the overlapping perichondrium, like Manuel described, underneath in the bony annulus, and then the important thing is what you said, to replace the annulus in the same position, and then you have no lateralization. So that's the key point, I think, in this perforation, to get no reperforation, to be fixed anteriorly. And for that, I would use the post-auricular incision. But there were questions from the audience and comments, please.
Yeah, in defense of the endoscopic surgeons. Can you hear me?
Yeah, what materials would they use?
We use biodesign, which is dissolvable, or thin cartilage with perichondrium from the tragus.
How you get underneath the annulus with the endoscope?
Yeah, you make a little pocket anteriorly, so you don't lift the whole eardrum, you lift about 80%. And then you make a little pocket anteriorly and pull
through.
And pull through. Yeah, that's a little.
Pull through, Gerlach. Yeah, please.
Sorry, my question is similar. I would like to ask the panel about their experience and their thoughts about using the synthetic or biological graft like biodesign, which is quite common with endoscopic surgeries, endoscopic tympanoplasties.
I have no experience. What is your experience?
I haven't any experience, so I don't know.
I use artificial material, Leodura, they call it a long time ago, and it didn't work well. I mean, if you have natural material, fascia and perichondrium works much better than artificial tissues.
I don't think we can afford very much of this artificial material, but we are open to donations if you would like to donate any to us.
No experience. No experience.
No experience. Okay. Please, last question, and then we move to the next topic.
Thank you. Double question. Do you think poor eustachian tube function has
a role in failure rates? Does it influence your graft choice? And do you think there's ever a role for balloon tuboplasty concurrently with tympanoplasty? 3 questions.
Absolutely.
Yeah, absolutely. But the problem is that when you have a perforation, you don't know about the eustachian tube. So you know about the eustachian tube when you close the perforation, most of the case. So it's a problem. When you see the retraction, it's one of the major causes of failure. I'm sure about that. What? So would it?
How can you assume? Yeah, please.
Yes.
So would you lean more towards cartilage in that scenario?
One of the first thing and the most basic, take a look on the contralateral ear. Good. And the second one, we have been following, I would say, more than 600 patients with chronic otitis media like that. And we came to the conclusion that you have 2 kinds of perforations. The first one, like that one, it's inside-out perforation. It's like an accident. And like the second, kind of like the second one, it's outside-in perforation because it developed from a retraction. And this is much more complicated to treat, and that's why I think the cartilage is a good idea, because it's the most resistant graft to hold the possible pressure, negative pressure. Of course, we can't say for sure that there is the eustachian tube dysfunction, but you can assume if you have both ears, if you have the patterns of the outside-in perforation, that probably the function wasn't that good at some point in the life. Well, again, you can look to you see, they are completely different. You know, if you spit in the first perforation there, it's going to close. And the second one is a different ballgame.
You can also look at the CT scan if you have one, because if it's pure pneumatization of the that they must have had poor ventilation during growing up. So if they've got good pneumatization, they've had good eustachian tube function.
But if you're uncertain, I think general agreement is that cartilage would be in the big perforation a good choice.
A lot of people do this in the US as an overlay technique. You know, just lift up the whole outer
Overlay.
layer. Yeah, lift up the outer
Okay,
connector
let's
layer.
let them make the same mistakes like in the 50s. Please. Last question and then.
Thank you.
Last question and final comment.
The last question is, at what age do you prefer to do a pediatric tympanoplasty? Because I think the age is problem for recurrence of diseases, for re-perforation.
Yeah.
Do you, before tympanoplasty, provide any surgery of the nose, nasopharynx, I mean, adenectomy or no?
Let's start with the answers from the panel.
Of course, if needed, to treat the nose before treating the ear. First, for the age of children, there is no question if it's a retraction pocket or cholesteatoma or whatever you want. And for the perforation, in France, we are used to wait about 7 years, after 7 years. Hold.
Usually, we will have to treat the nasopharynx first. So if the middle ear space is dry, then we can assume that the tympanic membrane, the eustachian tube is functioning. If there's a persistent discharge from the middle ear space, then you have to assume that the patient has got some amount of nasopharyngitis or adenoiditis or adenoid hypertrophy. Then you probably have to give some nasal steroids and so on. So it all depends on the case, but we will not operate below the age of 7 or 8.
We neither. I mean, we don't think the nasal surgery is really having a serious background for doing that. I mean, I don't know if other than charging twice, as you said before, it's any other reason for that. And again, if it's a big disease, it's cholesteatoma, you do it anytime you need. And if it's just to close a perforation, we wait until the age of tonsils to adenoids retract, so it will be like 7-8 years of age.
I'm sorry to say that I have to agree this guy supporting the PSG.
Well, I have a comment on that. We did an analysis of our tympanoplasty database with Helms in 1999, and we found no difference in reperforation rate depending on the age of the children, if we do it at 5, 7, or after puberty. That was surprising because TOS reported other situations. So for us, the age is not important. What we do is adenoid removal prior to surgery if there's a clinical course. But from that, the only criteria is that the child is cooperative for aftercare. But we could not confirm that depending on the age, we have higher reperforation rates. So with 7, we are fine. Maybe if the child is a little bit more behavioral, then 5. And for cholesteatoma, as Dennis pointed out, anytime you have the diagnosis. Okay, then keep the questions. After the next talk, we will hear about ossiculoplasty and how this may affect our procedures.
So that's the point. And I fully agree with the comparison between mechanics in the lab and mechanics in life. And what I'm going to show is the way I do it in very fast presentation, if I can. And it's, I mean, whatever type of material you use, I think it's more or less the same. That's what I think. It's a question of stability for me, which is the most important thing. And what was driving my experience and my evolution in these techniques of ossicular reconstruction was to find 2 things: the ways to stabilize the prosthesis, how to fix it, because it's a nightmare when you do this reconstruction and you have a recurrent prosthesis dislocation, whatever you do. So I was thinking a lot about this point. And then the second point was to place the prosthesis also in a vertical position, because we know that the more we put the prosthesis like this, the more is efficient. So I'm going to go through the different situation, and I'm using a classification for that, the Austin cartouche, which is not a perfect one. There's no perfect classification because there are so many different types of ossicular problem. Like, for example, when the Stapes superstructure is absent, eroded, there's no classification for that. So it's a complex one. So basically, we could say that in group A, when Malleus and Stapes are mobile, in the past I was using PORP, and I moved progressively to TORPs because I was following Bill Moretz from the US, who was one of the first to introduce the possibility to do that despite the presence of a stapedotomy. So I do a TORP now for Austin cartouche group A, and I never use, or nearly never, PORP. But that's, again, a personal view. And I compare my results before and after, and my results were published, and my results were better in my hands. So I moved to TORPs. Like, because this is what we call about a tilting movement. When we put a TORP like this, it seems to be fine, but there's a tilting, lack of energy. It's clear that with the new PORP, with you know, the clip PORP from Medel and other one, and Kurtz, they are much better. And I prefer hydroxyapatite because, as I said, you don't need cartilage in deposition, and you don't need cartilage in deposition, and you can trim it. But that's, again, a personal view. For Austin cartouche group B, I use TORP. There's no no discussion about that. I mean, everybody agree. But I know that some people don't use Malleus handle, and that's one of the, I think, important point. Do we have to use Malleus handle? My answer is yes. I think as soon as we have the Malleus, we have to use it. But that's the personal view. So, for example, in this case, this is a group B with a mobile foot plate without any residual ossicle except the Malleus. There's no superstructure. So for sure, I will put a TORP with the Malleus relocation that I described this morning, so you saw it. So by repositioning the Malleus, we put the Malleus over the footplate, and then we can measure accurately the distance from Malleus to footplate, and then we can cut the prosthesis. I'm looking for this kind of thing at the end. Whatever type of prosthesis you use, in my opinion, if you use a TORP, you need to find stability, how to fix it. This is why I use prosthesis with a groove at the prosthesis head, and how to stabilize. But if you don't have Stapes superstructure, there's no way to stabilize the distal tip of the prosthesis. Even if you use the shoe, like Kuntenbrink was introducing it, the problem is how to stabilize the shoe. It's a different thing. It's always the same thing. I know that some people, when we have that, do a Stapedotomy on a mobile foot plate. But sometimes I do it, very rarely. The group C is when you don't have any more Malleus and having a mobile Stapes. So for sure, you can move to PORPs or TORPs. And for the same reason, I use TORPs because I introduced the sylastic bending technique. So I stay in the same direction because I was able to follow my results prospectively with my database. So I never came back to PORPs, in fact, except when we got a very small distance from Malleus to Stapes foot plate. Then in that case, if it's less than 5, I prefer to use PORP. So sylastic bending, maybe tomorrow I will describe that, but I'm sure that many of you have seen my technique with that. So that's the point, to stabilize the prosthesis. Again, the group F, I'm going to go through this without any description. We all know about that. We do stapedotomy and Malleus to stapedotomy if there is an erotonicus, like in tympanosclerotic cases like this. And as we discussed, the problem with tympanosclerosis is that we have a completely different situation completely different than otosclerosis because it's huge, frequently not completely hard, but it's really harder than obliterative otosclerosis. But I use the same technique, enlarging the draining out until I approach the membrane and then opening up the membrane at the end and then put in a torp like you saw this morning, but in a regular fact. And then again, because I've relocated the Malleus again at the end, I introduce the Malleus within the groove and I have a vertical position. Always the same thing, stability and efficiency. And finally, the group D, which is the worst situation, when you don't have any more Malleus and any more superstructure, only have a mobile foot plate. There's no way to stabilize this prosthesis. You put a prosthesis directly from tympanic membrane to foot plate, and for me, it was a nightmare. I tried to find a solution for that. Some people would do stapedotomy on a mobile foot plate, but I think it's not really good. It's only to stabilize the distal tip of the prosthesis, but you cannot stabilize the head. So that's the reason why I was introducing the Malleus replacement prosthesis, you know this one, to rebuild the new Malleus, to recreate the point of stability. And interestingly, when I created Malleus replacement prosthesis, it's only because I didn't believe in mechanical effect of the titanium. But I was thinking of putting a new Malleus when the Malleus was missing to stabilize the prosthesis. So I'm using it as a stabilizer, if I can say that in English, to stabilize the position of the torp, to fix the torp to a new Malleus handle. That was exactly the idea that I was thinking about. I know that Fish was thinking about another different technique, but it was a very complex one, didn't work well. But of course, at the end, you can see the difference. If you put something to rebuild the Malleus, at the end you change the group and you move from group D to group B with a better chance of success. So thank you, that's it.
Let's say a little bit about stability.
I'm not so stable after seeing this presentation.
Oh, you don't use prosthesis?
I do, but we usually only for those who can afford it. But I think that's a fantastic presentation. I don't think I'll be able to reproduce anything like that.
Me neither.
Questions from the audience? Yes, please.
Well, my question is regarding staging. To stage or not to stage the surgery? Like if you have a large perforation or a diseased mucosa, what's the rationale to, I will do the reconstruction or I will stage for another moment?
This is my topic. This is the controversy. No, but we can go on. We can go on. I mean, all of them are my topic. So
if I have a perforation with a Stapes fixation, I stage. And in the most other situation, I don't stage. I mean, what is the risk? If you have a dislocation, then you can do a second stage, I would say. But if you can avoid the second stage, do it in one stage. That's what I mean.
Well, I was trained that you will never open the inner ear in an infected ear or an open ear to the outside. So I will never do a stapedectomy at the same time as a tympanoplasty. And concerning the other staging, well, it depends on a lot of different factors. I mean, it depends on your patient. It depends on the disease. If you have a cholesteatoma and you're not sure whether you remove everything or not, but the patient lives 5,000 kilometers away and will never come back, so you have to do everything in one stage. Otherwise, you may stage the operation. So it depends on so many factors that this is why we are still discussing about that after 45 years.
In fact, I do the same as you, but there is no evidence that it's mandatory not to do stapedotomy with a perforated eardrum. We think it's better to stage. But there is no evidence because the risk is infection, but infection they are already in the middle year. So I mean, it's just.
I mean, this is why I said I was trained with that, because I'm not sure whether this
it's
is
better
right
because
or not.
if you go in front of a judge, the judge will ask you why you.
What you did open the
medical equalities.
I have a question. Yeah, please, audience first.
Yeah, my question is again with the panel that with the osteoplasties and even stapedotomy, what will you call success in terms of audiometry? And also, I mean, subjectively, if a very large airborne gap, even 20 dB improvement, patient will be very happy. But what will you call a successful operation?
If we stay basic, success is an airborne gap of less than 20 dBs. For me, a success is when a patient said, "Thank you, doctor."
You know, the problem is that when we talk about stapedectomy, the situation is more or less the same all over. I mean, but here it depends on the situation of the mucosa, if it's an inflamed mucosa or it's normal mucosa, on the absence or presence of ossicles. So what Denise says is absolutely true. I mean, you cannot measure like you do for stapedectomy 10 dBs, 20 dBs or less or more. Is the patient being satisfied? And you have to take into consideration also the long-term run, because the long-term run of ossicular reconstruction is not the same as the long-term run of stapedectomy. In the end, results go worse and worse over time.
I think we are all fixed to this idea of getting an airborne gap closure of less than 20 decibels. But if you look at what the patients want to be able to hear. So I've got patients who we have just barely made 20 decibels, but they say, "Thank you, doctor, I can hear my child cry. I can hear the fire alarm, I can hear." So it's very subjective. So I think it's very difficult to, it's very difficult to do that.
And conversely, sometimes you see patient with a closed airborne gap, you said, "Oh, I'm the best." And the patient said, "I'm not sure I hear better."
I think one of the thing is we should not report on success, but only results. My teacher told me, don't speak about success, report the results and let the others decide if it's a success or not.
It's about the same as the quarter tympani on Stapes surgery. Don't ask your patient post-op if he is having any problem. If he has, he will tell you. But once you start, "Oh yes, doctor, I have a problem." Now you ask me, I have. So.
Good question.
Yeah. How many of you use the incus to do construction? The incus in this case with the malleus and the strip.
So what materials do you use? Incus or other prosthesis?
Or how much do you use the incus? In case if you have the TORP, do you prefer incus or not? Or
I prefer no incus, no TORP, no POP where there is a Stapes. Sometimes we use the incus to learn the resident to drill an incus, okay? But we use systematically the double block of cartilage on the Stapes head with very good results. It's natural, it's costless, even if I work in Rothschild Foundation, okay? And it never extrude. On the other way, if there is no Stapes, I use titanium prosthesis and I don't care of the Malleus. It's a struggle with Marseille.
Yeah. But that's another similarity between France and Germany, at least with Paris. We don't care about
Paris, not France.
Well, I think
Paris represented France wonderful at the Olympic Games.
I think incus transposition was a very good approach. The problem was when there was cholesteatoma, you shouldn't manage the incus if you still have cholesteatoma. They may be inclusions, cell inclusions in the bone. But from an extrusion standpoint, it was much better than the artificial prosthesis. But the fact is that it's much easier to open a prosthesis than to carve a good incus for just to put it as a transposition. But I still like the incus as a good material for hearing reconstruction when it's available.
Okay. I saw many people moving their head and agreeing with what you said. So I apologize. You have missed your topic. You should point out the controversies and please continue and put the finger for the...
Okay, can you hear me? Yeah. Okay, so, well, first of all, Robert, thanks a lot for allowing the hearing to be here in this conference. Congratulations for 25 years, and here's to the next 25. We hope to be here for the next 25.
Look pretty old for a 25-year-old guy.
Okay. Anyway, this topic is very appealing to me because it makes me go back to when I was 25. When I was young, I learned everything I know about middle ear surgery, and this course, this is me in 1982, and I learned everything from middle ear surgery.
You didn't change at all.
Yeah, well, that was me. That was my father, and my two teachers were my father. And you know this guy, Robert? He's Toño de la Cruz. He's Antonio de la Cruz. He was a very close friend, and he was a master. And well, 16 years after this picture, we were sharing together conferences on the same topic. But you know, time is cruel, and 45 years later of this time, persons have changed. In fact, Toño passed away, unfortunately, several years ago, and others became a bit older than before, but keep quiet because controversies are still the same. So I have been discussing for 45 years the same topics, and they are still here. So there are classic controversies, and I will just let you know what they are, and we'll discuss later on. Canal wall down versus canal wall up, mastoid obliteration and posterior wall reconstruction, one stage versus two stage operation, operating a dry ear or waiting for the ear to, wet ear or waiting for the ear to get dry. Underlay, we discussed that. Overlay or under overlay techniques for grafting, and fascia versus cartilage versus other graft tissues that was also discussed before. And we have some, I wouldn't say new, but more recent controversies, which are basically endoscopic versus microscopic surgery, diffusion-weighted MRI versus second look, and subtotal petrosectomy versus conventional surgery. Just to give you my view after 45 years of reflection and discussion of these topics, I think both canal wall up and canal wall down have their indications, and if possible, I will prefer canal wall up, and we will see if this is agreed by the others. I don't like mastoid obliteration. I don't like posterior wall reconstruction in general, so they're not my favorite. I prefer one stage or two stages, depending on the situation, as we mentioned before, and of the patient and the disease. I'd rather go dry, but maybe going wet, it's also an option. I like it more underlay, but again, this is something that we will discuss one more time after 45
Are
years.
you going to politics or?
Yes. I'm planning. You know, my government is changing, so I'm planning to apply for.
No, you're not politic. You made personal surgery.
Absolutely.
And we are at the era of personal medicine.
Absolutely. So I think this is something that I think the era of the protocols and all people doing the same coffee for everyone, it's changed, and this is not the time now.
Javier, let's wait a moment. If we do personalized surgery, both have their indications. If possible, canal wall up down. Give us a little bit of guidelines.
Okay.
And then we hear the opinion of the audience.
I think it depends on the extent of the cholesteatoma, on the situation of the patient, and again, like we said before, it depends on how easily will you follow up this patient. If the patient is going to come to you and you are able to make MRI with diffusion weighted images, then you maybe keep the canal wall down and the canal wall up and keep a normal ear. But if the patient is going to go away and you will never see it again, him again or her again, then a canal wall down probably will be a much better decision. So it will depend on many factors. But I was waiting for the discussion, so I'm just showing you my basic ideas. And concerning the new controversies, and I don't want anyone to be mad on that, I'm too old to play the pirate. I like to operate with both eyes and both hands. Having one hand tied to the back and having one eye closed is not my idea of surgery, but this is just a problem of age. And of course, endoscopes are wonderful to show images and to teach people. But for surgery, give me both eyes and both hands. Diffusion weighted and versus MRI, it will be cholesteatoma dependent. I think MRI right now gives you a very good approach to cholesteatoma, recurrent or residual. And finally, I love subtotal petrosectomy in selected cases. For some patients, selected cases, subtotal petrosectomy is the best solution. In a nutshell, if we are still debating this after 45 years, maybe it's because multiple options are useful. The main difference between 1980 and today are hearing implants. Nowadays, in my opinion, doing more than 2 tympanoplasties for functional reasons, not for cholesteatoma removal, but for functional reasons, does not make sense. Once you have failed twice to recover hearing, there are other solutions, and these other solutions in radical cavities with conductive or mixed hearing loss and a draining ear, bone conduction devices, or sound bridge with subtotal petrosectomy are magic, at least in my experience. So the take-home message is beware of dogmas. There are no dogmas when after 45 years we're still debating the same topics. And in the literature, you can find arguments in favor of any option and also the opposite. So before telling you goodbye, you're all invited to the next International Facial Nerve Symposium in Madrid. It will be in September this year, 24 to 27. Madrid is very close to here. You can go. We will love to have you there.
Motorbike.
By motorbike, yeah. Well, actually, I did that for this meeting. And it's organized by Luis La Saleta and myself, and we will love to see you there. Thank you very much.
Thank you, Javier. Thank you for reflecting 45 years. And one conclusion I have is we have even more controversies than 45 years ago. So which of the controversies are you most interested in from the audience?
There are 2 things which I would like to talk about. One is the posterior canal wall reconstruction. It's something which gives patients a cavity-free ear. And you can just obliterate the cavity and then you can do a posterior canal reconstruction, whether it's by bone chip or with the cartilage. And it gives the patient a very good ear. And the patient is free. If he goes away, he swims, he does anything. It's a very good thing, because sometimes while we are teaching the residents, they open up the dura and the sinus. And while giving a canal wall down cavity, open cavity to such, does all the things. So it's very difficult. So if canal wall reconstruction is done, these patients are very happy with the results. So I don't see a controversy in constructing the canal wall again if we have cleared the disease. And the second thing is, you showed a picture of a pirate with the one hand and one eye. So if a surgeon is given the second hand, like nowadays endo holders are used, like endoscope holders are used, which can be mounted on the microscope, or they carry standalone endoscope holders. So you have both your hands. You have, because we are all trained in endoscopic sinus surgeries, so we have that advantage of using that knowledge for endoscopic ear surgery. So two-handed endoscopic surgery takes that disadvantage also of a pirate, and the posterior canal reconstruction takes the makes the patient very happy. So there should be no controversies in these two things. I mean, when we are looking at the evidence of this.
There should not be, but the fact is that there is. I mean, we are discussing about that because I'm not convinced, even if I'm a pirate with just both hands and even only one eye. I like the image. I like the image of a microscope because I've been trained on a microscope and I've been 45 years using a microscope. So I think the microscope for the ear surgery is a basic tool. And the difference between endoscopic sinus surgery and endoscopic ear surgery is that endoscopic sinus surgery moved to be routine in a very short period of time. Abdominal surgery became routine in very short period of time. And ear surgery, endoscopic ear surgery, is not yet having this speed. It's like thyroid surgery. Endoscopic thyroid surgery is not going like that. The same people that were doing at the beginning are doing now. And with the ear, it's maybe a little bit faster evolution, but the fact is that it's not so convincing that we all do that. So this is why it's a controversy. And concerning the posterior wall reconstruction, my results are very poor. Using or cartilage or there's prosthesis that hydrocelapatite prosthesis that reconstructs the posterior canal wall, and my results are not good. So this is why I'm not in favor of that, and this is why it's still a controversy.
But we have heard about curved cartilage from the concha for the ear canal reconstruction. So I personally feel this is a good option. Depending on the extent of the cholesteatoma, if you follow the philosophy of removing the cholesteatoma on the way of origin, and I think this plays also a role to decide which way you want to go.
For me, the main interest of the obliteration is to maintain the cartilage, not to obliterate the mastoid. I don't care about that.
In fact, sorry. In fact, it's better to support the posterior canal wall with obliteration than obliterating the whole cavity, because then the aerated mastoid, the principle of aerated mastoid, it goes away if we obliterate the whole cavity. So if we support the cartilage from behind and leave the rest of the mastoid as ear cavity, it is better then. So
yeah, but if you see these reconstructed posterior canal walls in the long-term run, it will retract and fall back to the cavity and will end up with, so to say, a smoothened cavity. So it really depends on the extent of how much you have taken down the canal wall. Yes, please.
But if you use cortical bone, that does not become a problem, because I just drill out a cortical bone, measure it, chisel it, and then basically make a groove and put the bone back in to recreate your posterior canal wall, and it looks fine. Because where I work, you cannot tell the children to not swim.
Yeah,
they will in New Zealand. They will all go to they swim in school in summer. Almost every week. So they won't listen.
Well, this is the argument for canal wall up or reconstruction of the canal wall. But who has experience with re-implanting the bony canal wall? What are your results? I know the results from Feldman in the early 70s, and they had a saw, and they cut out the wall, and then it was replaced and it was degenerated. So what are your results with that?
Yeah, thank you very much. Results are good because I always obliterate to the mastoid, and I fill the mastoid up completely because in time I used to not fill it completely, and then the posterior wall fell back, and now I do the obliteration with the bony ear canal, get out and then replace it. And sometimes you place muscular flap on top of it to vascularize it. So the result is really good in my hands.
Yes, of course, in your hand. The other case come from Alio Loco, as we have heard. Do you fear, or how do you control recurrent disease of the cholesteatoma? The main argument against obliteration is you grow and dig epithelium into the depth.
That's
and I've never seen it. So we do non-API MRI to check it, of course, to follow up.
But I draw.
But to control it, you fill the gaps. So sometimes fascia on it, or muscular flap, or you need soft edges. So no gaps, but only soft edges, and then it heals really good.
Well, with non-epi DIV, we have the pioneer here sitting on the panel. Coming last year from the course, I was very optimistic that this would be a good way of control, and there's a poster of Dr. Schreier and Dr. Sophia Gander outside, and when we looked at the own data in collaboration with our radiologist, this was just discouraging. So I think this is another controversial topic which needs to be discussed in the future, and so far our conclusion is second look is even more important, or we have to train our radiologists, or better classify.
Probably.
Another controversy I missed is the Eustachian tube dilation. I was in an American academy, and everybody talked about it. It was like the hammer and the nail, and I didn't hear about it. So in the Netherlands we don't do it, but in a lot of countries everybody talks about it.
You're still doing second look surgery, systematic revision second look surgery in Netherlands?
Not only for sometimes hearing improvement, but not to check cholesteatoma.
Not to check cholesteatoma. No. You don't have a recurrency. Residual disease.
Yes, but that's not second look. That's revision surgery.
So you perform the second look surgery?
No, I only do revision surgery when there's recurrence of disease.
Prep. When do you do second look?
It's a good question. So I'm looking at it in the context of Asia. Yeah. So I've had to revise surgeries done elsewhere where they've obliterated and there was cholesteatoma recurrence.
From Asia, so to say.
Yeah. So when there's a cholesteatoma recurrence after obliteration, it's an absolute nightmare, especially when you didn't do the surgery. So I've had the misfortune to brain abscess and meningitis because there was a cholesteatoma after an obliteration done by someone else. And for me to revise the surgery is an absolute nightmare. So if you obliterate and then you need an MRI scan to make sure there is no recurrence, it's fine if you're from a country where MRI scan, it's free. But for us, the patient has to pay. So if the patient has to pay for MRI scan, they will not come back. So I would rather leave the cavity open. I tell them if you want to swim, just buy the earplug, put oil and swim, and they are quite happy. So I think it all depends. There's no right or wrong answer. There's no controversy. It's luck of the draw. Where are you born? MRI scan is covered by the government, then it's fine. But if you're in a place like mine where it's not as hot as here, I think then you just leave everything open and it's much safer. But can I go back to something that Robert said that I agree very much? So Robert said that you must, even if you do endoscopic, you must be able to do microscopic, and I absolutely agree. A scenario came to my mind. So we've had this problem now in a neighboring country where the younger generation are doing endoscopic cholecystectomy. So they have not been trained in open because cholecystectomy is all done endoscopically now. Now when they have bleeding, they cannot control the bleeding. They have to call the senior guys to come and do the open one because they are not trained. So I think you should not do an endoscopic ear surgery unless you have done enough open surgery and you can convert if required to. Because can you imagine someone doing an endoscopic cholecystectomy, you have bleeding and you can't control the bleeding and the patient dies. The same thing can happen with us as well.
And I agree. Yeah?
I remember when we were, doing the Live International Otology Network Live. Moaz Tarabici was also trying to perform endoscopic removal cholesteatoma. So he chose atypical cholesteatoma, and of course he's very expert in endoscopy. But in 2 times, he had to move to convert to microscopy. So for the young generation, I think it is a very important message to learn both and not only one.
Well, I think about education, what you mentioned is, I think the three-dimensional view of the microscope is important. And what we have seen is a much steeper learning curve, and Robert Nusky in his department pointed that out at the Otosclerosis meeting. They have a 3D microscope and a 3D monitor, as we had with Helms in the early days. And the students learned faster if they had a 3D image of the surgery and could follow in 3D. So I think this should be the precondition to proceed in either way later on if you have experience in ear surgery. But a substantial education should be mandatory.
I won't be here tomorrow because I have to go back to Paris quickly because I have a match. But Jan Lazar will speak tomorrow about exoscope.
Yeah.
And probably the future is to combine endoscope and exoscope on the same machine.
I completely agree. I'm looking very much forward to that. We have more controversies tomorrow, and the exoscope is really a third alternative. So we have next year more controversies, but I'm looking a little bit on the clock to be on time. Well, it was intended to have a last presentation on aftercare. I just want to raise quickly some points, but being the last in the discussion row, the dog bites the last, and we have a little bit more of controversies between white wine and red wine in the evening. And I think this is more important.
I don't think there is any controversies in this.
Okay, then we close the day then with
maybe Jose Carlos can talk about that.
Yeah, well, just address that we have addressed surgeries, and aftercare is important. It is often underestimated, and there are some principles about the package. We have seen different types of packages. We are always using silastic sheeting. We'll use a proper bandage. We have seen today, Robert, with silastic sheets and the Merosale. We have seen Merosale without silastic sheeting. So there are many ways, and I want to just create a little bit of discussion what is known and what is feeling how aftercare should be. We leave the package for 3 weeks. I don't know how long you will leave it, but there are no hard data on how we should confirm the aftercare. Everybody does it in a way how he had learned it from the teacher, and somehow it works well, and that's how we do it. But there are no statistical data on available how we use it. So we use silastic, we do Weber and Frenzel, we do a tuning fork test even in an in or outpatient procedure, and we change the daily. When we have the wound control, we should also have a look behind the ear. This is a friend of Northern Germany who has sent this to me 2 weeks after surgery when the patient presented at him. Also alio loco. Granulations are removed with micro scissors or forceps. For infections, we give local antibiotics, and we do, if we have a reperforation, sheeting with cigarette paper. We use ointment and antibiotic drugs and silver nitrate for itching. One personal question: who of you has access to Solutio Castellani in original composition? We don't have it anymore in Germany because of the fuchsin is called to be carcinogenic. Has anybody access to Solutio Castellani?
Which millésime?
Yeah.
Huh? Which millésime?
Vaginal solution. No,
Okay.
I have no experience of vaginal solution.
Yeah, but it's a off-label use. And yeah, what is about
Castellani solution?
Yeah,
it was fantastic.
Yes,
to
it
try
was.
here. It was.
Yeah,
because it's no more available.
No, in
and
our
for
country,
my
not-
range is this.
Huh?
My rangitis.
Yeah.
It was very, very interesting.
Valsalva maneuver after ear surgery. What is your opinion?
No problem.
No problem? You force the patient to do it or you avoid it?
No,
Just normal, so as it is. Okay, airplane we have discussed in the morning, 4 weeks. Scuba diving is open. Depends on. We are in a lucky situation in Germany. We have special scuba diving doctors, and so we give the responsibility to them. They have recently made guidelines, though, that ear surgery does not speak against scuba diving, but the responsibility is not with the surgeon, but with a scuba diving doctor. And for aftercare, you need patience. It needs time to heal, and if you have no more question, yeah.
Thank you for opportunity to ask this question. My question about cholesteatoma, about pediatric cholesteatoma.
Yeah.
How long should be follow up after canal volap surgery in the cases of pediatric cholesteatoma, and when we can provide hearing reconstruction, because second surgery should be done for reconstruction if we have no any suspicion of recurrency.
Okay.
How long should be follow up before reconstruction?
Who wants to answer?
We wait between 6 months and 1 year for a second look.
Okay, for pediatric cholesteatoma, our database and the literature, as far as I know, says that you have recurrency between 18 and 20 months, at 5 to 7 years, and at 25 years. So you have to follow the patients lifelong, and we do always one stage and reconstruct in the first session. So there's, in our concept, no need for a second look, so to say, to do the hearing reconstruction. This is different in other schools, but then I would follow Javier and Dennis to maybe after 6 to 12 months for the hearing reconstruction. But for the recurrency, you have to wait at least 25 years, because there are published data from Scandinavia that you have peaks of recurrence at 2 years, 7 years, and 25 years. Please.
Okay, I have a question. What do you do with what do you do with those patients that you make a stapedotomy and you close the gap, but they are still complaining about the results, that they are not happy about the results, but you close the gap?
This is a question to Robert. We would send the patient to Béziers, and then we solve the problem.
I think you have a patient in front of you. And I said, some patient come, the airborne cap is closed. I say, so what, are you happy? Oh, I'm not sure. What do you think? I said, look at the audiometry test. I know that I heard better. Okay? So with the patient unhappy, you have to deal with, because it's very often, except if you have a complication, of course, but when you have a good result, sometimes you are surprised because the patient said, I don't know if I heard better. And you show the graph, and they say, yes, it's okay. And that's the way I do. And I don't ask too much the patient, like Robert. If they have problem, don't worry. They will tell you.
Well, if the patient is not happy, what sometimes helps if you do a speech audiogram and show the speech audiogram before and after, and can demonstrate in word understanding what the improvement was.
I have 2 comments for the previous questions. In Necker, that's the reference for pediatric, they recommend MRI at 18 months. if you can do MRI, of course. And when you have a nice result, but the patient complains, I ask a speech therapist to help, because sometimes you have, I don't know, plasticity reconnections that you need to help and train.
What is your detection rate with the MRI?
5 millimeters. So you have to be careful. It's not because at 18 months it's negative that you have to say, okay, I will see you later on. It depends also when you do the surgery. I think you have to write down within the report if you're happy with the removal, if you think you followed everything, or if you lost some part of the cholesteatoma. And then I write down it on my report.
Yep.
I do write it on, and I may change the frequency of MRI if I'm not happy during the surgery.
Right. Yeah.
I have a strange
Behind,
question.
And then Manoa.
Okay.
No, I never do second look without MRI. I first do an MRI, and depending on the result, I go or I do not go. And depending on my surgical impression, I may not wait 5 years more to do the second MRI, but maybe, I don't know, 2 years or 1 year more. But
Again,
it's true. We're a very wealthy country, so it's easy.
Let's meet tomorrow with Sophia and Andrea at their poster, please.
Excuse me, if you have a complication with your patient, like facial nerve palsy or failure, I ask all the panelists and all the audience, what is your feeling after that? And I hear about that a lot of doctors have a depression because of this action.
Oh, so which complication do you mean?
Yeah.
Facial nerve palsy?
That's number one. Even
direct after surgery or delayed?
Direct after surgery and failures, all type of failures.
Let's stay with the facial nerve palsy, and we ask around, and we ask the audience, and then we'll end up at 9 o'clock. But maybe we have to. Let's ask about. Well, it's a good question about the feelings of the surgeon.
I think facial palsy for me would be the most difficult thing to accept. The other one is also difficult, but then you can accept it. Facial palsy is a problem because the patient is just showing the complication every day you see him, and it's very difficult to accept for the patient too. So I would say this is the worst for me. I would say, but I never had any for Stapes. I had one in chronic ear surgery, and it's difficult always. More than a dead ear. Dead ear is difficult, but facial palsy is worse.
Facial palsy. Sorry, facial palsy. And what I do, I don't sleep.
Yeah.
For many
weeks.
days, I don't sleep.
Well, I feel miserable if I have a facial paralysis. I didn't have facial paralysis in middle ear surgery, but I have hundreds of facial paralysis in skull-base surgery. So this is why we organized the facial paralysis symposium, because we are experts on that topic. But I feel miserable because I feel myself responsible of something bad that happened to a patient. And when I always say the same. I mean, if you work with cars and you have an impact in the car, you fix it up and everything goes right. But when you do something and the patient suffers for the rest of his life, that's a serious problem. So, but if I will not be feeling miserable, I will stop doing surgery because I will be dangerous.
I think if you have done enough complex surgeries, you will have complications. It's virtually impossible not to have complications if you do complex surgeries. If you have done enough complex surgeries and don't have complication, you haven't done enough. I don't think any one of us can run away. So the only thing we can do is do the best we can, be honest to the patient, and the rest is God's will. That's the best we can do.
Well, facial palsy is a disaster, and one of the main things is you should work in a team and have colleagues who help you to overcome the depression. And luckily, in my career so far, I experienced 3 facial palsies, delayed, permanent, and no permanent, but transient. But as Dennis, it gave me a few days of no sleeping and really difficult times, because this is really the disaster you can have, and you have to ask yourself, what could I have had better? But when it happens and you need to go in for surgery, you should go to somebody else whom you trust and let him do the surgery also for medical legal aspects, and get an objective description of what you found, if you made a mistake or if it's on occasion of the disease, and not try to solve something that you did not realize under surgery by yourself.
Can I come back to one of the earlier points, which is what do you do with the unhappy patient, and how do you measure success? And one thing we didn't touch upon is selection of patients in the discussion. And one of the things we didn't talk about was the opposite ear, because if you're doing stapedotomy and they have bilateral conductive loss, and they're going to notice a gain, whereas asymmetric loss, the happiness of the patient are going to depend on the overall function, not just on that technical closure of the ear bone gap, and that's an important point in the selection criteria. Even closing a perforation, if they can use a hearing aid better without discharge, there's a big difference to them versus the technical ear bone gap. So looking at success and patient happiness more than just the ear bone gap, it's about the ability to hear in the sound field, and that's not just the technical result. So selection is really important.
Okay. Well, at the end, I need to have another question to the audience. What can we do to make the doctors and the speakers happy in the evening after we had this discussion on depressants and facial nerve palsy? So I would come to an end and thank Robert for trying out this experiment. And I like to thank all the speakers and the panelists, and especially to the audience for the lively discussions and for the discussions and what we have learned out of that. Thank you and happy evening.
Take a picture.